Good afternoon, everyone. I think it is 1:56, so we thought, especially our secretary has said that we should start on time and end on time. And as you all know, sir is very meticulous, so we will start off with the scientific program. And glad to see that many of us are already here. Over to you, Dr. Nimisha. We'll have the scientific session.
Good afternoon, ladies and gentlemen. I am Dr. Nimisha Nath, your Master of Ceremonies. And it's a great honor to welcome you all to Alapura, the Venice of the East, known for its serene backwaters and rich cultural heritage. This beautiful city serves as the perfect backdrop for CSI Kerala Annual State Conference 2024. On this lovely November day, it is both a privilege and a joy to gather here for a symposium dedicated to inspiration, knowledge, and camaraderie. This year's theme is drawn from one of Shakespeare's timeless lines. All the world's a stage, and all the men and women merely players. As cardiologists, each of you plays a crucial role in the vast and intricate theater of healthcare. Every patient encounter and every case contributes to the rich narrative of your professional journey. Over the next 2 days, we will step onto the stage of cardiology, engaging with real-life case scenarios that will unfold before us through a structured 5-act program. As we embark on this experience, let us commit to learning, sharing, and playing our roles in advancing cardiology, pushing boundaries and enhancing the quality of our life of our patients. Thank you, and let's begin this journey together. Act 1, Scene 1. Drugs for the heart. I prescribe, therefore I am. I would like to invite our stage directors, Dr. V.L. Jayaprakash and Dr. George Koshi. Our stage managers, Dr. George Thayil and Dr. George Sharyan. Our inaugural protagonist, Dr. Jabir A. I invite you to the stage also, sir.
Good afternoon all. Welcoming to this, act. All the stage is set. All the men and women are ready. And the actors are waiting. And we stage directors and stage managers are ready. So let us start this act 1 as you like it. It is none other than the master brain who has created it, and it is none other than, I would say, Shakespeare Sargent. So let us start by giving a big ovation to Dr. Sargent. Now it is time for the first actor to entry. I think already he has entered the stage. None other than one of the biggest actors, Dr. Jabir. I will not say Jacques, he is Jabir. And he is to start his play.
Thank you.
Thank you.
Thank you, sir. സാജൻ ഇത് പഴയ വീക്കെൻഡ് കഥയെ പറയുന്ന പോലെ ഭീകര കഥാപാത്രങ്ങൾ ഓരോന്നായിട്ട് സ്റ്റേജിന്റെ രണ്ട് ഭാഗത്തു നിന്നും പ്രവേശിച്ചുകൊണ്ടിരിക്കുകയായിരിക്കും. ഇപ്പൊ നായകനാണോ പ്രതിനായകനാണോ ഹാസ്യ കഥാപാത്രമാണോ എന്നൊന്നും പറയാൻ വയ്യാത്ത അവസ്ഥയാണ്. എനിവേ, thank you, Sajan. It's a great program, great ideas, and it's a pleasure to be here with my colleagues, friends, and teachers. And it's always a great pleasure to be in the CSI. So let me talk about Fenrinon and CKD and heart failure. Sajan has given me a case, a 55-year-old gentleman who was admitted with anterior MI and he underwent angioplasty to LAD. He had features of left ventricular failure, which settled with IV diuretics. The diabetes detected 2 months ago. At presentation, his fasting is 184, postprandial is 256, and HbA1c is uncontrolled. Urine albumin 2+, creatinine 1.4, LV ejection fraction 44%, NT-proBNP 1432. He is already on aspirin, ticagrelor, bisoprolol, atorvastatin, losartan, potassium, and dapagliflozin. So what more you need is the EGFR. The calculated EGFR is 59. urine albumin creatinine ratio is 434 and serum potassium is 4.6. Previous urine albumin creatinine ratio at the diagnosis of diabetes was 484 milligram per gram, and he was started on metformin, dapagliflozin, losartan, and atorvastatin at that time. So the case is of a diabetic, established ASCVD, heart failure and mildly reduced ejection fraction, CKD, macroalbuminuria, and a normal potassium. So the aim of therapy is to reduce the cardiovascular event, to reduce the kidney events. So the approach is using various agents which can produce hemodynamic impact on inflammation and fibrosis, and impact on metabolic dysregulation. The drugs we have is RAS blockers, SGLT2 inhibitors, GLP-1 receptor antagonists, that is basically for the metabolic control, and Findrinone. So I'll talk about Findrinone. The mineralocorticoid receptor plays a key role in the crosstalk between heart and kidney in diabetes. What it does finally to the kidney is organ fibrosis, remodeling, injury, fluid retention, reduced eGFR, proteinuria, which indicates a glomerular damage, and finally a reduction in renal function, which may lead on to renal replacement therapy or a renal death. In the heart also, it produces organ fibrosis, remodeling, injury, myocardial dysfunction, heart failure, hospitalization, and death. So albuminuria is an excellent predictor of cardiovascular and renal events. You can see the cardiovascular events occurs quite early, within 6 months of detection of albuminuria, and the magnitude of albuminuria is correlated with the cardiovascular composite endpoint and the kidney composite endpoint. We have RAS blockade evidence. We have evidence from various trials of SGLT2 inhibitors, dapagliflozin, empagliflozin, and even the canagliflozin. But despite all these agents available, there is a significant residual risk of renal and cardiovascular. So Findrinone is the new agent, a non-steroidal agent, bulky agent, with a unique structure, results in very selective and potent interaction with the mineralocorticoid receptor and regulation of the gene expression, and it exhibits antifibrotic and anti-inflammatory effects. Some difference between the already available agents like spironolactone or eplerenone. The potency is high, equivalent to that of spironolactone, no CNS penetration, highly selective, or it is the highest selectivity among all these agents, no hormonal side effects, short half-life, no active metabolites. So this short active half-life and no metabolites make it more potassium friendly. We have large amount of data. We may consider it a significant amount of data which is accrued from 2015 in the last ESC conference, which starts from the ARTS trial to the Fidelio group of trial, the Fine Arts, and some trials still going on. So the Fine Arts, Fidelio DKD, and the Figaro DKD gave the greatest or the available data which resulted in the utility of the drug in this particular condition. Either in a late stage CKD patients where the urine albumin creatinine ratio is 30 to 300 and GFR is 25 to 60, or macroalbuminuria up to 5,000, 5 gram, and eGFR 25 to 75. Or an early stage CKD disease, the Figaro DKD, USCR, the urine albumin creatinine ratio, microalbuminuria, eGFR up to 90, and urine albumin creatinine ratio, macroalbuminuria up to 5 gram, and eGFR more than 60. And a pre-specified pooled analysis of these two, that is a fidelity. Reduction in the cardiovascular endpoint by 14%, reduction in the kidney composite endpoint by 18%. You can see the kidney composite endpoint, the reduction started, the curve starts separating by around 2 years. A 32% reduction in the urine albumin creatinine ratio at 4 months. And this benefit is on the top of SGLT2 inhibitors. The utility was only around total, it is around 6% of the patients, and heart failure hospitalization as well as cardiovascular composite endpoint, benefit was irrespective of the use of SGLT2 inhibitors. Hyperkalemia, of course, 14% versus 7%, 7% in the placebo, but hyperkalemia leading to permanent discontinuation was only in 1.7%, and no deaths due to hyperkalemia. The Findrinone in mildly reduced or preserved ejection fraction, the Fine Heart, reduction in the cardiovascular endpoint, cardiovascular death, and the heart failure events, predominantly driven by reduction in the heart failure events. This is in heart failure with mildly reduced ejection fraction and preserved ejection fraction. This is irrespective of the LV ejection fraction, whether it was more than 60% or less than 60%, and the use of SGLT2 inhibitors, which was 14%. So the fine arts conclusion, Findrinone reduces cardiovascular event and kidney events in patients with cardiometabolic kidney disease, reduced total deaths, not cardiovascular deaths. Benefits were evident in all subgroups tested, including those with multiple intersecting cardiac kidney metabolic conditions, and it was beneficial on the top of SGLT2 inhibitors as well as GLP-1 receptor analogs. And of course, there is a need to monitor the potassium level. So Findrinone practical uses, urine albumin creatinine ratio 30 milligram per deciliter or above, up to 5 gram. We have data only up to 5 gram. Serum potassium less than 5, EGFR 25 to 60 or EGFR more than 60. If up to 60, we start with 10 milligram, and more than 60, we start with 20 milligram. And those already on 20 milligram, if the potassium is less than 5.5, will continue. If it crosses 5.5, will stop and see whether the potassium comes down to 5, then restart with 10 milligram. And treatment can be continued up to a lower EGFR level of 15. Intensification after 1 month, 10 milligram. If the potassium remains less than 5, increase it to 20 milligram OD. So in heart failure, the fine arts up to 40 milligram, and here in the DKD patients up to 20 milligram. So more than 5.5, it's a cutoff. So the case, it is diabetic kidney disease, atherosclerotic cardiovascular disease, heart failure, and preserved ejection fraction, already on aspirin, ticagrelor, bisoprolol, atorvastatin, losartan, and dapagliflozin. What you have to add is Findrinone. One question remains: is aldactone a cheaper alternative? I do not know, because there is no data comparing Findrinone versus aldactone in the above situations. So my take-home message will be: we have a clear evidence of the disease-modifying potential of Findrinone in broad high-risk patients encompassing cardiometabolic kidney disease. Diabetes should be tested for, all the diabetics should be tested for urine albumin creatinine ratio, and those with diabetic kidney disease should receive Findrinone. And mineralocorticoid receptor antagonist of choice in heart failure and mid-range ejection fraction, and heart failure and preserved ejection fraction, is currently Findrinone. Thank you so much.
Dr. Jabir, an excellent exposition. We know this new molecule, it is a non-steroidal mineralocorticoid.
Shall we,
it is in the end.
sir, shall we have the discussion at the end
Discussion.
of
Okay.
the talks?
Okay.
Sorry for the interruption.
Thank you. Now it's time for the second actor to enter. That is none other than Dr. Narayan Namburi, another renowned actor. And he is on flecainide in atrial fibrillation. And let us see the play.
Thank you, sir. And thanks specifically not for anglicizing my name. And thanks, Sergeant, for this wonderful show, taking us by 4 centuries back to Elizabethan era. And my duty is to take a pound of flesh from this topic in the next 8 to 10 minutes. And I'm not sure whether I will be able to do it without letting a drop of blood out. So this patient, in index case, is 67-year-old lady, Mrs. M. We can call it as Lady Macbeth or something. So this patient had hypertension for the last 4 years, episodes of palpitation for the last 2 years, documented to have paroxysmal AFib, no history of diabetes mellitus or history suggestive of obstructive sleep apnea syndrome, normal thyroid function, LA mildly dilated, a Chart-Swart score of 3 contributed by gender, hypertension, and what else is hypertension, age, and gender. So this patient's ECG had shown atrial fibrillation without any significant cardiomegaly, was on minimal dose of beta blockers, bisoprolol 2.5 mg/OD, still continued to have tachycardia episodes and symptomatic that time. Her ECG, Holter had shown an average heart rate of 53 with no significant pause. What next? We know the cornerstones of atrial fibrillation management should include anticoagulation, the most important one, rate control, rhythm control if possible, which could be based upon pharmacological, catheter-based surgical methods or hybrid approaches. In the pharmacological, the mainstay of treatment would be class 1C drug and class 3 drugs. And class 1C drug include flecainide, the most important in the management of atrial fibrillation for pharmacological management and rhythm restoration as of now, apart from amiodarone. The how to use Flecainide in AFib. There are 5 scenarios where we can use or prescribe Flecainide for atrial fibrillation. One is pill in the pocket on outpatient basis as an adjuvant to beta blockers. Then, if the patient is either inpatient or outpatient, for acute termination of AFib episodes after a period of 48 hours, as pharmacological cardioversion of paroxysmal AFib episodes as an alternative to electrical cardioversion. Then, if the patient is already planned for electrical cardioversion as a pre-treatment prior to it in non-paroxysmal AFib, either persistent or permanent. Then, as a regular medication for prevention of recurrent episodes, if the requirement of pill in the pocket strategy is very frequent, or post-AFib ablation for 3 months, that is in the blanking period. These are the 5 indications where Flecainide can be liberally used for rhythm restoration or maintenance. In fact, in the guidelines, both Flecainide and propafenone are given equal importance. We are discussing about Flecainide, and the initial dose for cardioversion as a pill in the pocket or pharmacological cardioversion in elective case should be something like 200 to 300 milligram. And it has got definite advantage over propafenone in certain aspects. Like overall success rate is 60 to 80%, while compared to 45 to 55% for propafenone. But there are some contraindications for Flecainide based upon the evidence from CAST trial, which was done almost 30 years plus back. And it should not be used in ischemic heart disease or significant structural heart disease. In fact, when you give atrial for atrial fibrillation, it can sometimes convert to atrial flutter and it can have one-to-one conduction. Flecainide is not a drug that to be used in patients with atrial flutter. If you have a baseline 2-to-1 or a 3-to-1 or 4-to-1 conduction, atrial flutter cycle may prolong. Essentially means atrial flutter rate can actually become reduced, and based upon that, the AV node can start conducting one-to-one. This can cause hemodynamic problems. And also it can induce mild QRS widening related to its class 1C property, which is a potent sodium channel blocker. And it should not be used for pharmacological cardioversion of atrial flutter, where you have better options like abutanide or even amiodarone. Another important point to note is that Flecainide has no role in rate control whatsoever. The pill in pocket is a very good option, especially patients get very infrequent episodes of atrial fibrillation. They have to be on beta blockers at baseline. This high rate of patient compliance, safety profile is very good, reduces the cost, reduces the recurrent hospital admission. And another major advantage is that the treatment can be initiated very early at outpatient. Based upon the weight, more than 70, it is 300 milligram, less than 70, it is 200 milligram as a single oral loading dose. Should not take more than 1 dose during the 24-hour period. And an AV node blocking drug should be instituted, like beta blocker should be added prior to it. There are some the guidelines clearly state that the initial trial or pill in the pocket should be given in a hospital setting, only following assessment of efficacy and safety assessment based upon this ESC guidelines. And by this AHA guideline, it is reasonable for pharmacological cardioversion if previously tested in a monitored setting. But if you exclude the conventional risk factors and get an ECG, you exclude there's a structural heart disease, probably it can be given even without hospital setting in the initial phase, which is actually safe as per accumulated experience from many cardiologists. It's contraindicated if you have structural heart disease, LV of less than 35%, post-MI, ongoing ischemia, second or third degree AV block, bifascicular block, QRS duration more than 120, or significant renal or hepatic impairment. One should also remember that conditions without ventricular scar or fibrosis like ASD or rheumatic substrate should not be considered as contraindication. The whole concept came after the study based on the CAST, where the patients with the post-MI patients were enrolled significantly. And this pill in the pocket strategy is highly efficient, and it can be up to at least more than 50% of them convert. The study had shown 94% could terminate. And what is atrial fibrillation for the patient? Many times it can be recognized by pulse or smartphone app or watches. with a great degree of sensitivity and specificity as per ESC guidelines. And if the patient is for a chronic oral dose and administration, it can be given up to 300 milligram. And we know the overall pharmacokinetics of these patients. It is primarily a class 1C agent with significant effect on conduction velocity and also some effect on prolonging effective refractory period. 1982, it was approved first, then by FDA in 1985. The CAST trial had created some shadows on it, but it could be related to some of the possible reasons like this. This patient might have had late development of ischemia, CHF, accumulation of drug to toxic levels. Another important is the activation of late sodium channels in diseased heart and prolongation of action potential duration, which is expressed in patients with ischemia and structural heart disease. High rate dependence because of the use dependence property and prolongation of the facilitating re-entry in these cases. But later on, studies have shown it is very safe and effective also. As you can see, the mortality benefit is maximum with sometimes, will take only 1 more minute. It will actually, sometimes it can cause a junctional rhythm and prolongation of the QRS. This patient had a Brugada genotype and it is very fast. Within 3 hours, the peak plasma levels is reached. Plasma half-life is almost 20 hours. Minimal effect on sinus node, AV node conduction, and other hemodynamic parameters. Should not be used in children or pregnancy as per recommendation, but it is frequently used. It is one drug used in fetal arrhythmias and all. Impaired renal and hepatic function could be a complication. With amiodarone, it can be combined. It should be reduced the dose. Many patients will do that, and it is quite safe. And the non-cardiac side effect is minimal for these cases, and it is highly effective and faster in restoring sinus rhythm compared to amiodarone. And some advantages over propofenone, as I mentioned earlier, and is highly effective in acute cardioversion with a minimal relapse rate. This patient had on flecainide had post-termination pauses, and we took this patient for cryo. This is my last slide. You can see the atrial fibrillation, that blue line that goes on in pulmonary vein, and the yellow one shows the surface ECG and intracardiac electro. That actually shows atrial fibrillation continues in the pulmonary vein, while actually it became sinus. Its intracardiac electrogram became regular, and eventually the atrial fibrillation within the pulmonary vein also terminated. Out of 70 plus cases we have done in the last 3 years, and this response we could see only in less than 10 cases, but substrate adds to the complexity of atrial fibrillation. What we discussed the role of flecainide in AFib, guidelines of practice, fill in the pocket strategy, safety and efficacy, pharmacokinetics and pharmacodynamics in comparison to other antiarrhythmic drugs. Thank you.
Thank you. Now it's time for the third actor to enter the stage. And he is on inclisiran, the revolutionary road. I request the third actor, Dr. Thomas Matthew, to play his role in this.
Respected senior doctors, chairpersons, and dear friends. So, as sir already said, Sajan has given me a very catchy heading. It's about inclisiran and the revolution it unleashes. So, one important hypothesis regarding the origin of life is that it originated from RNA. Then 3.5 billion years later, we are finally able to modulate it to some extent. So basically, inclisiran and like molecules, they are all small interfering RNAs. They are synthetic molecules, they are not natural, and they dominate this field in clinical practice. So all these drugs act on the liver on various receptors. If you take the index case, that is inclisiran, it acts on PCSK9. It interferes with the production of PCSK9 mRNA, thereby reducing PCSK9 levels. So as we all know, PCSK9 destroys the LDL receptors. So when PCSK9 is low, the LDL receptors are upregulated. The LDL is taken to a bigger extent into the liver, and thereby the blood levels of LDL are reduced. So other molecules of interest to us today are plazosiran and sotaziran. I will come to that later. So this is the index case given to me by Sajan, a 63-year-old lady, CABG done 2 years ago. She had only mild acidosis then. She is on rosuvastatin 40 mg. But now her LDL is 376. She has severe aortic stenosis, and on detailed examination, probably long-standing tendon xanthomas were discovered. So what is this patient? Most likely she is having familial heterozygous hypercholesterolemia. So one important and unfortunate thing in these patients is that the median age of diagnosis of this condition is usually 44 years, and unfortunately the median age of diagnosis is also 44 years. So herein comes the importance of diagnosing it early and reducing the LDL cholesterol to targeted levels. So about inclisiran, it has already been approved by US FDA in December 2021. It's also in the NICE guidelines. It is approved for patients with history of cardiovascular disease, that is including CAD, ischemic stroke, peripheral arterial disease, any revascularization arterial procedure, and even in acute coronary syndrome, including myocardial infarction, unstable angina, even during hospitalization, provided the LDL cholesterol is above 100 milligram per deciliter, that is 2.6 millimoles per liter, despite maximum tolerated levels of statins. So if the patient is already on statin and it is at the maximum tolerated level and LDL is more than 100 milligram per deciliter, we can use it even in acute MI. And of course, it is also approved when other lipid lowering therapies are not tolerated or if they are contraindicated. So what about the dose? It is very easy to give. Subcutaneous 284 milligrams on day 1, followed by a second injection at 3 months. That is only for the second dose only. Thereafter, it has to be given at every 6 months interval. So what are the factors to be considered when prescribing inclisiran? What all guidelines says, when there is history of atherosclerotic cardiovascular disease or heterozygous familial hypercholesterolemia, provided the patient is already on maximally tolerated levels of statin plus or minus ezetimibe and other lipid lowering drugs. In other patients where LDL levels are still high, but the patient is not willing to take molecules such as evolocumab, or in patients with, as I already said, side effects, or when there is poor adherence to therapy. It has already come in the recent CSI guidelines in 2024. It reduces LDL by 51% on top of statins, triglyceride by 12%, and spectacular effects on lipoprotein A and ApoB. One important thing about inclisiran is that these are all the initial trials, but hard cardiovascular outcome data is lacking. That is still in the process of being corrected. These are the 3 pivotal trials. There is Orion 4, Orion 8, and Victorion Z2P, where we should be able to see whether it actually improves cardiovascular survival. From 7 large clinical trials, it has been found that it has no major serious adverse effects. The major adverse effects are rash at the injection site and other injection site complications such as swelling and hematoma. This is a real world study. In that, it was found that it was safe and effective, but in this in real world setting, the LDL cholesterol reduction is only 38%, whereas in studies it is to the tune of around 51%. So this is a drug which degrades LDL, reduces PCSK9 levels, thereby increasing LDL receptor levels and thereby reducing LDL levels. So as I already said, it is approved in patients with prior MI. Here the reduction in LDL cholesterol at 3 months. That is, the patient receives the first dose and the second dose. At that stage, it is to the tune of 60 to 75%. But by 1.5 years, there is a day 510, the LDL cholesterol reduction is only 51%. And side effects, it's very well tolerated. Moving on to the next drug, it's a promising drug, that is plozasiran. It is targeted mainly at patients with severe hypertriglyceridemia. Again, this should be given only to patients who are on stable statin for at least 1 month, and it was given at doses of 25 and 50 milligrams. This study was recently published in NEJM. At 50 milligram dose, this drug, that is plozasiran, actually increases the incidence of diabetes to 20%. But look at the other dose, that is at 25 milligrams every 3 months, the incidence of diabetes is similar to placebo. So it's a very promising new drug, especially in patients with severe hypertriglyceridemia, especially if the patient has high risk of pancreatitis. The last drug, Sodaseran, again targeted at severe hypertriglyceridemia. It is also found to be effective and safe, but just like Plozasiran, it also has an increased incidence of diabetes. HbA1c is at least transiently reduced in many of these patients, especially when the highest dose, that is 200 milligram, is given. So, friends, senior doctors and chairpersons, as we are at the beginning of the revolutionary road of small interfering RNAs. There are other drugs which are approved for these patients. Patisiran is already approved. That was the first molecule of this class to be approved by US FDA. It has been in vogue for 6 years for hereditary transthyretin mediated amyloidosis. Givosiran for hepatic porphyria, and other drugs for primary hyperoxaluria and other similar conditions. And at every organ, there is targeted therapy in clinical trials now, and this class of agents is likely to revolutionize medical therapy in the years to come. Thank you.
Thank you. Now the actor 4 on tafamidis, Dr. Hisham.
I think I'll have to announce that the route to the stage is actually on the right side.
Okay.
Because we don't need orthopedic emergencies. Thank you.
Thank you. Respected Chairperson and members of the audience. Now switching gears to another clinical problem, which is infiltrative cardiomyopathy. So the index case is a 52-year-old lady who is a long-standing diabetic, close to 2 decades of diabetes. Dyslipidemia, the presentation is with progressive exertional dyspnea, swelling of feet, orthopneic episodes sometimes in the last 1 month. And she has symptoms suggestive of peripheral neuropathy, which could be explained by long-standing type 2 diabetes, and clinical examination was consistent with the clinical picture of heart failure. This is the electrocardiogram of the patient. Some would say this is largely unremarkable. Some would argue that there is a little bit of maybe a lack of ROA progression from V1 to V6, but otherwise fairly unremarkable electrocardiogram. This is the echocardiogram. As you can see, in the parasternal long axis as well as the short axis, there is evidence of diffuse left ventricular thickening, dilated left atrium. And in the apical four-chamber view, you can see that these findings are reconfirmed with probably a hint of thickening of the right ventricular free wall as well. The global longitudinal strain is markedly impaired with minus 10.6, although the pattern of regional strain abnormality does not seem to invoke any characteristic pattern in this particular patient. This patient had severe diastolic dysfunction bordering on grade 3 diastolic dysfunction, and keeping in mind that the clinical presentation was that of congestive heart failure. So in terms of clinical summary, this is a patient who has a restrictive cardiomyopathy type of phenotype, clinical heart failure, elevated NT-proBNP and elevated troponin. And this patient had a coronary angiogram done when she was referred to us, and rightfully so, because of severe exertional dyspnea and long-standing diabetes, although that cannot explain her current phenotype. So we need to deeply understand what this restrictive cardiomyopathy is about, and hence if we do a CMR, probably we might know that whether this patient has an amyloid phenotype, and this is based on abnormal gadolinium kinetics. That's something which we need to investigate, and of course we need to investigate amyloid phenotype because that is one of the primary restrictive cardiomyopathies that we see in clinical practice. So looking at the CMR, we find that the nulling pattern is normal. So this is in 50 to 75% of patients, the nulling pattern will be abnormal. That is, a blood pool nulls before the myocardium normally, but in this case, it is a normal nulling pattern, not suggestive of amyloid. And the CNE sequences on the left-hand side confirms the echo findings of biatrial dilatation, fairly preserved left ventricular ejection fraction. There is subtle mid-myocardial late gadolinium enhancement, very subtle, and in that area of subtle LGE, we find that the native T1 is markedly elevated, 1419 milliseconds. Our scanner has a normal of 1250. 1400 is a very high native T1 value, and often it is found in infiltrative cardiomyopathies like amyloidosis. So in terms of an algorithm, where do we start to investigate this patient's this patient's restrictive cardiomyopathy phenotype. So we always have to rule out light chain amyloid, and that's why we always have to start over there. And we have to understand whether this patient has abnormal monoclonal proteins. If the patient has abnormal monoclonal proteins, if the answer is yes, then the next objective is to demonstrate amyloid in tissue, either fat pad or bone marrow biopsy. If it is negative, then we must attempt a tissue biopsy in the involved organ. In this case, it's endomyocardium. And if we have deposits, we have typed the deposits by immunohistochemistry or mass spectrometry, whichever is available in the center, and therefore confirming a diagnosis of light chain. In the absence of light chain workup, and only in the absence of light chain workup, should we proceed to the ATTR workup arm, where we proceed with technetium pyrophosphate scanning. And if it is positive, it is presumed that it is ATTR amyloid, and therefore we have to differentiate whether it's a wild type versus a variant type based on genetic testing. So what did we do in this patient? So CMR said that it is possible amyloid, not very typical appearance. And in terms of amyloid workup, the first step that we proceeded was to look at light chain workup. This patient had a comprehensive light chain negative workup. That is, the kappa lambda ratios were normal, the serum protein electrophoresis was normal, and the serum immune fixation electrophoresis was also normal. So in terms of the very first step that we saw here, this patient had light chain negative workup. But still, this patient has a restrictive cardiomyopathy phenotype, and the amyloid question is still in play. So in the absence of light chain workup, the next suspicion is whether this is ATTR kind of amyloid cardiomyopathy, which is the second most common type of amyloid presenting as restrictive cardiomyopathy. So we went ahead and did a technetium pyrophosphate scan. And as you can see at 1 hour on the right-hand side panel, you can see at the end of 1 hour and at the end of 3 hours, there was significant diffuse uptake in the myocardium, much more than the ribs. And you can also see that the heart to contralateral chest ratio is more than 1.6 in our patient. Anything more than 1.5 is highly significant. And you can see that the uptake in the myocardium is significantly more than the surrounding ribs. So this presented us with a result of Perugini grade 3 positivity, a grade 2 or a grade 3 positivity in the absence of light chain workup, in the absence of light chain evidence, is considered to be a positive scan. And this diagnosis is ATTR variant cardiomyopathy, and our gene sequencing revealed that this patient had a pathogenic variant which is characteristic of ATTR amyloid. So what are the therapeutic options? So essentially, we need to understand that the basic pathobiology is an unstable TTR tetramer. So the various options are either you can reduce the production, you can stabilize the tetramer, or you can increase the clearance. So essentially, the agents which are approved now are patisiran and vutrisiran, which are essentially RNA silencers. But the drug which is now available in India to treat these patients is now tafamidis, which is a stabilizer. Hence, tafamidis has a robust clinical data based on a landmark randomized clinical trial called ATTRACT. And this was a trial which is responsible for its FDA approval. You can see that there is significant improvement in mortality, and the number needed to treat is quite impressive at 7.5 to prevent 1 death over 30 months follow-up period. So this patient was initiated on tafamidis, which is known by the trade name of Vindamax, 61 milligrams per day. There are many staging systems in ATTR amyloid. Our patient will fall into Mayo stage 3, or if one tends to use the NAC staging, the patient also was stage 3. And there are many ways. There are 3 main ways to actually clinically follow up these patients: the clinical and functional parameters, laboratory biomarker, that is BNP and troponin T parameters, and of course, we can follow up these patients by imaging and electrocardiographic changes. So suspicion of restricted cardiomyopathy is very important when we encounter patients with this kind of a clinical picture. And a constellation of cardiac and extra cardiac manifestations, which are listed here, should always alert the suspicion to a restricted cardiomyopathy phenotype, probable amyloid. And in summary, the sequence of evaluation is especially important. One needs to start with light chain workup, and only in the absence of light chain workup should one proceed to evaluate for ATTR. So a high index of suspicion, this evaluation sequence is quite important, and the diagnosis, to establish a precision diagnosis, is also quite important because these diseases, either light chain or ATTR, has specific therapy. Thank you for your patient listening.
Thank you, Dr. Hisham. Now we move on to the last actor, that is a primer for the adult perplex cardiologist. That's a pediatric cardiac drugs. It's Dr. Edwin Francis is playing his role.
Good afternoon, everyone. Thank Dr. Sarjan and his colleagues for inviting me. I think there is nothing new in pediatric cardiology, probably that's why I'm probably going back to a drug which is probably age old, that almost everyone knows it. I'll just remind you, mostly that do that, nothing else. Another thing, I was just trying to read about it a few days back, then suddenly anything new has come up, and I knew why probably Sarjan selected this. This is predominantly used by a pediatric cardiologist, but why an adult guy is interested in this? And looking at it, one of the first indications was shown was managed erectile dysfunction. Probably a lot of adult older cardiologists, probably that's why he selected this. And second comes a patency to this one. So just my disclosures and no experience, the first indication. So in the history wise, it was isolated from the seminal fluid long back in 1935. And then it came into use in 1950s, when isolated specifically, discovered in 35, but used in the early 60s, and was approved in the US in 1981. Even here, have a review in Anesthesia Journal at the time of 1975. They have a review article coming up in Anesthesia, and so that's the level of development they had almost 50 years ago. Just coming to indication, like everybody knows the mechanism of reducing the calcium influx and relaxing. So just go to the labeled indication is basically a patency of the PD in the newborns. Another one I have already mentioned, and then a lot of non-labeled ones like a treatment of Raynaud's phenomenon. Again, it's all borderline benefit. You have a prevention of contrast nephropathy, stenosis of the spinal canal. There are subtle indications which are never proven benefit in trials. Coming to the background in which what conditions does it benefit the prostaglandins? The CHD continues to contribute to the major infant mortality even now, because other things, treatable causes have been done. So, of which the critical heart disease is heart disease which requires intervention in the first 1 month of life. These, of which duct-dependent circulation is one of the major ones, and they get easily missed out because they remain very stable in the immediate first 1 or 2 days. So that's why they don't get picked up. They remain unstable. Almost 40 to 50% of them get discharged without a diagnosis. They come crashing in. That's the time, as a case scenario, as Sarjan suggested, the adult cardiologist is called upon. I think it's less often because of now pediatric cardiologists are quite available, but still many situations in which it's not available. The pediatrician, the neonatologist is not used to prescribing it or using it. That is the trouble which happens. According to the duct per se, get closest functionally with the first 1 to 2 to 3 days of life. And basically the reason, as you all know, the oxygen level increases and the prostaglandin levels comes down, so they tend to close off. But the anatomical closure happens up to 10 to 14 days of life. Probably this is important that sometimes, rarely, you can open up the PDA a little more easily or medically within the first 1 to 2 weeks of life. I'm talking about full-term babies. Preterm, they don't close off so easily. They maintain the patency longer. Beyond 2 to 3 weeks, you may have to do more difficult to open up these PDAs. So what are the scenarios in which, or categories in which is this useful? The most often used are a duct-dependent pulmonary circulation, that is predominantly a pulmonary atresia or a critical PS where the pulmonary blood flow is dependent on the pulmonary circulation, on the PDA, or a tricuspid atresia, or the reverse, the duct-dependent systemic circulation, the classical example being the hyperplastic left heart syndrome, or the reverse, coarctation of aorta or aortic atresia, that is, PS was a mistake. And the third category is a transmission of great arteries, in which for the first use of prostaglandin was used in even the early 70s. This article published in which it could be quite useful in preventing mortality in the case of TGA with a low saturations, provided they have a decent ASD, at least after septostomy or before that. Otherwise, the LA pressure will go up, patient may become more sick if you start a PDA with prostaglandin. The preparation available in India is most often uses the alpostin, which usually comes in 500 microgram per ml. That's 1 ml ampule which comes in. So just easy to remember that. The E2, the dinoproston, was earlier used, which was the first prostaglandin to be discovered, but is less effective, and so it's almost always is the E1 which is used in the maintaining the patency of the PDA. In the clinical scenario could be like the one, like the scenario Dr. Sarjan suggested here was like it could be an antenatally detected TGA or a duct dip in circulation, so you know what exacerbation is stable. Or it could be a cyanotic, non-acidotic baby with a suspected CHD. In both the cases, sometimes it may be difficult to get an echo done in the newborn. It will be ventilated. You may not have a portable machine. It will be a very tiny machine. You may not get a very good diagnosis if you are adult cardiologists which are not routinely doing a pediatric echoes. Or it could be an acidotic unwell baby with suspected CHD, which is duct dependent, or newborn with the femoral pulses, poor pulses with acidotic. The last two indications, you need to go at a higher level of prostaglandin dosages. In the first two, the stable ones, you can initiate a lower dose and wait to see the response. And response happens within 5 to 10 minutes or 15-20 minutes. But in the last case, if there is an absent pulses in the coarctation, many of times the prostaglandins may be life-saving because the patient may be so sick, cannot be taken for surgery. The prostaglandin infusion may improve the flows into the lower limbs. But it may take longer. You may need higher dose and to wait half an hour, 1 hour to see the response in the case of coarctation. Please remember that. And the method of administration is the dosage is like intravenous, nothing like that. It's 0.05 to 0.1 microgram per kg per minute. As I said, the higher doses may be required in the systemic PDA-dependent systemic circulation and in the case of coarctations. And in those cases where the PDA is closed or they're almost closing. In a stable scenario, the recommended dose is 0.01. Or they started even lower dose that is usually effective and causes less complications. The most complication heard of is the most common one is hypotension and apnea. The apnea is the most common. So if you start with the still lower doses, this apnea is less common. So just to remember yourself, for a 3 kg child, usually comes as 500 micrograms in 50 dilution, 550. You start with 0.9 would be 0.05 dose. So you start with 0.5 and slowly increase 0.1 ml every 5 or 10 minutes. You may not end up in major trouble and get a good response. Now, always expect something saturation around 70-80% only. Don't try to get a saturation of 85-90%. The side effects are the most common, as I said, apnea and hypotension. Fever and convulsions can happen. Somebody's hypercalcemia, it may have convulsions can happen at a lower threshold. And start at lower dose and increase slowly and fluid bolus. A few conditions next as many of the interventionalists, I thought I'll show you one key scenario in which it's a 13-year-old, I think more than 2 weeks probably. Psychospectria, restrictive VSD means a severe PS. There is no flow through the VSD into the pulmonary artery. There's no PDA seen, saturating around 65-70%. They thought of going BT shunt, but in echo, it didn't show any PDA, but I thought I'll just go, saw an ampulla. I did an angiogram, there was no flow at all. So started giving a small doses of 10 to 20 micrograms of this one. You can see it's not so clear, I don't know. You can see the minimal flows you can see after I waited 15-20 minutes. Now you can see it's a reasonable flow in the last one. A subtle flow is seen. So you can see a subtle filling of the pulmonary artery there. Then it's a very easy thing. You put in a wire and then do a stenting. And then you can avoid a surgical BT shunt. Another scenario was here. One more scenario. So the VSD pulmonary atresia. Here a bilateral PDA. The left one was flowing reasonably well, while the right was going to a spasm with the recurrent spells. I thought of going and trying to poke in, but couldn't go with a regular wires. I didn't use a CTO wire. But I thought before that I'll try a regular prostaglandin infusion. It's only a 6-7 day old. Again, PDA was almost closed off. You can, after prostaglandin, you can see the PDA opens up very easily, and then doing a procedure becomes far more easier here. Then the wire just goes off easily, and then the post-procedure stenting. So just to conclude, the prostaglandin is a game changer in hands of a wise. So you can really save patients with prostaglandin. Thank you.
Thank you. Now, before putting curtain for this scene, I would like to call all the 5 actors onto the stage. Dr. Jabir, Dr. Narayan Namburi, Dr. Thomas Matthew, Dr. Hisham, and Dr. Edwin Francis. Please. Thank you. Now it is the role of the stage directors. I would give the mic to my stage director, Tayil sir.
Very interesting. A lot of hard information went one by one, so we have to sort it out, which may be more relevant. I think I'm more interested in flecainate because our center where I worked, German Heart Center in 1989, it was involved in the CAST trial. I think the flecainide came to the scenario in 1985.
Yes, sir.
And then 89, the CAST trial started, which was published in 91 in New England Journal of Medicine. It was initially started for the treatment of supraventricular arrhythmias and ventricular arrhythmias. Now, after the publication, there was an increased mortality in the treatment arm compared with the placebo. And those days, I think the class 1C Vaughan Williams included flecainide, encainide, and moricicib. Now it has changed to flecainide and propofenone alone now, recently. At that time, 3 molecules were there, and flecainide, encainide, and placebo. There were a lot of mortality. It was a big shock to the treatment of flecainide until recently. Now it is gaining importance in US, as Dr. Nambudiri well depicted there, and in Europe there is something called a pill in a pocket. It has come to that extent that for the patient without a structural heart disease, with the recent onset atrial fibrillation, paroxysmal atrial fibrillation, which can be detected by a Apple Watch or any device, the drug of choice, a miraculous revolutionary drug would be a flecainide given, which would, with the certainty of, I think, since it almost up to 78%, it will terminate, it will convert the atrial fibrillation, which is a very good drug. Now, we are here and we have been using amiodarone for all the ventricular arrhythmias, for atrial fibrillation, even to terminate. Now it is time to switch on to flecainide. I don't think this information has gone to all the physicians or cardiologists. Even now, we give an infusion of, there are centers where they give amiodarone infusion and try to, I think that will be a very good thing. And I think whether you mentioned or not, there is IV flecainide also is available. It is much superior to propofenone, naturally, in terms of for converting it to sinus rhythm. And this pill in a pocket, that is also a class 1, class 2B designation, I think so. It is very much practiced in US and also Germany, I know. And how far have we reached with the treatment of flecainide? How common it is in Kerala or in India?
Sir, it is very commonly used. In fact, as you mentioned, 1989 FDA approval was given for flecainide, but the CAST trial came. It went to a bit of, a lot of concerns raised on it. But that the substrate was patients with either post-MI, LV dysfunction, ischemia, and all, where the expression of late sodium channels would be dominant. And also, it has been shown in 1980s itself. All these trials were done in Germany. In fact, Vaughan Williams and Singh, an Indian, right, they worked in Germany, where even amiodarone was developed 20 years prior to it.
Absolutely.
In fact, those studies have clearly shown that there is a peculiar property called anisotropic reentry is possible in these patients with a structurally abnormal heart. So otherwise, patients with a structurally normal heart, it is an absolutely safe drug, except for a certain substrate like a prolongation of the AV conduction or associated sinus node dysfunction. Along with beta blockers, it can potentially.
And even for WPW, I think
it's a safe drug.
It is being used occasionally.
So it is very commonly used.
But in this pill in a pocket, that is not yet being practiced
It's
in
being
our
practiced.
setup, in our scenario.
Very commonly practiced.
Where in India?
In India, in Kerala, sir. Even today morning, I had a patient who took the flecainide and reverted. It generally happens within 2 hours. It terminates.
In fact, we have a yes and no card with you. So, how many of the audience here have ever used flecainide?
The
as a
pill
pill
in the pocket.
Yes, a lot of yes and some no's. Okay. Right. Thank you.
Okay, sir. Thank you.
Sunil.
Thank you. I just want to ask you, how frequently do you get acute left ventricular failure when you give flecainide? Is it not?
It is extremely uncommon. But we have seen patients, some other centers. I had a patient from another center who had put on, but generally it is due to long pauses after adding along with beta blockers and tachycardiomyopathy uncontrolled, and many other reasons for that.
It is a negative inotropic agent also, that may be a reason why the incidence of heart failure was very common.
സാജ ഈ രംഗത്തിന്റെ തിരശീല വീണല്ലോ അല്ലേ?
I think flecainide we can move on.
കഥാനായകൻ ഫ്ലെക്കൈനയുടെ
Move on from flecainide.
Flecainide we will move on, and I think audience
in the CVD format only and use Panyreron in the CVD CKD competition. That will be possibly the best option for us right now.
what do you
Also,
think, Dr. Jabir, on this? Move on to conventional MRIs in cardiac failure and in renal.
reduced ejection fraction, because the TopCat was not a positive trial. By and large, it was a negative trial. So the conventional MRI or the steroidal MRIs basically in heart failure and reduced ejection fraction, but there they reduce mortality. But the steroidal non-steroidal MRIs in heart failure and preserved ejection fraction, mildly reduced ejection fraction, no reduction in mortality. It's only reduction in heart failure hospitalization. And the cardio-kidney metabolic issue, the renal dysfunction, there it is highly effective, especially in those patients with an early glomerular damage, which can prevent the progression of the renal disease. And the renal patients also mostly die of cardiac problem. So in the renal patients, it reduces the renal endpoints as well as the cardiovascular endpoints. Whether it can be extrapolated into the steroidal agents, we do not know, because steroidal agents were never tested for such an indication.
Yes or no question. How many of you routinely test for UACR in our cardiology practice? Yes, please raise your hands. Yes, very honest answer. I think that is one message that Jabir sir said.
And why there was not a reduction in the cardiovascular mortality in that fine heart?
Fine heart, because mostly none of these preserved ejection fraction trials, none of the these drugs we have used could really reduce the mortality. It may be due to the multiple cofactors. It's rather a multi-system disorder than a heart failure. And not only that, in that particular trial, there was no reduction in the renal endpoints also. It was only heart failure hospitalization.
Yeah, Dr. Jayagopal, please.
I think in heart failure with preserved ejection, the major cause of mortality is non-cardiac. It's not the cardiac. Just a question to Dr. Hisham. We talk about stabilizing the amyloid, but then what about the depleters? And a lot of noise about doxycycline, and there are a new variety of drugs being actually introduced for to reverse the amyloidosis called the depleters.
Yes, I think that's a very important question. So I think if you saw the third half of the slide, so the first half was about agents which can limit the production of the TTR tetramers. And the second aspect was stabilizers. There are some trials, especially there's an agent called NTLA1004, which is an investigational agent, which is actually investigating whether the deposited ATTR fibrils in the myocardium and other tissues can actually be sort of degraded, or whether they can accelerate the degradation of these agents. So they're in clinical trials. We don't have robust data on these agents yet. It's very early days with these agents. Yes.
Yeah, one more query on that itself. What is the data on combining these silencers and sequencers together?
So of late, there has been Helios B trial, which in fact has some of these patients, 20% of these patients were allowed to take vutrisiran on top of the tafamidis which they were already taking. And they found that, so there is no head-to-head comparison. This was a small subgroup analysis. The entire study was not actually powered to do a direct comparison. So this is the only trial which actually had a group which was already on tafamidis background therapy and vutrisiran. So the analysis showed that the outcome differences at 30 months was not very different between the two, but there are more trials which are actually being planned, which have looked at the combination of a silencer and a stabilizer.
Well, sir, we should, one question on the cholesterol, it's one of your favorite.
Dr. Cherian George, sir. Cherian, sir.
Yeah, no, it's a comment. I think though inclisiran reduces it up to 50% LDL levels, I think whether it get translated into the reduction in maize, I think Orient 4 is going on and we'll have to wait for that. So only reduces the cholesterol level, but maize we'll have to wait for it, is it?
Yes, sir. That's one of the drawbacks of inclisiran because there is no hard outcome data as of now. This Orion trial is supposed to go on till 2049, even though the preliminary results are supposed to be out in 2027. That is the problem with proving survival in a new drug, a new class of drug.
We'll go on to one pediatric discussion, and then I think it's time to wind up. I'm very sorry. Point very well taken, sir. Point very well
Most of
taken.
your patients do not eat.
Yes, there are a lot of practical issues. One yes or no question to the audience. How many of you get jittery when you get a newborn consult, even today? I think there are many people still here. So last one point on pediatric discussion, and then we'll wind up.
Yeah. I think I would ask, other than the prostaglandin manipulation, doctors wait and see other molecules are there. What is your, that like potassium channel ATPase stimulators like pinacidil and all?
None of them are proven of efficacy. Some say adenosine, some say atropine and all, but then this has been quite available, and then it is quite clear results are available. So I don't think as of now there are no other major drugs routinely used.
Thank you. Thank you. We'll
I
have
think we should
last
conclude the session. All the actors has played a big role in there. Let us give all the actors a big clap.
Please stay on the stage and have a last bow so that we can have a group photo. As is traditional in the place, the actors and the directors stand together and get a snap. Thank you. Thank you so much. We had a wonderful start to our session. Over to you, Dr. Nimisha.
Thank you, directors, managers, and protagonists, and especially Sergeant sir. Act 1, Scene 2, Coronary Artery Disease in the Spotlight. I would like to call upon the stage directors, Dr. Saji. I would like to invite the stage directors, Dr. Saji Kurutugulam, Dr. Vinay Kumar D, stage managers, Dr. Leela Thomas and Dr. Anil Kumar. I would also like to invite our first protagonist of the session, Dr. Shifas Babu. A note of recall. Stage directors, please note that the discussions for all the topics will take place at the end of the scene following all 5 presentations. Thank you. Over to you, sir.
Now we come to Act 1, Scene 2. So we have got a few real world issues now. The first one is by Dr. Shifas Babu. Over to you.
Respected chairpersons, senior faculty, teachers, and my dear friends. So Sajan has given a case scenario like a 64-year-old chef from Tamil Nadu came to Kerala on a weekend with his assistant as part of a catering job. Suffered a STEMI inferior may can't afford primary PCI. No one to give consent to, and contacted brother give some medication and send him back. And he told me this is regarding thrombolysis. So when I heard about this topic, the first picture came into my mind is like this. Because I asked myself, how many thrombolysis I did last month? Answer is 0. Last 6 months, 2, but not for STEMI. 1 for pulmonary embolism, 1 for acute limb ischemia. What about last 1 year? 6, none for STEMI. Last 5 years, around 14 thrombolysis, but none for STEMI. In last 10 years, 1 STEMI, but that was for a instenosis, post-intervention, stent thrombosis, and lysozyl stent replace. And my SK use in last 10 years, it is only 1, but that was also not for STEMI. It was for a AV fistula thrombosis. So I think most of my friends also will have this same experience, especially in the private hospital setup. So what about Indian registries? If you are looking into the CREATE and Kerala ACS registries like CREATE and Kerala ACS, it is around 40-50%. And most of the cases, more than 90% is with the streptokinase. So that means that most of the thrombolysis is happening in the government hospital setup. Why? Because the primary PCI established its advantages like better restoration flow compared to thrombolysis, better reinfarction rate, less reocclusion, and intracranial hemorrhage is better, and reduction in mechanical complication is less. Primary benefit of primary PCI is less time independent compared to thrombolysis. Then it is beneficial in late presentation and in elderly, and it is beneficial in cardiac shock. So when we are looking into a CAPTIM trial and from the National Registry of Microinfarction Investigators. If the delay of primary PCI after diagnosis of MI, if it is more than 2 hours, then the long-term outcome is not good. So this leads to a recommendation in the last STEMI guidelines. Like if the patient is diagnosed in a PCI capable center, then we have to go for a primary PCI. If the patient is not in a primary PCI center, and if the delay for the primary PCI, if it is more than 2 hours, then we have to give thrombolysis within 10 minutes. So indication the current ARIS fibrinolytic therapy is recommended within 12 hours of symptom onset if primary PCI cannot be performed within 120 minutes from STEMI diagnosis and there are no contraindications. So what are the contraindications? This previous intracerebral hemorrhage or stroke of unknown origin at any time, ischemic stroke in preceding 6 months, central nervous system neoplasms or AFib malformations, recent major trauma, surgery, head injury within preceding month, gastrointestinal bleeding, non-bleeding disorder, aortic dissection, and non-compressible punctures in the past 24 hours. And there are some relative contraindications also. And what's the benefit of thrombolysis? It prevents 30 early deaths per 1,000 patients treated within 6 hours after symptom onset. And the largest benefit is within 2 hours. And what about pre-hospital thrombolysis? Pre-hospital thrombolysis reduces early mortality by 17% compared to in-hospital fibrinolysis if it is less than within 2 hours. And in STREAM trial demonstrated that pre-hospital fibrinolysis followed by an early PCI strategy was associated with a similar outcome as transfer for primary PCI in STEMI patients presenting within 3 hours after symptom onset who could not undergo primary PCI within 1 hour of first medical contact. So what are the available fibrinolytic drugs? The cheapest one is streptokinase. We know that it is in powdered form and we have to reconstitute with the 5 ml saline or 5% dextrose. Then we have to mix it into the 100 ml saline and we have to give it over 30 to 60 minutes. And we have to look for hypotension, anaphylaxis, bradycardia, arrhythmias, etc. And now we have better drugs, fibrin-specific agents like alteplase, retiplase, and most commonly used one is tenteplase. And if you want to, because if you have forgotten about the streptokinase and if you want to know about streptokinase, there is one book. This is the Trivatam Protocol, and it is actually published in 1997 before the primary PCI era. And you can see many of our teachers' chapters in that. And in this book, there is a beautiful chapter by Dr. Late Tennyson sir. And you'll get A to Z about streptokinase usage in this particular, and you never get any more than this details in any of the journals or this. So I'm using this opportunity to pay homage to him. So what about bleeding? Intracranial bleeding is 0.9 to 1%, and major non-cerebral bleed is 4 to 13%, and advanced stage, lower weight, female sex, previous cerebrovascular disease, systolic and diastolic hypertension on admission are significant predictors of intracranial hemorrhage. And how do you know successful fibrinolysis? It is basically a disappearance of chest pain, ST segment resolution more than 50% at 60 to 90 minutes, and typical reperfusion arrhythmias, especially accelerated ventricular rhythm, late VPCs, and sometimes bradycardia. And early high rise of CPK is also a feature of successful fibrinolysis. And what about failed lysis? The combination of less than 50% ST resolution and absence of reperfusion arrhythmias at 2 hours after treatment predicts streamy flow less than 3 in the infarct artery. It has a sensitivity of 81%, specificity of 88%, and positive predictive value of 87%, and negative predictive value of 83%. So, interventions following fibrinolysis. Emergency angiography in PCI is recommended in patients with a heart failure, shock, or evidence of reocclusion or recurrent ischemia after successful fibrinolysis. And rescue PCI is indicated immediately when the fibrinolysis has failed. As I mentioned, less than 50% resolution at 90 minutes. And angiography and PCI of infralateral artery is recommended between 2 to 24 hours after successful fibrinolysis. And what about re-administration of fibrinolysis? There is no benefit as from REACT trial. So we have to do a rescue PCI if there is failed fibrinolysis. And what are the objectives? Aspirin and clopidogrel reduces the risk of cardiovascular events and overall mortality in patients treated with the fibrinolysis. Prasugrel and ticagrelor have not been studied in adjuncts. And GP2B3 inhibitors, no evidence, bleeding may increase. And what about anticoagulant therapies? Parenteral anticoagulation should preferably be given until revascularization. Otherwise, it should be given for at least 48 hours or for duration of hospital stay up to 8 days. And net clinical benefit is favored enoxaparin over unfractionated heparin as in ASCENT 3. And fondaparinase have some data in streptokinase. And Clopidogrel, actually, if you are planning for a thrombolysis, we have to avoid loading dose if the patient is more than 75 years of age. And regarding enoxaparin, usually our usual protocol is if we are planning a tenterplace, we will give 30 milligram of IV bolus, then we will give tenterplace, then after 15 minutes we start the sub-Q dosages. So what about bivalirudin? In this HERO 2 trials, some data with the streptokinase treated patients, but otherwise no evidence. So coming to our patient, I will try wait at this IV tenterplace, aspirin and clopidogrel, and enoxaparin IV followed by sub-Q administration until the time of PCI, because this is a most studied cocktail. Thank you.
Thank you, Shifas. We move on to the next. We'll have the discussion at the end.
Thanks.
Optimal sedation protocols during primary PCA, Dr. Anil.
A very good evening to you all. To start on a lighter note, Shifas, you should be happy that Sajan called you for a cricket match and gave you a unfamiliar tough pitch. To me, he called me in full attire for cricket and gave me a gold stick in the form of sedation protocols. When he gave me this topic, I told him I have only 2 slides. First slide, as everyone does when the patient is agitated, call the anesthesiologist. Second slide is exclusively for me. That is, I have a private hotline number which can be contacted 24 hours. That is my better half, who is a cardiac anesthesiologist. So that was it. So coming to the scene for the protagonist, this is again AI generated image. Sergeant wanted the patient in the ICU. My cath lab staff shifted them to the cath lab. Agitated, young, anti-revolve MI patient. So what are the basic problems here which is creating trouble? One is the intense anxiety, the so-called anger anemia, extreme pain of anti-revolve myocardial infarction, and most importantly, hypoxia, brain hypoxia resulting in delirium. So having said that, I still remember another case which I had during the start of my career, a patient, young patient with anti-revolve MI in the wee hours, fully spirited gentleman. By the time I was wearing my gloves, he was standing on the cath lab table staring at me. So after great negotiation, I had to tell him this one to calm him down. So these sort of scenarios are not at all unfamiliar to the cardiologist, and you should know about the basic sedation protocols. So with that, let us go to the plot per se. Cardiac catheterizations and PCI are typically well tolerated, but not at every times. Significant pain and anxiety may occur in emergency situations. So if you look at the ACC SKY expert consensus document, they have made a very emphatic statement. Appropriate sedation is imperative and ensures patient comfort. That's it. That's the end of it. There are no further recommendations, no data to support the recommendation. Believe me, even in anesthesiologist guidelines, there are no specific recommendations for drugs as of now. So before going to the how to deal with the agitated patient, you should know what is this depth of sedation. So we cardiologists should be aware of the left extreme part of the table, that is minimal and moderate sedation. Here we are calming down the patient without affecting the airway, ventilation or cardiovascular function. So our aim is to achieve that, and the second part you leave to your good colleague who is the anesthesiologist. So what are the drugs available? Benzodiazepines, they are good anxiolytic, and more importantly they give good anterograde amnesia. That is why if a patient, if you give midazolam, the next day when you ask him, that is right, because this gives good anterograde amnesia. So the drug which is commonly used is midazolam. The dose range comes around 0.5 to 5 milligram, and time to peak effect, just see 3 to 5 minutes, and half-life is just 1 to 4 hours. You should also know the antagonists for these drugs also, that is flumazenil. There are other drugs like diazepam which orally, which can be given in an elective setting but not in an emergency setting. So to cut short, the benzodiazepine which can be used is midazolam, which has got a rapid onset, shorter half-life, can be given shortly before the procedure with fewer implications in the post-procedural period. Now coming to the second group of drug, that is the opioids. We have the good old friend morphine. I think you all remember the mnemonic MONA, that is morphine, oxygen, nitrate and aspirin. That was the cocktail which was used in the earlier days. But this good old friend is not very favorable at these times because of the various adverse data for morphine. So the drug of choice currently is fentanyl, which is given in the dose of around 25 to 100 mics. Again, the onset of action is around 2 to 5 minutes, and the total duration of action is around 30 to 60 minutes. And if you look at it, to cut it short, the potential opioid of choice is fentanyl, rapid onset of action, there is lack of active metabolites. So in renal impairment, you need not have a dose reduction per se. So you should also know what are the beneficial as well as deleterious effects of these cocktail. Beneficial effect, most important, it offers cardiac protection and it has shown to produce coronary dilatation. And believe me, high dose morphine has been shown to reverse cocaine-induced coronary vasospasms. And it can reduce the pain and anxiety, obviously. We should also know about the adverse effects. The most important one is nausea and vomiting because this can interfere with your antiplatelet drug action. If you are in the habit of loading patients on table, think twice before giving these drugs. And there are certain studies which showed increased infarct size with morphine. That is why morphine is going slightly out of the whole scene. And certain patients can have paradoxical agitation, the so-called Velakandechada Pandai. We're giving something to calm down the patient, but the patient can have a paradoxical agitation. And you should also know the associated medical conditions. The patient is having a renal impairment, be careful with morphine and pethidine. The patient is having a liver impairment, be careful with benzodiazepines. Obese patient requires more doses of the anxiolytic drugs. Sleep apnea is a relative contraindication for sedation because high risk of hyperventilation and airway obstruction is there. So the war room tactics should be always give oxygen supplementation, monitor the vitals, SpO2, respiratory pattern and respiratory depth. That is very important. Always calculate the total dose of sedation and give in division, that is give us bolus doses. Restrain the patient because there is high risk of fall for such patient when the patient is agitated. A person with good intubation skills to be present in the cath lab, that is very important, and ACLS team and equipment should be on standby. What are the triggers for intervention? If there is a drop in oxygen saturation, if there's a loss of spontaneous respiration, if there's a hemodynamic compromise, the patient is going for a cardiorespiratory arrest. Call your good friend who is the anesthesiologist. If you don't have one, I advise you befriend one. So leave alone the emergency part. This is one data in the elective setting. That is, there's a data of around 2,000 patients which shown that routine procedural sedation, that is mild dose of 1 milligram of midazolam and around 50 mics of fentanyl, resulted in less spasm in the case group. And the number needed to treat, just see, it is just 18. So this is one thing you can think about because if you want to reduce the radial artery spasm, that is of great use. So denouement or the conclusion, as sergeants say, there is limited evidence to guide the optimal use of sedation for the cardiac catheterization and coronary intervention. In the given case, I may give 2 to 3 milligram of midazolam, 50 mics of fentanyl, and enough of inverted commas vocal and restrain the patient and keep the procedure short and sweet and come out of the cath lab. Benzodiazepines and opioids likely results in reduced pain and improved patient tolerability. The decision on whether to use sedation, which agent to use, dose should be individualized based on patient factors. So to play cricket with golf, I got inspiration with this guy because he is playing cricket with the bat upside down. He is the god of cricket. I am just a cardiologist. Thank you so much for your patient listening.
Thank you, Anil. That was wonderful. You got a lot of questions waiting. Now we move on to the next one.
May I invite the next protagonist, Dr. Bina Benjamin, to speak on CT coronary calcium scoring.
Respected chairperson, senior colleagues, teachers, and friends. The index case is a 44-year-old techie from USA. He wants detailed cardiac evaluation. He has dyslipidemia. His father had CAD and post-TAVR. This patient, obviously, doesn't have any symptoms. He needs primary prophylaxis. So you can use one of the ASCVD risk assessment calculators to find out what is his risk. You'll get a value. It could be somewhere between 1 to more than 20. So this patient, I didn't get the complete profile of this patient. Most likely you would be falling somewhere in the borderline or intermediate risk category, somewhere between 5% to 20%. So in a patient with intermediate risk for atherosclerotic cardiovascular disease, what next? Most of the cardiologists among us may be asking for a treadmill test. But when I search the literature, there is no data or there is no guideline supporting treadmill to be used in these type of situations in an asymptomatic patient where there is no strong suspicion of clinical cardiovascular disease. Guidelines in these type of patients, right from 2018 blood cholesterol guideline, they recommend in intermediate risk group, you go for coronary artery calcium scoring rather than stress test. Again, in 2018 and 2019 primary prevention guideline, in intermediate risk group, CAC has been given class 2A indication when then there is indecisiveness regarding the role of statin. Multiple guidelines after guidelines recommend CAC in intermediate group. Recent 2022 expert consensus also recommends the same. So what is CAC? This is Arthur Agatston. He is a cardiologist from the United States. He introduced this particular calcium scoring, otherwise known as Agatston score. It is a highly specific marker of subclinical atherosclerosis. Not only that, it's a strong predictor of future atherosclerotic cardiovascular events. What you do, you use low radiation multi-detector CT scan to find out this calcium scoring. I'm not going to the detail, but CAC scoring is a function of both area and density of calcification. So at the end of that, you can get two types of score, absolute score and a percentile. An absolute score, you get a value. Here, you just get a value. It doesn't account for the age, gender or race of the patient. But say it is 100. 100 may be significant in a young patient, but the same score 100 may not be having the same impact in a person who is 70 or 80. So you have to adjust for his age, sex and race. So you can go for relative score. Here it considers percentile of plaque burden based on age, race and gender. So these two types of score in CAC. So what are the advantages of CAC scoring? It's non-invasive. You don't need even an IV cannula. No contrast. Don't bother about kidney function. It's cute. Hardly take 10 minutes. Cheap. Double the cost of a treadmill test. Low radiation involved. If you look at the radiation, it's almost double that of a bilateral mammogram. Widely available. Can detect CAD very early, much before the symptoms appear. If you look at the guidelines of CAC, get confused. You have guidelines from multiple parts of the world, American, UK, European, Australian, New Zealand. So, and not only that, you have specialty guidelines also. You get perplexed. So this particular review article from JACC, Major Global Coronary Artery Calcium Guidelines, help you. This paper compares 7 clinical practice guidelines from CV societies across the world. And they found out there are certain disagreements as well as agreements among these guidelines, mostly agreements. First, we'll discuss the agreements. One common agreement is regarding the indications. When will you do CAC? Here, it should be the age more than 40 years. Don't ask for CAC in young patients because in young patients, mostly soft plaques, which may not be causing calcium spikes, and go for, do that in intermediate risk patients and particularly when they are asymptomatic. So the typical indications are there in asymptomatic patients where the index of suspicion for a clinical cardiovascular disease is less, more than 40 years and intermediate risk. Now regarding the common treatment threshold, there is agreement regarding the use of CAC. When CAC is less than 0 or 0, downgrade the risk. You withhold statin or there is no role for statin. When the CAC is more than 100, initiate statin. Agreement regarding that. But there are certain areas where there is disagreement. Certain guidelines, they, depending on the calcium score, they advise aspirin for primary prophylaxis. So here there is some difference of opinion. And in some of the guidelines, you optimize antihypertensives depending on coronary CAC scoring. In pre-hypertensive or stage 1 hypertensive, you optimize the antihypertensives based on this. So these are the agreements and disagreements. You go for a patient, select the patient wisely. You select patients more than 40 years, intermediate risk without any clinical suspicion or symptom or of CAD. Now, the most recent issue of JACC in November, the latest one, has come forward with a staging of coronary artery calcium to gate preventive interventions in individuals without clinical ASCVD. This is based on coronary calcium scoring, existing primary prevention guidelines, and 2022 ACC expert consensus decision pathway. And they are staged into 5 depending on CAC score. The first stage is 0, where the CAC is 0, and it can go up to 1, 2, 3, and 4. I'll briefly touch upon each one. The first stage 0, here the CAC score is 0. Here, there is no indication for statin. There is no need to consider statin unless there is a compelling indication like diabetes, high LDL, smoker, family history, etc. When you go to stage 1, CAC is between 1 to 99. Here, mild atherosclerotic burden is there. You can consider statin along with anyway, in all patients you promote optimal risk factor goals. When you reach the stage 2, CAC score is 100 to 300. Here there is moderate atherosclerotic burden. You have to advise statin and need to achieve an LDL cholesterol less than 70 and consider low dose aspirin therapy in this group. When the score crosses 300 to 99, here the risk is more like a patient with secondary prophylaxis. The risk of myocardial infarction is similar to that of a myocardial infarction survivor. Severe atherosclerotic burden. So, along with all these things, you go for high intensity statin and low dose aspirin. Try to achieve an LDL less than 55. When the CAC is more than 1000, extreme risk, similar to have multiple atherosclerotic cardiovascular event rates, you go for high intensity statin, non-statin therapy, and other emerging therapies. So there is evidence of association of atherosclerotic cardiovascular events in CAC, which is overwhelming. But at the same time, the benefit of preventive therapy based on CAC severity is not yet fully established. Now, when to repeat CAC scoring? You repeat CAC only in those where the CAC score is 0 or close to 0. And when to repeat, that depends on the risk. In high risk, those patients who are diabetic, you may repeat in 3 years. And low risk patients, you can wait for the next 7 years for a low risk patient. So next, this is a crucial question. Is it time to include coronary artery calcium scoring in executive health checkup package? For me, it's a big yes, but you have to choose your patients wisely. I would like to hear from the respected chairpersons and the elite audience. Thank you.
Thank you, Bino. That was a wonderful talk. We'll have the discussion at the end.
Yeah, next we may invite James Thomas for the regarding talk on TMT.
Respected chairpersons, teachers, senior colleagues, and dear friends. So this is the topic which I have slightly modified from what Sergeant has given me. So the topic is TMT, positives, negatives, and some things in between. Now this is a script. 60-year-old lady, mother of neurologist, mild diabetic for 1 year, mild dyslipidemic on irregular statin, has history of recurrent atypical chest pain. She comes with a TMT report done elsewhere, probably the hospital where the neurologist is working, which has reported as borderline changes for inducible ischemia. Now luckily, the idea to do treadmill was not mine. If it was mine, I would have said the dialogue of Valencia in Mahesh. Mahesh's പ്രതികാരം ഇത് എൻ്റെ ഐഡിയ ആയിപ്പോയി നിന്റെ ഐഡിയ ആയിരുന്നെങ്കിൽ ഞാൻ തന്നെ കൊന്നേനെ. So luckily it was somebody else's idea. So basically I had to interpret this TMT and not wonder why did I do it in the first place. So the first question is whether we should do treadmill in this patient. So we know that treadmill is one test which is indicated when your probability of having a coronary artery disease is intermediate. If it is high probability or high pretest probability or low pretest probability, the indication is only class 2B. So do it when you suspect CAD and the suspicion is of intermediate severity. That is, in the pretest probability is intermediate. The next question is, do women behave differently on treadmill? We know that women has lower CAD prevalence, especially premenopausal. Most are unable to exercise to maximal aerobic capacity. And one important factor is that resting ST changes are more frequent in females, so that there are more chance of false positives when you are doing treadmill, especially in premenopausal women. But in symptomatic intermediate risk women with normal resting ECG, actually TMD is the first test of choice. So you can't blame the person who has done the treadmill. So now it is our job to interpret. We have done the TMD, so what is the verdict? So when you do the treadmill and you get the result, it is not often in black and white. It is often in 50 shades of gray or 100 shades of gray. Sometimes it is clearly positive, sometimes it is clearly negative, but most often you get this gray area where it is open to interpretation. So what exactly are we looking in a treadmill test? We have to see the clinical response, which is very important: chest pain, exercise capacity, hemodynamic response, heart rate, very important, and the blood pressure response. But I will be focusing upon what Sajan has given me, that is the ECG response, that is the borderline treadmill. So I will focus upon this, that is the ST segment. So we all know how to measure the ST segment in a treadmill report. We know that the TP segment is the real isoelectric point, but when you're doing a treadmill, you take the PQ junction, see the J point, and measure the ST at 80 or 60 millisecond depending upon the heart rate. So this is no confusion. This is the unequivocally positive treadmill. That is, you have more than at least 1 millimeter ST depression from the PQ junction at ST80 or ST60. But it has to be a horizontal or downsloping ST depression. That is the current AHA guideline. The only thing is that if there is an underlying or already a baseline ST depression, there has to be an additional 1 mm ST depression. We also have to know that if someone is having more than 1 mm ST depression in the resting ECG, that's actually a class 3 indication or a contraindication of doing a treadmill. So never do a treadmill in someone who is having a baseline ST depression more than 1 millimeter. Again, unequivocally positive, we know that ST elevation more than 1 millimeter. So there is no confusion regarding that. And the unequivocally negative, no ST depression, of course negative, and the J point only ST depression. So that is, there is no, the ST depression is less than 1 millimeter at 60 millisecond or 80 millisecond, no confusion, unequivocally negative. So where is the confusion? Confusion is regarding this, the equivocal treadmill. So this is the definition for the equivocal treadmill given by 2013 AHA. That is the upsloping ST depression, where there is more than or equal to 1 mm ST depression at ST60 or ST80, that is 60 or 80 millisecond after the J point. They acknowledge that we can identify CAD in highly symptomatic individuals, but in a general population, it is not predictive. And if you take it as a positive response, the specificity of a treadmill will come down. But the question is, can you fully ignore the upsloping ST depression? Now, I hope you can identify this gentleman. He is none other than enlisted, who wrote this landmark book on stress testing. And this is his data, which came in 1976. When he took a cutoff of 2 mm ST depression, the downsloping patients or the patients who had downsloping ST depression, of course, fared bad. But the horizontal and the upsloping ST depression were almost similar if you see the hard events. And the incidence of CAD was also similar in those who were having horizontal ST depression compared to those who were having upsloping ST depression. Similar data in other study also, that is, even if you are having upsloping ST depression, even though the chance of finding a normal coronary arteries were higher, still significant number of patients had single vessel, double vessel, or even triple vessel disease. So that is why Elistad gives the criteria, that is, he considers, or there are a group of people who considers that you have to take ST depressions also significant, but only thing is that the cutoff is 1.5 millimeter, and if you increase the cutoff to 2 millimeter, it actually improves the specificity. But only thing we have to make sure is that you have to do it in a higher risk group patients. That is, if you do it in the entire population, of course your specificity will come down. Now there is one division of this upsloping ST depression into fast versus slow, or the slope of the ST depression. So this is how we calculate. From the J point, you will draw a line till 1 second, and from there you draw another line, perpendicular line, and then you extrapolate the ST to meet the perpendicular line. So where it meets gives you the slope. So here it is a fast slope, which is supposed to be negative. And here you can see that it is a slow slope. So the question is whether this is positive or not. So does the slope really matters? The ELISTAT again has the answer. We know that the slope is slightly difficult to measure, tedious, and actually it is not required. You see here, if the ST depression persists for 80 milliseconds after the J point, it has to be slow upsloping. So you don't have to measure the slope. If the ST is still depressed at 80 milliseconds, it is actually slow upsloping. Why is this upsloping ST elevation occur in healthy patient? That is because of this, because there is something called the atrial repolarization wave, which we usually don't see in the ECG because of the QRS complex, but can be seen in complete heart block patients. Here you can see that. This is the atrial repolarization wave. This actually occurs in the direction opposite to the P wave. It has got a reasonable magnitude. And sometimes what we see that, what happens in exercise is that the amplitude of the P wave increases. So the atrial repolarization wave, the size of the repolarization wave also increases. And especially in patients who are having short PR, it can extend through the QRS into the XT segment and cause ST depression. And one important point is that it is accompanied by a downsloping PR segment. Here you can see that. So how to differentiate? Only 1 or 2 slides. How to differentiate ST depression due to this atrial repolarization versus ST depression due to a really positive one? That is, those patients in which this atrial repolarization wave is causing the false positive ST depression usually occurs at a higher peak heart rate. The patients often have a large amplitude P wave, and there is often a greater J point depression. And most importantly, you can find this downsloping PR segment just before the ST depression. And also they are prominent in inferior leads, that is in those leads where the P wave is more prominent compared to the true positives, which is more commonly seen in maybe in V5, V6. So this is that pattern. You can see the downsloping PR segment in those patients who are having false positive exercise test compared to true positive, and also more commonly seen in 2-3 AVF compared to that seen in V4 to V6 in true positive treatment. Of course, there are 1 or 2 other parameters which you can use. You can adjust for the heart rate, etc., etc. And even after doing all this, if it is still equivocal, of course, you have to consider stress imaging, which is a class 1 indication, or a CT coronary angiogram, which is actually a class 2B indication. So I will leave you with this message. Choose the patient for a treadmill wisely. Equivocal or upsloping ST depressions are very common. Upsloping ST depressions also probably significant in higher risk patients, especially if they are symptomatic. Cutoff we have to keep at least 1.5 mm. Rule out this atrial repolarization wave as a cause of this false positive upsloping ST depression by the criteria which I mentioned above, especially the leads in which it occurs, and also the accompanying the PR depression. And always interpret this equivocal TMT in the proper clinical context. And when you see this report, always try to give an unequivocal advice in equivocal TMT reports. Because don't let the patients tell you this. Like what Arjuna told Sri Krishna in Bhagavad Gita, my intelligence is bewildered by your equivocal instruction. Therefore, please tell me decisively what is most beneficial for me. Thank you.
Wonderful, James. Okay. So now we'll go to the next talk and then we'll call you back. CTO intervention. Why I am a believer and others are non-believers. Is that? No. You have an opportunity to convert everybody.
Actually, the stage director actually misinterpreted the talk.
Intentional misrepresentation.
Correct. So actually, CTO PCI after a culprit PCI is actually the question asked. CTO PCI should I attempt? It has a low success rate, high incidence of complications, high cost, and perceived lack of clinical benefit. Patient's perspective, clinical benefit is a question mark, cost, risk. Clinician's benefit,
basically a procedural complication and technical success rate. Is it risky? Basically, the mortality is 0.14 in normal PCI, and it is compared to say 3 to 4 times more in CTO PCI. If you look at the CABG data, it is more than CTO PCI. From physician's perspective, success rate. It requires a lot of wires, dedicated microcatheters, dedicated re-entry system, development of hybrid algorithm, etc. Success rate actually in experienced centers 85 to 90%. The CTO PCI success rate is proportionate to the CTO PCI volume by operators. The operator and the hospital CTO PCI experience were directly related to procedural success, but were not related to the major adverse events among patients undergoing CTO PCI. If you look at the CTO, there is actually a gradation of skill development going up to the retrograde collateral using septal collateral, then epicardial collaterals. What are the complex subset? Patients with a low ejection fraction, frail and elderly people, advanced CKD. Technically, ipsilateral collaterals with the left dominant system, previously attempted CTO and post-cabbage. What are the difficult lesion morphology? Ambiguous proximal cap, ambiguous CTO, post calcific CTO, long CTOs. Operator experience, definitely skills and selection of the case are very important because of the complication and the success rate. Which are the cases reserved for the dedicated operators like stumbless CTO, heavily calcified CTO, previously failed CTO, ostial CTO, and long and tortuous CTO? What are the complication rate? If you look at the Japanese registry, it is less than 2%, but otherwise it is more than 3%. From both the patient's and the physician's perspective, is there any clinical benefit? Angina, will it affect mortality? Basically, angina affect almost 1/4 of the patient's stable coronary artery disease. Persistence of angina associated with a high rate of cardiovascular events. If you look at that, patients without angina and patients with angina actually have an increased risk of myocardial death. Symptoms of angina and dyspnea should be the indication for CTO PCI. Any improvement in angina exercise capacity of quality life after CTO PCI? Yes. EuroCTO, there is a study done by Gerald Werner, indicate that the MACE rate was higher in the medical therapy group, and successful PCI leads to lower event rate, even though there is no mortality benefit. If you go to the quality of life, definitely it is more improved by CTO PCI. Reduction in the major cardiac events in long term, yes. Whenever there is a data published, 10-year data, definitely showing the Korean group telling more survival with the CTO PCI group. And this again, the Canadian registry also shows more survival with the CTO PCI in long term. What is the role of CTO device in LV dysfunction? Yes, if it is more than 2.8 years, there is definitely a significant advantage in the patients with severe LV dysfunction. Should I do a PCI after culprit PCI in acute MI? STEMI, successful revascularizations will reduce cardiovascular death. Actually, if you look at the AMI study with the data with the Korean registry, improved 1 year survival. And PCI of the CTO of non-infarct related artery, again, improved long-term clinical benefit. Tips to improve the outcome: attempts at recanalization at acute phase should be discouraged. Keep equipments ready. You should know about your guide wires. You should know about your microcatheters. You should be familiar with the dual lumen catheters. You should be familiar with the low profile balloons for the CTO crossing. You should be knowing about the guide extension catheters. You should use IVUS in complex cases. Proper techniques, adequate hardwires, skilled operator, success in CTO is possible. Meta-analysis: successful CTO PCI have a low risk of death and stroke. Definitely, it improved the clinical outcome. Success matters. I'll show you a case, actually, a 54-year-old, similar case which is given by Sergeant to me. RCA, MI 3 years back. The patient actually had an unstable angina on 19/1/2023. TMD was done, strongly positive outside. Angiogram done, osteoproximal occlusion of the RCA. they attempted a PCI to RCA on 6/2/2023. So the reattempt is good or not? That is a question asked by Sergeant. So Sergeant is asking this question. So the answer is, I used dual catheters actually with the multiple wires FC, XTR and Gaia-3. This was the result created in this patient. If you go to the next case, a moderate LV dysfunction, triple vessel disease with 100% occluded LAD and RCA. Acute pulmonary edema, admitted in our hospital for further management. Patient was on a mechanical ventilator with a global EF of actually ejection fraction of 32%. Angiogram outside, LAD CTO, patient was actually having an RCA disease. Advised cabbage, referred to a hospital in Cochin. On the way, the patient thought that I can get into the hospital because of a daughter is a nurse. Angioplasty done to the RCA in 15 minutes time. But can we leave this vessel? Patient extubate on the next day. EF improved 35%. Creatinine also improved. It was actually 2.7 mg/% 2 days back. What to do? PCI, cabbage or OMT? Rota and OPN assisted OCT guided PCI to the CTO LAD produced a result like this. NSTEMI, 61-year-old man, post-cabbage. This was a lesion. Stenting done into the graft. We managed like this on maximum medication, ranelacin, nicorandil, nitrate. This was the angioplasty. Patient is doing well for the last 3 years with IVUS guided. RCA CTO, this I did a live demonstration in Aurangabad in 2022, refractory angina in a 42-year-old female. Twice attempted antegrade CTO. Lot of wires and material used, opened the CTO in the RCA. This was a patient, unstable angina 5 months, LMCA CTO, 8/5/2024. This patient came to me with a creatinine is very high, ejection fraction of 28%, moderate MR, moderate TR. I did this case on a live demonstration. We used, keeping the angiogram on the other side, I used a Suhotri wire. You can see the microcatheter on the PDA. These are all the left system is actually taken different. You can take the wires going from the wire. Actually, I just looked at the angiogram and taking the wire from the PDA, you can actually see that this wire will go easily up into the LAD. Wire goes to the LAD. Once the wire goes inside, I 0.5 ml of contrast I use to understand that the wire is in the proximal, that is actually use the microcatheter. Cyan black is externalized. Once I externalized, I did IVUS in the RG3, fine cross across the septal artery. IVUS shown that vessel is actually negatively remodeled. Balloon, FC, IVUS, LM to LAD to LM. IVUS again, pull back, cutting balloon used, 2 stents used, 3.5 into 28 and 1 more stent. We have seen an edge dissection, 1 more stent and the final shot. Taken only 12 ml of contrast, creatinine is improved 0.9. So the CTO intervention is beneficial if you could demonstrate ischemia. LV dysfunction with the persistent preserved thickness will get benefit from CTO. CTO will reduce long-term mortality. Angina reduction is already proven. In asymptomatic patient with a CTO, inexperienced and low volume operators should never attempt. If you are in confusion or success, don't forget to refer to me. Above 5 patients came to me from the hospital, not by hospital referred, patient by themselves. Thank you.
Thank you, Pratap. I think you please stay. Please stay. So we'll call all the actors onto the stage.
Dr. Shifas, Dr. Anil, Dr. Bino Benjamin, Dr. James.
So please, all the actors onto the stage. You have only one director and associate lady director, so nothing to worry about.
Actually, the thrombolysis, why we included was last month I came to know about a DM student, cardiology DM student in Kerala, who said that candidate has not seen a single thrombolysis during the DM course. So that's a reality. So that's why.
First one to
Yeah,
Shiva. Let's start
Dr.
from the top.
Shafas.
Start-
Sure.
yeah, let's start.
Thrombolysis we'll ask. So despite the number of thrombolytic agents and available, and also there are a lot of studies, extensive studies regarding its beneficial in survival and also in keeping the patency of the artery, but still it is underutilized in acute myocardial infarction. So what in Indian scenario, current scenario, what could be the probable reasons why it is still underused in spite of demonstrating its benefit?
It is, actually, government setups, I think it is using. As seen in the Indian histories, around 50% patients are 50%.
No, Sajan was telling it was not, he has not seen it.
One DM candidate in a private medical.
Most of the private hospital, it is really underutilized.
Lot of schemes are there, and I think that is one reason, because if one patient coming with a STEMI, most of the time from the ER emergency room itself, they will be tuned for primary PCA. Then it is available also. That's
Can I? Django ഞാൻ പെട്ട് എങ്ങനെ പുറത്തിയാടി? So what will you do in such a situation when you have only a consent from
actually, I haven't come across such situation, because I'm working in a private hospital setup, and most of the time, and I actually, as in the case of that case scenario, it's a chef. And nowadays, chef's salary is much better than most of the MBBS doctors. So most of the time they will agree. So otherwise, what we can do is we will thrombolyze with. And the thing is, if we have to thrombolyze with a tenter place, that costs around 40 to 50,000 rupees in private hospital setup.
Yes, and I have come across such situation. We can even take a consent over phone, and this phone consent is valid. So I asked our medical superintendent also.
For license also, anyway, we need to take a consent.
Yes, so it's the same thing. It's the same thing for primary or for license. So something happens after the license. So that is really going to be a problem. So that also we can take the consent over phone and then proceed and do it. So we'll move to Anil. Optimal sedation in primary PCA. So actually the scenario was the patient was agitated in the CCU. Some of the patients are as cool as a kitten, but some of them are like a Rottweiler. So how will you sedate in the cath lab, in the CCU before shifting the patient?
So the same protocol, even though there are no specific guidelines, as I mentioned, there are no specific recommendation for specific drugs. But with available data, you can use a cocktail of a benzodiazepine, preferably midazolam, with an opioid. The currently best recommendation is for fentanyl. You can give a combination of both, pacify the patient, and then shift him. And it is always better to restrain such patient, because there is two things. One, he is agitated. Second, there is high risk of fall from the cath lab table, which can again further complicate your
A scenario what he described is the patient is quiet in the CCU and become agitated when they are in the cath lab. So that is a problem. So the best thing what you said is right. Get an anesthetist, but so you have a very close anesthetist on call. So that is not the case with everybody. Please.
See, this patient is in acute pulmonary edema. See, all the case scenarios in the meeting are real life patients that we have seen. So this is a patient in acute pulmonary edema. So would you consider elective intubation before you take up such a patient?
It depends upon how the clinical situation is. The patient is having a significant desaturation, he is not able to lie down properly. If you can consider BiPAP on the table and do the procedure, and still the patient is cyanotic, not maintaining saturation, better to call in an anesthesiologist, intubate the patient and do the procedure.
Intubating the patient prior may be a better idea, because the patient will be calm and our adrenaline levels also will be less, because we don't have to be looking at the patient on one side and looking at the screen with the other eye. It's difficult.
Dr. Bino, calcium scoring offers an actually inexpensive test and does not require contrast also. So you beautifully clearly explain what the utilization in the reassessment of the risk, especially in intermediate cases. So can you, we can utilize it more in our executive checkup, like how can you utilize it more in our current scenario?
we cannot advise this to all common garden patients. We have to choose these patients. Like for many of the executive patients, they would be having some other clinical cardiovascular disease previously. They come for executive checkup. When you evaluate the patient, they would say previously I have one stent inside. I came for another checkup. We won't bring any documents. So in these type of patients, there is no point in going for CAC scoring. So you have to first screen these patients, make sure it's a patient who never had coronary artery disease and there is no symptoms. Then if the patient is more than 40 years, you can go ahead.
See, when we see patients with executive checkup, we get a patient with echo is normal, ECG is normal, borderline lipid levels, and TMT is negative. And this patient may be having multiple risk factors like positive family history. See, many of these ASCVD risk score and other does not include family history, does not include lipoprotein A levels. So, which is definitely a drawback. We tell them your heart is okay. Are we telling the right thing? No. We cannot. We are not. Even in an asymptomatic patient, it is not. How do you react to the idea if we say that in an executive checkup, instead of treadmill, replace it with a calcium score?
Surely, data is like that. We are not underutilizing CAC. We should use it more.
So when we have
actually data is supporting CAC score. That is what it's actually showing.
When we have a patient with calcium score 0, it does not mean the risk is 0, but the risk is near 0. It's almost 0, but it is never 0 because we definitely there can be soft plaque and it can be different. So, and also calcium score tells you about the extent of the disease and not about the severity of the disease. So these are the two important things we need to know about calcium. And it is not used for assessing the response to therapy as you said.
Yes. That's why it's not repeated in those patients who are already on treatment.
Yes.
Once you have decided regarding the treatment, to know the response of treatment, repeat scans are not advocated.
Time and again, we come across patients with TMT negative and they come back after 6 months or 1 year with an MI or an ACS and we see the angio got triple vessel disease and the patient is asking what is this? So that's a problem. So we do it above the age of 40, asymptomatic patient. This may be a useful.
That may not happen with CAC. Once the score is 0, I won't think you
when
must
the
be
score is 0, you can reasonably say that your risk is extremely low.
If the score is high, I mean like more than 100 or so, what next? You do a coronary angiogram?
No.
Or you go for a
coronary angiogram should be symptom guided or if there is any evidence of clinical evidence of CAD. Otherwise, no coronary, but you will risk stratify, start statin or if necessary aspirin if the score is more than 300. That's a primary prophylaxis.
Secondary is 300.
But in primary prophylaxis patient itself, if the score is more than 300, their risk is as good as or more than that of a secondary prophylaxis patient. Yeah, that's right.
Excuse me, I have one question, combined question to Dr. Bino and James. So this is a real life patient. This is my cousin, my first cousin. He's around 65 years old. There's one risk stratification program in Bangalore. It's called Nuvo. They combine CAC, TMT, everything for 10,000 rupees. And this gentleman had a calcium CAC score of more than 3,000 and his TMG was negative. Mildly positive. Say, like you said, the borderline upsloping that you showed, James. And he was asking whether an angio should be done. So the patient is asymptomatic and he walked 13.5 minutes on the treadmill. So this is again another problem. So my just way out was to rope in a colleague who was in the town of, who resides in the same town as this patient. And I said, you please get his opinion. And then anyway, I sent him across this thing about this more than 3,000 CAC score, keep on LDL less than 50 and the antiplatelet drug and management of the risk factors. So what will be your suggestion if the patient is asking for an angio?
It's only to you.
No, he's asking, should I do angio or not?
Tough question.
In this patient, it's a even though he's having significant coronary disease, it's a stable disease.
Yeah, that's right.
So what are you going to gain by doing angiogram? Suppose you are seeing one lesion, you address that. What's the gain? There is no morbidity benefit, no mortality benefit.
Yeah, I was thinking about it. This is what I advised him. I said the same thing.
No, we cannot generalize. No.
Yes.
Yeah.
Perfusion scan.
It's a very valid point which coach sir made. That is,
Sir,
in
Jabras.
such scenario where you have got a borderline or equivocal TMD, the guidelines also recommend the class 1 test or the test which has got class 1 indication is stress echo or a stress nuclear imaging.
Okay,
I think we are
same, JP sir.
yeah, that is on the same thing. You're telling on aspirin prophylaxis based on CSC score. But I think that you have to look at the other factors also rather than blindly relying on aspirin prophylaxis, because up to a CSC score of 100, aspirin has not been shown to be beneficial if the other ABS-CD risk score is less than 10.
Yes, sir.
So you have to look at the ABS-CD risk score also rather than blindly looking at the CSC score and putting on aspirin prophylaxis.
Told that for aspirin, guiding aspirin therapy based on CSE, there is a difference of opinion. There is no clear data.
Only Chinese guidelines say that we can use it if the score is even 1.
Can I?
We are
just
yeah,
one,
running
one
short of time.
statement, One statement on sedation prior to PCI. See, if it's possible clinically from the patient side, I would rather not give any sort of sedation at all, because even the slightest suggestion of hemodynamics comes from the patient response. That is very important. Yawning, for example, these things are going to be affected by your sedation. So if it's possible, I will try to avoid sedation in any patient undergoing PCI.
One last question.
Last question to Pratap sir, desperately.
Yeah, Pratap. Pratap, yeah. Anybody want to ask any question to Pratap? Yeah, please. You have converted all non-believers into believers.
Good treadmill test. I think more than the ST depression or the delayed slopic ST depression on horizontal delayed ST depression on exercise. A more important finding will be ST depression in recovery. Usually, see that at 3 minutes and beyond that. First minute recovery may not show any change, but when 3 minutes on, you see the thing. That is more
Point taken. Yes, it's an important point.
The permission from director.
I think that can be the last last
audience can ask one question.
Last comment.
So we are talking about ASCVD risk. Can we apply this ASCVD risk in Indian population? Is there any data? There is a scoring for risk stratification. Is there any data? There is no data for calculate ASCVD risk in Indians. Do you have any? What is your opinion? All the studies are based on ASCVD, but the ASCVD is excluded in the population. It's only for whites.
So if you go for data, Indian data.
I want your opinions about this.
Yeah, that's right, sir. There is no Indian data. But if you go by that, we can't use any of these drugs, any of these interventions. Uris 3.
all the drugs are from wisdom.
No, we cannot take everything just based on the score, because ASCVD risk in young patients underestimates and older patients it overestimates.
Right. I would request the director to.
Okay, I think we come to the end of the session. It was wonderful. So all these speakers did a wonderful job.
Last book and photograph.
Thank you, everyone. This brings an end to Act 1. Moving forward, Act 2, Scene 1, Pacemakers and Devices. I extend a warm welcome to the stage directors, Dr. Praveen G. Pai and Dr. Shyam N. I would also like to invite the stage managers, Dr. Ravi Charian and Dr. Bijumon PR. I also request the first protagonist of the session to please take the stage, Dr. Jyoti Vijay. Over to the stage directors.
I think as we are running short of time, we will start in time itself. The first talk is on pocket closure and suturing techniques. That is for a refresher. The protagonist is Dr. Jyoti Vijay.
Very good afternoon to all of you, dear teachers and colleagues. So now we will be having a small session on pocket closure and suturing techniques. So we have seen the scenario given: a young cardiologist going to do a first pacemaker. So we'll be limiting our talk to pocket closure and suturing. So outline, we'll discuss briefly about the incision and pocket preparation, how to suture the leads, how to do a pocket isolation and wound closure. So patient preparation is paramount for a safe procedure. So we need to prepare the patient prior, especially if it's an elective procedure. Should you make the patient bath 1 day prior and in the morning, as well as we can scrub. Just we all will be doing just scrubbing before with an antiseptic solution. Shaving is not recommended, and the patient should have a wide bore IV cannula on both sides. And the left side, mostly we'll be implanting on left pectoral region. So left sided cannula we usually don't use. We only use for the contrast injection, and antibiotics is usually given through the right sided cannula. And a temporary basing intra-procedurally is advisable in CHV and indicated cases. We usually don't put for pre-procedural for routinely. And we can see there is actually, you can see two images. The other one on the right side is actually suboptimal. This can get displaced during the procedure. Just to note, temporary pacing routinely is associated with a more chance of developing device infection. So it's better to avoid if not required. And these are the equipments required. So it's comprehensive, but we routinely see it every day. So all these cases, we initially start with a local infiltration, especially make sure that we infiltrate in the pocket also, along the incision line and also in the pocket. And a deltopectoral incision, most commonly used incision, the advantage is that it gives you access for a cephalic vein also, and as well as the axillary and subclavian vein. Sometimes a horizontal oblique incisions were used more commonly, especially if you are making a subpectoral pocket. So this is what is the deltopectoral, deep is a deltopectoral incision, and other is a horizontal and oblique incision. So it should be a single line, adequate and confident, because the first step, and if this is gone, whole your incision, suturing, everything will be affected. And after that, there should be a layer by layer dissection. We should not be just cutting through directly into the muscle. We should be making a layer by layer dissection. For that, these two instruments are very useful. What is on left side is called a Wheatlander retractor, and right is a Metzenbaum scissors. So using this, we can actually do a layer by layer dissection, and especially if the patient is an antiplated post-PC patients, avoid splitting the prepectoral fascia, then you will see the bleeding spots across the muscle, and don't dissect the muscle then. So for better to make a pocket at the beginning of the procedure, because it will make some time, it will get you some time to control the bleeding, as well as leads will not get displaced if you make it later. And especially if you are making a submuscular pocket, then you can make it later. Sometimes, rarely, pocket has been bilateral. This is a case which a tunneling has been done from one side to the other. So these patients may need a bilateral pocket. That's a rarity. And we will not be going to a central venous axis and placement of the leads. So coming to the lead suturing. So it's a very crucial step for preventing the lead displacements. So one point we need to keep in mind is a lead usually moves in between the sleeve and the lead. So you need to fix the sleeve to the lead first, and then you fix that to the base. So while doing this, if the lumen lead, then better to put a straight slit at least half the length of the lead. So initially sutures are put on the grooves of the lead, tighten it, and then anchor to the muscle. So we can see a ventricular lead is fixed, and then atrial lead, you will push it, then you put the suture. First you tighten it to the sleeve, and then the arrow mark is a needle, so then you tighten it to the bed. A good current of injury, if you notice after lead suturing, indicates that there is a good lead positioning. And after that, you need to get slight tuck on the lead to see whether it is fixed adequately. And then you need to have a stay suture. So that is to prevent migration, especially in elderly females and in post-PD chain where already it is migrated. You have to just make it just not lax, not too tight. So that stay suture helps in fixing the device. You can see that it is not very tight. It is not loose as well. The stay suture. So before pocket closure, we should do a fluoroscopy of the pocket. That is to ensure that your pins are proper. Sometimes we even have seen cases where we had to reopen because the pins have not been inserted properly, and post-procedure interrogation you will find faulty measurements. So also you should make sure that there should not be an acute angle, there should not be a foreign object, and gauge count also should be done. So this is a fluoroscopy. So we can see acute bends there, not ideal. So common to all techniques of suturing is you would make 3 to 4 layers of suture, usually using an absorbable layer. Leads are suture of the non-absorbable suture. We commonly use the polyester suture for the as non-absorbable suture. So usually it's closed in 3 to 4 layers. First one is an interrupted suture layer, followed by 2 layers of continuous deep and superficial, and then a subcuticular layer. And liberally give a local anesthesia, it will make your suturing very easy. So interrupted sutures are given for the pocket isolation, and we can see here. It should be taken from the deepest part of the pocket. Too much tight, it can cause puckering of the skin. Too lax, it will cause exposure of the device. So at the end of this, pocket should be completely isolated. So pocket should not be visible. And corners of the pulse tender should be secured and isolated, and avoiding pressure points is very important. So you should take care of the edges, because most of the time the erosion occurs at the edges, especially medial edge. So this is one case which I have seen where because of the chronic pressure point there have been erosion. Then you can put the deep continuous suture. After putting an anchor suture, you need to anchor the continuous suture at both ends. And then you will put a deep and a superficial layer. And then you reach a subcuticular layer. Subcuticular layer don't add much to the strength. It adds to the cosmetic appearance. So make sure that your wound is strongly sutured before that. So our subcuticular layer is done with the absorbable monofilament suture, and you can use a knot-free technique. Like you may not have to use a knot there to end the suture. You can actually bury it. I'll show you how. So it's a subcuticular suture which is starting, where you have to anchor the suture at one end. Then you proceed further, and at the end you will take it out of the skin by burying the knot if you are producing one. So, and don't leave the final dressing to the assistant. After putting, you have to wash with betadine or clean with betadine, and then we usually put a steri strip and then an adhesive dressing with a gauze. And routine dressing is not recommended if you are using an absorbable suture, and day 9 or 10 you can remove it, and rarely patients do develop some allergic reaction. So we'll see a few images. So if you are not tackling the bleeder at the right time, the chest of the patient, there is a hematoma. Then as I have told, at the end of the wound you have to bury the knot. So it has not done, so there was an erosion at the edge, medial edge. This is an allergy to the dressing. It's another case where there is an allergy to the dressing. And sometimes it will not come soon. This occurred after 7 years of PG change. It was pus. And day 7, interrupted suture done at another center. So I just put this picture to tell about the color of the pus. It is red. So what may be the organism? This is actually Serratia mercescens. It's because of the prodigious and pigmented serratia. It's a red pus. And not to final slide, not all complications are iatrogenic. So this has happened because it is a PG change. You can see a scar. So patient has accidentally spoiled put the boiling water over the chest. So that's it happened. So this was a scenario given. Yeah, I think everyone faces this challenge when we finish your cardiology training. Where first pacemaker will face it. Maybe after 1,000 implantation also still we are continuing to learn. And safe implantation requires training, constant practice, and passion. So, for those who wish to read further about the detailed aspects of the suturing and procedure techniques, we had a recent article. Thank you.
Thank you, Dr. Jyoti. We'll have the discussion at the end. I call upon Dr. Anis Tajuddin for device infection prevention and treatment.
Good afternoon, everyone. Short presentation on management of device infection, also its prevention. Some aspects are already been covered by Dr. Jyoti Vijay in the previous presentation. But if you look at the risk factors for CIED or implantable electrical device infection, now it is There are many risk factors, but what we have found is that absolute rate of infection has grown in the last few years. This is because we are choosing more sicker patients for implants now, which include patients with diabetes, COPD, renal failure, aged patients. And then there are some procedural factors which are important, like device revisions and hematoma have a higher risk of infection, especially device revisions which you do within before the patient is discharged for any lead displacement or anything. If you do capsulotomy or removal of the capsule, when you do a reprocedure, there is a risk. Then there are device factors like non-pectoral implants, or when you have a more complex device implant in sick patients or because of prolonged procedure. Some of these risk factors can be mitigated by proper selection, like avoiding implantation when there is fever, or controlling diabetes, or removing unwanted lines, and adequate source control of infection before implant. Now, there are some new data on leadless pacemakers, subcutaneous ICDs, etc., which may be important when considering the risk of infection. Now, there are various scores which will help you predict the risk of infections. We need not have to go into details, but the PADIT score, for example, considered prior procedures, age, depressed renal function, and immunocompromised status, and the type of procedure. CRT has more risk of infection compared to ICD, like that. So based on the score, you can predict the risk of infection. Anyway, pocket revisions and device upgrades have a high risk of infection, in some studies up to 4 times the risk. And presence of anticoagulants or antiplatelet data, but however was not collected in the PADITS trial. So there are still other scores based also available. Basic to do is that, as I mentioned, shaving of the skin is not recommended. Electronic clippers are preferred. Topical antiseptics, we use either povidone iodine or chlorhexidine. There are some studies which show that chlorhexidine alcohol solution may be better than povidone iodine. Operating room sterility always needs to be stressed. Neat floors, minimal equipments, minimal personal movement within the field of or around the pacemaker procedure. Positive pressure ventilation, filtered air, etc. are very important. Especially training of personnel is very important. I always tell the nurse that you are responsible for an infection if it happens in the future. And I also ask them to wear my gloves. I mean, they will wear my gloves for my, so not touching the risk of infection, so that they are more careful. As mentioned, pre-op antiseptic shower or bathing is a general recommendation, either on the day of procedure or before. Site sterilization with alcoholic chlorhexidine is probably superior to iodine, and there is a strong recommendation for it. And in addition, you have to have good surgical technique, as already mentioned by Jyoti Vijay. Careful dissection, not going below the pectoral fascia, avoid blunt dissection of muscle, especially useful to avoid hematoma, which has a high risk of infection. So as mentioned, hematomas increase the risk by several fold, up to 7-fold according to some studies. There are various methods. I generally use electrocautery liberally for even cutting through the tissue and also for hemostasis. Now, oxygenated regenerated cellulose Surgicel is available, which may also reduce the risk of hematoma once there is increased bleeding. And there are 2 landmark trials, Bruise Control and Bruise Control 2, both showing that when you have a patient on warfarin or a NOAC, it's better to continue those NOAC oral anticoagulant and never to use heparin for bridging. The recommended INR can be up to 3.5. I generally do procedures with INR around 2.5. And if in case hematoma happens, prolonged antibiotics after the procedure, not just the initial 1 day or 2 day, is often required to reduce the risk of infection. And also never aspirate an hematoma. If there is a very tense hematoma, the patient has to be taken to the OT or to the cath lab, and under sterile precaution, surgical evacuation of the hematoma may be done, just like when you are doing a new case. About infection prophylaxis, general recommendation is only the class 1 recommendation is only for cefazolin, because the studies have shown that cefazolin alone is not inferior to more robust antibiotics, including vancomycin or post-procedural antibiotics. So post-procedure antibiotics, there is no recommendation for use, but generally in our settings, we give for 24 hours or 48 hours. When you are using clindamycin or vancomycin, in case of, if there is penicillin allergy or something, you have to make sure that those medicines are given around 2 hours before incision. But usual cefalozolins or penicillins, they are effective when you given within 1 hour before incision. Then there is the new development with antibiotic envelope, as you know, the Tyrex, which is found to be very effective, and there is a general recommendation to use this in patients with high risk of infection, like patients with skin disease, patients with compromised immunity or renal disease, etc. So in this study called RAPID study, which was published in NEJM, there was a 40% risk of reduction in infections when you use the antibiotic envelope. And there are other data from the same study which shows that anticoagulant use, antiplatelet use, or when you use a periprocedural vancomycin instead of cephalosporin, these are all factors associated with a slightly higher risk of infection. Especially that RAPID study showed that hematoma increases the risk of infection by almost 8%, 8 times. There is also new data coming on pocket irrigation. We generally give, I generally use vancomycin solution to irrigate the pocket before placing the device. And there are these studies with chlorhexidine gluconate pocket lavage in place of normal saline lavage, showing decreased risk of infection. Once there is infection happens, you have to differentiate between pocket infection and a combination of pocket infection with bloodstream infection. So for pocket infection, you have to do blood culture in all of them, whether you think it is possible infection or definite infection. Empiric antibiotic use should not be given. It should be only be given for superficial incisional slight inflammation. And if there is definite pocket infection like erosion, sinus, purulent drainage, it's all definite indication for device removal. In certain situations, you have to depend on TE, that if there is any bloodstream infection is suspected, or if there is no bloodstream infection or blood cultures are negative, then then the patient has possible pocket infection. FDG PET may allow localization of infection to the pocket. If there is no pocket infection and there will be bloodstream infection, you suspect CIED when there is 2 or more cultures positive for Staph aureus or Cons. Even when the patient has no pocket infection, these may be cultures repeatedly positive for Staph aureus or Cons indicate infection, and that may indicate removal of the device. Possible CIED is suspected when there is repeated cultures positive for non-staph bacteria, especially viridans group bacteria, enterococci, and some gram-negative bacteria. In those situations, you have to use transesophageal echo or FDG PET, but oftentimes these may be negative, and then you have to use your expert judgment on whether to remove the device. Possible CIED when there is without any blood culture, that is blood culture negative. TE is often not very useful because vegetations are not, the thickening in the TE may not be vegetation, but FDG PET may be useful. Again, the thing to do is device removal if there is definite CIED infection or there is valvular infected endocarditis with infection, whether blood culture is positive or negative. And many possible CIED infections will eventually turn to be definite lead infections and it will result in device removal based on clinical judgment. After removal, you have to give antibiotics up to 4 to 6 weeks minimum in case of valve vegetation, but 7 to 10 days in fit of pocket infection. And the new device timing is once the infection is settled. Blood cultures have to be repeated. I usually, even after removal of the device, repeat the blood cultures at 3 days. And after 3 days of negative blood culture, you can go with a new device. If there is valvular infected endocarditis, 14 days before the next device. Now, there are new options because we have now shown that in addition to temporum pacing, which we routinely use, which can be there for up to 2 weeks, you can use a leadless pacemaker, either as a bridge or as a permanent solution, and that can be done even immediately after there is removal of the device. And it is usually done on the contralateral side. The data on leadless devices show that with more than 3,000 patients implanted, there was no reported device infections in these studies, but in outside these studies, there have been reports of device infections. But even when there is bacteremia, no devices have been removed in the device exemption study by MICRA. And leadless pacemaker devices are a choice which is available now as a permanent solution or as a bridge. About the bacteria, I am not going into the details, but generally if there is infective endocarditis of the valves, device removal is recommended, often not done. Many people try to treat it. I just wanted to show a case of infective endocarditis, valvular pocket infection, without pocket infection, bloodstream infection in a patient with ICD. This patient is admitted with cardiac arrest outside. And the TE here shows finally that there is a vegetation. This patient actually had gram-negative bacteremia, Pseudomonas bacteremia, and finally candidemia. And it was advised explantation but was not willing. I think I have covered prevention, diagnosis and management, especially the new advances in leadless pacemakers and the relevance of complete CIED removal. Thank you.
Thank you.
I call Dr. Abhilash SP for the next talk about subcutaneous ICD, when and how.
Respected stage manager, stage director, and the principal director, dear Sajan, and all the august audience who have come to watch the show at the CSI Globe Theatre. 2-3 weeks back, Sajan called me to tell Cheta, the play is Device and Pacemakers, as you like it, and the act is for 8 minutes, and the scene is straightforward. And then I agreed. Immediately I agreed. Sajan says something, nobody refuses, I believe. And then he sent this script. 40-year-old officer in the Merchant Navy with ECG showing Brugada pattern. One episode of syncope while recovering from a short febrile illness. No VT on a 3-day ECG monitoring. Then since Sajan sent this, we need to read the line in between lines and look at the colors also. Anyway, it was sent in black and white, so there is no color issue. 40-year-old officer, so he's young. Anyone between 40 to 45, I consider as very young. Then he's a Merchant Navy officer. So that probably Sergeant meant that he has a good fat pocket. But he's away from home, Merchant Navy officer. So any event in the sea, there could be an issue. So we can't take risk with this guy. ECG showing Brugada pattern. I assume that Sergeant meant type 1 Brugada. But there are differences between Brugada syndrome and Brugada pattern. We'll come to it. One episode of syncope. Sergeant hasn't meant it's a resuscitated cardiac arrest. He just meant syncope and recovering from a short febrile illness. So it's not spontaneous Brugada. It is recovering from a febrile illness. So each point has validity in the evaluation. And a 3-day halter showed no VT, no ventricular tachycardia. Soon I realized that play is set as I like it. Then to act or not to act is the question here, whether he can be just kept on medical or whether we want to put a device. And for me, the scene is dark. So we need to evaluate him. The topic, if Sergeant had given me subcutaneous ICD alone, it would have been straight. But now I need to evaluate him. I am assuming that he had type 1 Brugada and arrhythmia related symptom, no. He had a syncope during fever. Inducibility of VT with PES, that I can do. Documented ventricular arrhythmia, no. Family history, since Sergeant hasn't given me, I assume it is not there. This is the evaluation pattern for a Brugada. Of course, Brugada is not my topic, but I quickly come to that second part, that is a subcutaneous ICD. History, ECG, provocation with sodium channel blockers, but I have to mention that we stopped doing this because we lost one patient, suspected Brugada, when we did Flecainide challenge. Recurrent VF happened and we couldn't resuscitate. So we are not, even the guideline says we are not doing it thereafter. Then we need to document type 1 Brugada, either spontaneous or after the sodium channel blocker, or you have to demonstrate it one space above. Then spontaneous type 1, cardiogenic syncope, we have to get a history. Cardiac arrest, we have to get a history. No questions, it's go for an ICD. Then if fever is there, give antipyretics, avoid Brugada inducing medications. Even though we say pill in the pocket for Flecainide, always screen for a Brugada. We may be giving Flecainide for the wrong patient. Then ICD and ablation, that is my topic proper. Ablation not. Ablation is reserved for resistant arrhythmias despite having an ICD and while on quinidine. Then this is a score. For our patient, we'll just calculate. It's a fever-induced type 1 ECG, score 3. He has a syncope unclear etiology and a score more than 3.5 suggests it's Brugada syndrome. It's not Brugada pattern alone, it's a syndrome. You look at the highest score ones. I have to go faster because of lack of time. But you see that spontaneous type 1 carries highest score. Unexplained cardiac arrest or documented VF is against high score 3. First or second degree relative gets a definite 2 score. This adds up. Even 3.5 says it's Brugada syndrome. This is only to diagnose. This is not for risk stratification. Then now the second question. This patient, 40-year-old young guy with enough finances, whether to put an ICD, I think that is clear. That is what Sergeant conveyed to me. He's away from home, Merchant Navy, so we cannot take risk also. So between these two is the question. Should I go for a transvenous or a subcutaneous ICD? Subcutaneous ICD, you know, we all know, like it does not have a venous lead. It's an outside battery and a shock coil outside the sternum. Then these are the advantages. We'll see where our patient fits into. The absence of leads within the heart and preservation of central venous system doesn't matter for him, but this is important for somebody who has a congenital heart disease or a vascular access problem. Then subcutaneous ICD carries a class 1 recommendation. No vascular injury or pneumothorax, that is advantages for our patient. Previous device infection, hemodialysis, immunosuppression, artificial valve, especially on the right side. These are all straight away indication for SICD, but not very relevant to our patient. Explantation is rarely necessary because it's not within the vasculature. An young patient, he's an young patient. He will recover it for quite a long time, and lead failure rates are actually as high as 5 to 10% over say 10-15 years. So young patient with an active lifestyle. And one more thing, he does not have a pacing indication. Normally 10% of Brugada can have a pacing indication, but normally it's not. The relatively simplified, of course, and we don't have to depend on a fluoroscopy cath lab also. We don't require fluoroscopy for subcutaneous ICD and can be done in any theater. And of course, the cosmetic advantage. Of course, everything is not rosy. Pre-implantation screening is mandatory. So we need to identify the vector. The company guy will come with a placement of a plastic electrical recording, which will look at the R wave height to the T wave height. It has to be at least 3 times more. It should not produce a T wave oversensing. So all patients are not eligible for subcutaneous ICD. Around 7% are not eligible. And around 15% of Brugada, because of the broad QRS and downsloping ST, may not be an eligible candidate for subcutaneous ICD. So we need to screen for that. Our patient, I am assuming that it was appropriate. Inappropriate shocks are similar. Undersensing is a problem with subcutaneous ICD, even though it's not, it's rarely only reported. Prolonged time is required, but most of the time we put it for structurally normal heart. No pacing ability is the main disadvantage. And atrial arrhythmias, of course, pulse generator is larger, and actually the life is less, and the cost almost 4 times, 5 times the cost. So no pacing capability, cost. I think none of this matter in this particular patient. So plan was to put a subcutaneous ICD. This is from a patient who underwent subcutaneous ICD. Anterior axillary line. This is the 5th rib, and this is your sternal parasternal incision. We'll go fast. I have only 1 minute. This is the chlorhexidine Anis sir was mentioning about. This is how we cover it. You can see that unlike pacemaker, you cover this aspect as well. You have the pocket here. Then this additional one is the trochas. I will come to it. And again, you have a longer shock coil, distal electrode, proximal electrode. And this is the first incision. Just make it like a pacemaker. And the second incision is made parasternally. Until you feel the external intercostal muscle. Then using the trocar, which I show you. Using a trocar, make a connection between the second incision to this. There is a 3 incision method also. Somebody put a 3rd incision also here. So make a connection. Then through that tube, introduce the lead to the pocket and here anchor it. Then along the parasternal region, you introduce the 3rd trocar or 2nd trocar for the remaining lead to be threaded over. That's how it is positioned. Here actually you need to be very careful, don't expose too much of skin. It can move around. If it is done, you have to make a 3rd incision to fix it. Then this is the emblem, only one, it's a Boston proprietary, and complete the procedure just like a pacemaker. And in addition to what Jyoti Vijay told, if the patient has enough finances, we can use this Arixta. It's a hemostatic powder. And this is also available, which contains rifampicin and minocycline, which Anis sir told. It costs around 70,000 rupees. So almost the price of a single chamber pacemaker. Then we have the knotless sutures also available for suturing. Anyway, that's a different day's topic. Then these things called a dermabond available for skin closure. Thank you. Sorry, I had to rush through.
Thanks. We'll have the discussion at the end. I will call upon Dr. Arun Gobi to speak on leadless pacemakers.
Thank you.
Respected Chair, friends, warm good evening to all. At the outset, I thank Sajan for the opportunity. And this picture summarizes what path-breaking revolution therapy of bradyarrhythmia has happened in the quality of life of patients, from the life of the person on the left-hand side who got the first conventional pacemaker implanted in 1967 to the traditional transvenous pacemakers that we implant to what patient satisfaction Micra or leadless brings about. So why do we need this is the gist of my talk. So traditional pacing systems that we all implant have been reliable, but still they have almost a 3-year failure rate of 15 to 16%. And that happens at either a pocket-related issue like pocket infection, hematoma, erosion, which is about 8% at 5 years, or lead-related issues like lead fractures, insulation breaches, venous thrombosis, tricuspid valve issues because of lead, which happens to the tune of 11% at 5 years. In addition, in this era where people want minimally invasive procedure and fewer post-implant activity restriction, leadless pacemaker is a boon which leaves no chest wall scar, no visible bump on the anterior chest wall. So currently Micra VR, which gives a single chamber pacer, is been indicated for paroxysmal or permanent high-grade AV block in the presence of AFib. In patients with sick sinus syndrome, it is an alternative to dual chamber pacer only if dual chamber pacing system is considered difficult, high risk, or deemed necessary for effective therapy. Micra AV, which provides VDD pacing, is indicated for patients who have paroxysmal or permanent AV block, in whom they will benefit with maintenance of AV synchrony, in whom they have adequate sinus rates. With this, it translates to almost a 66% reduction of complications compared to transvenous system with the leadless pacing system. Now, this 1.5 gram device, 0.8 cc device, has almost 8 to 13 years of battery longevity, is 3 Tesla MRI compatible, has auto capture facilities, has rate sensing facilities, also gives the ability of remote monitoring. Now, our interest in this therapy started off way back in 2017 when we had this elderly gentleman who came with resuscitated cardiac arrest. He was defibrillated. ECG showed AFib with complete heart block with an escape rate of 26. An emergency temporary pacing was put in. He was fully dependent on the temporary pacemaker, and the family was just not willing for the conventional pacemaker. And that's how our journey with leadless pacing started off with. So what we require is a single femoral venous access. You have the temporary pacing from the right jugular axis. So it's a 23 French delivery system, and from the delivery introducer sheath, we take in this delivery system and we take it from the right atrium to the right ventricle with a deflection button. And this is the areas where you need to be careful about. You check with the contrast injection that you're on the septal. It's all about staying septal. In the RA, you check whether you're in the mid septum or not. So you have to be in mid septal location. Always avoid the free wall and apical location. And with the contrast injection and fluoroscopic anatomy, you confirm that you are in the mid septum or the apical septum for sure. Contrast injection ensures that if you have a space between the site as well as the free wall border, you ensure that you're not in the groove. And once in the right side, it is just an unlocking the button. You press the device with that blue button on the front panel where you see. You press that button and that releases a very novel fixation mechanism which we call as a flex nitinol tines. It is quite different from the conventional pacemaker. This is an endoscopic view of what happens inside the heart. You can see the leadless pacemaker inside the trabecular right ventricle. And the beauty of this is it has almost zero dislodgement rates because of its novel fixation mechanism. It has almost 4 flex fit nitinol tines which go into the RV myocardium like sutures, and each of these tines have almost 8-fold the force required for holding this device in. And once it is implanted, it remains stable. It has stable electrical parameters, and once it is implanted in, you just check the electrical parameters, cut the tether, and you release the device. And this is what it looks like. Now, this was a de novo implant. This would be a leadless pacemaker, would also be a game changer for people who have complications with transvenous system, like people who have lead dislodgements, who have Twiddler syndrome, who have pocket erosions, who have erosions of the pulse generator, who have endocarditis on the leads like this, who have a lead thrombus with a PFO where it's almost at a high risk of stroke. If you have a lead fracture. So these are all conventional failures of the transvenous system like this scenario. 70-year-old complete heart block gets a dual chamber pacer in 2007. By 8 years, he gets a first generator change. By 7 years, he gets a next generator change. As the generator change goes on, his chance of infection goes up. And post-extraction of this device, what is the option? So this Micra is the way you treat these patients. So we would get the infected pulse generator out. We would get the leads out and get in a Micra placed in these kind of patients. And this is just a single venous access procedure. For thoracic outlet syndromes, for SVC syndromes, this is the way forward when you have a venous access issue. For patients with CKD, if you want to preserve the central venous system, this is the way you want to treat them. If you have severe TR, which would preclude a lead going across the tricuspid valve, go for a leadless system. So currently, leadless systems are indicated for patients who have complications for transvenous device, who have higher risk of infections, who have anatomical vascular issues, who are elderly, who have a patient preference, and especially in patients who have infrequent pacing. Now, what do the evidence as well as the real world data show? It has almost 99% implant success rate, 0% dislodgement, 0 infection rates, mean implant time is just 28 minutes. It has absolutely stable thresholds and very low thresholds which remain stable over time, and the VDD pacemaker Micra AV gives almost 80% AV synchrony. Now, if you want to look at safe practice, it's all about avoiding complications. 2 important complications with leadless pacemaker is cardiac perforations and AV fistula. So about vascular access, it's all about ultrasound guided access using a micropuncture, use a balloon tip TPI and go for a figure of 8 kind of closure. Regarding cardiac perforation, it's always about understanding high risk patients, getting into the right ventricle slowly, go low, go slow and pause once you across the tricuspid valve, and always ensure that you're deploying the device in the interventricular septum. So with this modifications from going from apex to septum and identifying the risk patients, we have actually reduced the risk of cardiac perforations from 1.8 to 0.8% over time, which is almost equivalent to transvenous pacing systems. And this is the risk scores that have been developed from the trials. So we know that elderly patients who have COPD, female patients who have BMI less than 25, patients on oral steroids, they have a high risk of perforations. And in these patients, don't go for multiple deployments. You have to minimize the recapture and redeployment. The key here is patience. You need to wait for 3 to 5 minutes, ensure and don't go for magical numbers, accept a threshold somewhere like 1 to 2 volt, because even a 1.5 volt has a longevity of 9.6 years. And regarding placement, you always try to avoid the apex, inferior aspect, RVOT or free wall. Mid-septum is the ideal position. You need to take the lateral view, which will give you a game, it's actually eye opener, because 20% of devices placed septally on LAO look anterior on the lateral view. In the lateral view, the cup should be directed towards the camera, not towards the sternum or towards the anterior surface. And this RAO space sign is where you inject contrast on the RAO view. You actually find a space between the catheter tip and the chamber border that confirms that you are not in the groove and you are on the septum. So this is the space sign that we are talking about. Now, when you are deploying this device, you need to ensure that on the LAO, when you are pushing this device, you are becoming perpendicular septum. That ensures that you are septal in contact. The direction of the catheter should always be pointing towards spine in LAO, should be away from the spine in RAO, and should be towards the patient left in AP. When you inject contrast, you again look for whether you're in the trabeculated space or not. And when you look at the contrast flow, if there's a definite flat flow pattern, it indicates that you're in septum. Well, if you have a free flowing contrast like this, you are definitely in the free wall. And the shape of the ring, it should ideally be oval if you're on the septum. It should be a circle if you're on the anterior wall. You can use echo to guide your deployment, either transthoracic or intracardiac echo. Like this is an echo guided positioning in the free wall. This is an echo guided positioning on the septum. And this is an RV angiogram which you can use in difficult anatomies. And the future would be CT integrated into your fluoro to guide your placements. So I would conclude with our own experience at Metro with leadless pacemaker. Leadless pacemaker has absolutely niche indications. So in the last 7 years, from January 2017, when we implanted our first device, we have implanted only 27 micras till now in the last 7 years. About 6 were actually dual chamber micras, 21 were single chamber micras. Indication specifically, almost 25% of them out of 27 had AV blocks. Only 2 had 6-sinus syndrome who were extremes of age. And 5 of them had failed transvenous system. The average procedure time was 29 minutes. The fluoro time was 14 minutes. We have absolutely stable thresholds on follow-up, almost 0.5. And with 7 years of follow-up with the first implant in 2017, we still don't have any replacements done, no retrieval done for anyone, no infections absolutely, and no device failures. Only 1 patient had a mortality that was later on due to heart failure due to AR. So all this has been happening because of wonderful team that we have, and we were happy to have the first single chamber implant in our state and the first dual chamber implant in the country. So that's all about leadless pacemakers.
Good evening. Thank you, Sajan, for this magnificent ensemble, first up. And thanks to CSI for the opportunity. So let me get started without delay. So my job is to try and make this simple. So here's the example. I won't stick exactly to the example, but this is a patient in whom we want 100% biventricular pacing and 100% biventricular capture. That much is obvious. So we're going to look at that. So let's take it step by step. These would be the 5 things that you would look at if you were to look at a CRTD interrogation. The first step, it's just like a pacemaker. Are the lead and the device parameters normal? The second 2 are very specific for CRT. Is there adequate biventricular pacing and is there adequate biventricular capture? Pacing doesn't mean capture. Biventricular capture means you need synchronized capture of both the ventricles and the atrium, which can generally be determined only on an ECG. The interrogation will not tell that. Then, of course, the bugbear or the nightmare of many of the cardiologists. Have there been any tachyarrhythmia episodes, any alerts, and a big bunch of graphs that they bring, which mostly mean nothing. So the device parameters. So what I put in green is what I'd ideally like to see. But what I put in black is the recommended normal range, right atrial impedance, right atrial threshold, P wave. What I mean is, if it's somewhere between that green and that black, I would prefer to call this patient for interrogation a little more, early. Whereas if it is, less than 1000, if all those numbers are in that green, I don't mind calling this patient back much later. But if those numbers are somewhere between the green and the black, I would like to call this patient for interrogation a little early, because those are numbers which are okay but still make you feel a little uncomfortable. Same for the right ventricular threshold. Just understand that the R wave, the Biotronic amplifies R waves more than the other systems. So if you implant a Biotronic ICD, the recommended R is 5. If you implant any other ICD, the recommended minimum R is 4. I've used the same principle here. Less than that green number, I'd be very happy. Between the black numbers are the normal numbers, but between the green and the black numbers, I would prefer to call the patient a little more frequently for repeat interrogation. Now, when you come to the RV impedance, if you are looking at Medtronic ICDs, there are two ways in which you can pace the right ventricle or you can sense from the right ventricle in Medtronic. You'll get two numbers in Medtronic. You'll get what's called RV bipolar impedance and RV tip-to-coil impedance, and a graph representing both. Now, first up, make sure you look at the whole graph, not just one number. Every device gives you a graph, so look at the whole graph. Okay. Now, this is how the ICD senses. It can use all of these things for sensing, but all ICDs except Medtronic look at only this polarity for sensing, for the R wave. Okay, these are used for discrimination. Think of these like the ECG. These are look for discrimination to decide whether it is SVT or VT, and this is of course variable sensing. But in Medtronic, there's this additional option that you can use this particular vector for sensing. That's called the tip-to-coil vector. It has plus and minus. The plus is you are sensing from a bigger area, so you get a bigger R wave. The downside is, if you do program to tip-to-coil, you might as well call the patient more frequently for interrogation, because it might cause a little bit of over-sensing. But just to be familiar, if you look at any Medtronic ICD, if you look at the impedance graph, you'll find both these graphs, and this is what those two graphs mean. Now, this is what you'd ideally like to see. Now, the P wave is solid, so it's color coded. The P wave is pretty good, the R wave is solid, pacing threshold is solid, shock impedance is good. So this is ideal, but that doesn't happen all the time. What about this particular patient? The P wave is up and down a little bit, and more importantly, that some of the P waves are not sensed. Is it okay to not sense some of the P waves? Why does it not sense some of the P waves? And none of the R waves are sensed. So RV is the light blue. There is no light blue line here. So why is this? Very simple. Patient has complete heart block. If the patient has complete heart block, the R waves may not be sensed. Now, what I want to tell is an extrapolation of that. ICDs sense R waves somewhere around 12 midnight to 1 p.m. They just inhibit pacing for a short period. Not inhibit, bring it down to a particular number for a short period. If at that time a P wave or an R wave occurs, it will sense. If at that time it doesn't occur, it will not sense. So it's perfectly okay not to have this, if provided you say that it is predominantly paced. But if you see a lot of dropping in a patient who is not predominantly paced, then there's a problem. You need to investigate that. And what is worse is, in a patient who's 100% paced, what you might sense as the R wave may actually be a PVC which happens between 12 midnight to 1 a.m. And you might get a huge fluctuation of R wave. So what I mean to say is, if you have a 100% paced patient, if you have a huge fluctuation of P and R waves, don't bother too much. It may be just an ectopic beat that is sensed. But bother if you get a huge fluctuation in a patient who is virtually sensed all the time. The defibrillator impedance is basically the impedance of this or this. And once again, I put the numbers there. This is the normal number, but any number beyond 100, I'd be a little worried. I would call the patient for follow-up a little more frequently. Now, always remember to review the trends. Now, this is a patient who had interrogation at this point. 10 days later, he came with a shock. Actually, 9 days after that, his lead parameters had gone up. You can see the impedance has suddenly gone up and then gone up to 3000, then come down. Simultaneously, the R wave has come down. There is nothing that's happened in the defibrillator coil impedance. This means that the pace sense coil has fractured. If this is a DF1 lead, well, if you want to, you could just replace the pacing part. LV impedance can be all over the place, especially if you program to unipolar. You can't really put a normal number to it, even though that's the usual number. Same with LV threshold. You know, you might accept a higher LV threshold because you want better resynchronization from a particular polarity. So don't look at LV threshold in isolation. Try and find out what the LV threshold was at implant and try to compare with that. The operator might accept 3.5 at 0.7 because that gives the best resynchronization. You don't put LV leads for threshold. You put LV leads for resynchronization. Look at the percentage of biventricular capture. It should be more than 95%, as close to 100% as possible. So these are all good. But if it's less than 100%, find out why it's less than 100%. In this particular patient, it's 96% and that's fine. It's because 3% PVC. So that's okay. 3% PVC is not such a big deal. Whereas in this patient, BIV pacing is 0. Perfectly fine. Look at the indication. It's a young patient, hypertrophic cardiomyopathy with a long PR, narrow QRS. CRTD has appropriately been implanted for secondary prevention. It's appropriate to implant a CRTD here because it's very likely that he will develop VT in the future and it's very likely it will be difficult to ablate that VT. So in that context, it's okay to have less BIV pacing percentage. Another common reason is sinus tachycardia beyond the upper tract rate. So if you have less BIV pacing percentage, look at the episodes of tachycardia. That this is what you'll see, sinus tachycardia beyond the upper tract rate. Yet another reason will be multiple episodes of AVIP. So all of these need to be treated. And this is another thing. This is an atrial tachycardia with a 2:1 conduction. It's not really mode switch, but it's 2:1 conduction. So look at all these causes of loss of BIV pacing. Just one thing when you hear this one says multiple episodes of monitored VT and 1 episodes of AFib. Just understand that the monitor zone arrhythmias are not discriminated. That is, if you have an arrhythmia in the monitor zone, if it reaches a counter of 130, it says there is a tachycardia. It will always call it a VT. It not necessarily have to be VT. In a monitor zone, it will not try to differentiate VT versus VT. So if you see something called monitor, ignore the first part. It does not necessarily have to be VT. It just means a monitor zone tachycardia. ICDs do not discriminate in the monitor zone, but this is very important. Ensure biventricular capture on a 12-lead ECG. And finally, the nightmare of many of the cardiologists, any tachyarrhythmias. You must look at the electrogram of every tachyarrhythmia. The first patient says slow non-sustained tachycardia. Second one says one shock for VT and multiple AFib episodes. So small examples. First thing is understand the annotation. So these are what they mean. AP means atrial pacing. AR means an atrial event which will be count for discriminating SVT versus VT. But it will not be tracked to the ventricle. AB means an atrial event which will not be count for discriminating AT versus VT. I'll show you the importance of that very soon. Okay, you have to understand what's the difference between AB and AS. Now, this is obvious. TS is tachycardia sense. TD is detected. TP is antitachycardia pacing. CE, charge enabled, charge delivered. This is obvious. More V than A is VT. VS or TS occurring in a patient with complete heart block, like here is VT. Okay. And I'll skip these. Just last one point I want to say, having an atrial lead does not ensure that the diagnosis is correct. So this is what I was coming to. So in this tachyarrhythmia, the ventricular lead says VS, 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 and there is nothing on the atrial channel. So as far as this device is concerned, this is a ventricular tachycardia going on. There is continuous V without any A. So this is the importance of looking at the electrogram. You look at the electrogram, there is an A corresponding to every V. So this is because the A falls within the blanking period. There's something called blanking period. After a ventricular sensing, within the first 50 milliseconds, as far as the device is concerned, nothing exists in the atrium. So don't just believe on the interpretation. Always look at the electrograms. Another example of why you should look at the electrograms. This is far field sensing in the atrium, low frequency. This is near field sensing in the atrium, high frequency. So the actual rate is only this much, but the device says that rate is this plus this. So I'll stop with that because it's too complicated to go through all interrogations. And the last thing about graphs, one word, don't bother about them. This is something which the industry made up to sell their products. Now, if you look at all the other things, the graphs per se don't make much sense. Thank you.
Thanks, Ajit, for delineating that topic very nicely. I will ask you to stay on stage and I will call upon all my actors here. Jyoti.
I request Dr. Jyoti Vijay, Dr. Anish, Dr. Abhilash SP and Dr. Arun Gobi to please join Dr. Ajit Tachal on the stage. The stage is now open for discussion.
So I will start
Dr.
first
Jyoti
with
will-
Dr. Jyoti. Jyoti, you have done very well explained about the ways in which pacemaker has to be done in a fresh setting. Unfortunately, your patient is already on TPI. So you and Anis had both told that for reducing the infection. So what all you will do in a patient who is already on TPI? You cannot do the scrubbing and other things properly. So what is the importance? I want everybody to understand. That's why I'm asking them.
So when
Patient is already on TPI in CCU.
So when someone is already on TPA, first thing is minimize the duration on TPA. So it's better to do a permanent pacemaker as early as possible. That's the first thing. Second, minimize the complications associated with the TPA. Can give anticoagulation, heparin, antibiotics, prophylactic antibiotics, all those things. And if you are expecting a longer duration, switch over to a semi-permanent pacing through a jugular route, which will be better and patient can even be mobilized.
What is your preferred antibiotic also?
With one TP, I generally tend to give a dose of antibiotic if the patient is 1 day prior to the permanent pacemaker, and then on the day of pacemaker, another dose 2 hours or 1 hour before the procedure. Antibiotic I usually give is cephalosporin, usually cefazolin. Sometimes I use Magnexport or Viat, this cephalosporin sulbactam. And high risk patients, I add vancomycin or something.
I just want to ask, I have come across hematomas. So how do you usually manage the hematomas? Because our CTO surgeons, usually they ask just to aspirate it and keep it. And usually we get recovery. And we have sent for cultures which are usually negative and CRPs are negative. And but still we get along with it. So people were telling like you want to re-explore it and do a drainage.
No. As fast as possible, don't re-explore unless it is very tense, causing so much pain, or there is a risk of skin erosion. Only in that situation you should re-explore and never aspirate, because sometimes you may introduce skin bacteria, usually coagulation negative staph, into the hematoma if it's sterile. So generally don't aspirate. You can re-explore only if it is needed, like very tense hematomas. And
So
also
how
avoid
does-
Chimerol Forte or anything which can lyse the blood. And usually I don't give anything. I just give antibiotics and pain relief medications. And usually it settles down if it's a moderate amount of hematoma.
And how long do you give the cefazolone? Because outside India they usually don't give antibiotics post procedures, but
we are not used to that kind of setup. So I generally prefer 3 doses of at least 12 hours apart, prophylactic dose, 3 doses, or at least more than 24 hours. That's the then I stop.
I just want to add one point, sir, because regarding the re-exploration, as much as possible, it's better to avoid re-exploration, because re-exploration before discharge is the strongest factor which can cause infection, almost odds ratio of 33. So that is the strongest factor which can cause infection. If you open 1 or 2 times, it is going to get infected.
The numbers are like for a regular pacemaker, infection rate is 1%. The moment we put a needle or a blade, it is 6%.
Yeah.
Regarding the leadless pacemakers, you are telling like the micro pacemakers. So what are the complications? Like have you had any in device displacement, and what will you do for battery change?
Okay. So 2 important aspects. One is the complications. As I said, the major complications are vascular access issues and cardiac perforations. Dislodgements are absolute zero. That's the beauty of this device. Till now, in the trials, in real world, dislodgements, if during the procedure it has not happened, late dislodgements never happen at all, because of the novel fixation mechanism, which has this 4 tines in. Each tine has 8-fold the force. So even we would only release the device if there are at least 2 tines are well held. So if you have 2 tines well held, that means you have almost 15 times the holding force for the device. So dislodgements would never happen. The next aspect was end of life care for Micra or any of the leadless pacing systems. So Micra is one novel device in which it gives you the ability to switch it off. No other pacemaker gives you a programmable option of switching it off. Micra has the beauty that it can be switched off at the end of life. So Micra, the volume that Micra takes up inside the cardiac chamber is just 1% of the heart volume. So in an autopsy specimen, they plunged in Micras and they found that almost 100 Micras can be put in. But in live specimens, what they have done is they could comfortably place 3 Micras inside a heart with no interaction at all. So at the end of life, what is recommended is you switch off the device, implant another Micra. The newer leadless pacing systems that are coming in like Avir have a retrievable system along with it. The same has been used for Micra also. You can retrieve Micra only if as there are case reports of infections which have been reported, not for actual, not inside the trials, but outside trials, there are case reports of infection which are reported with Micra. In those, you can actually retrieve it with the Avir retrieval system, or you can have a home generated system where you use an Agilis deflectable sheath and a conventional 3 mm end snare, and you can retrieve it. There's a proximal retrievable feature or a cap on the Micra which allows you to capture it and retrieve it.
Okay. Thank you. Thank you very much.
Yes, sir. I just want to ask you, your case scenario was like the same thing, case scenario. Let it be a person who is young fellow, 30, 35 years, who is going to the gym. He developed a syncope. He has come to the cardiologist. He has never had a syncope, no family history, nothing. Cardiologist has seen it. It's a Brugada type of ECG.
Type 1.
And,
Type 1.
Type 1. Then what happened? He doesn't have any history of fever, nothing. And he's showing an LV dysfunction. It's a global LV hypokinesia. So, and Holter was done, no VT. How do you go forward?
LV dysfunction etiology?
I don't know. Just, it's a.
But he had a Brugada pattern.
He had a Brugada pattern and a global hypokinesia.
Coronaries were?
Just mild.
Coronaries were?
Normal. And he has a VT, no episodes of VT in the Holter. Holter was absolutely normal.
Any cardiac MRI could be done?
No.
I think we should do a cardiac MRI.
Cardiac MRI.
Cardiac MRI.
Right. I think we'll conclude. It's time. The last bow, please, and then we'll go on.
I will congratulate everybody for doing a good job by sticking to the time and explaining the factors. And we'll have a.
No, it's okay, please.
Excuse me, Dr. Arun. Dr. Arun, the cost of Micra, specifically the single and the double chambers.
So single chamber Micra cost around 7 lakhs or so. Dual chamber cost about 9 lakhs.
Okay, thank you.
Thank you, everyone. Moving forward, Act 2, Stage 2. Sorry, Scene 2. Gadget Corner. How do I use? I extend a warm welcome to the stage directors, Dr. P.K. Ashogan and Dr. Sunita Vishwanathan. I would also like to invite the stage managers, Dr. Srikala P. and Dr. Sandeep George. I also request the first protagonist of the session to please take the stage, Dr. Shafiq Matumal. Over to the stage directors.
So I think this is a very interesting session. It's a gadget corner. How do I use? I think this actually only 4 people talking. Bahulan sir is not there.
Sir has got a respiratory infection, is down. So he has conveyed.
We have sufficient time and all the gadgets specialists are here.
But yeah, we would like to use that 10 minutes so that we can move on to the next session.
Oh no.
Yes, we are not extending the time for discussion.
That is
we
not
want
fair.
to stick on time. As per the secretary's.
So I think the first talk is on ultrasound for vascular access. That's the in thing now, I think. Shafiq.
Yes, ma'am.
So please go ahead. The stage is yours.
Good evening.
The stage is yours.
Thank you. Good evening, everyone. And I think this idea of stage and everything is going really well, Sergeant. Congratulations to the whole team. So we have been doing interventions now since more than 5 decades, and over a period of time, we have achieved gradual reduction of access site complications, which took around 3 to 4 decades, and now it has come down to a very dismal amount even after the experience, and even with the large bore access as well, we have achieved now achieved significant reduction in access site complication, as because it's extremely important to have less, as they are associated with definitely increased hospital stay, increased mortality as well. So the complications can be dissections, stenosis, perforations, or formation of pseudoaneurysm, which all have long-term treatment implications. Now we have seen a paradox. Paradoxically, increasing rate of femoral artery complications because of the new generation who are under training, are getting trained in radial interventions during their cardiology course, and now their expertise in the femoral interventions is coming down, and then it has now an issue that is to be addressed, as well as it is important to have safe access procedures. So there comes the role of ultrasound guided punctures, and which in fact it has many advantages, like it can differentiate between veins and arteries. It identifies specific an arterial location or anatomical location where you can identify the branch and precisely pinpoint the puncture location. It can see whether there is a calcific wall, calcium on the walls of the puncture site, and we can avoid certain areas. It can actually, we can see the needle movement in real time during puncture. It is easily available. It's not very expensive. It precludes the radiation exposure. Even though it has a learning curve, it is actually an easy technique to adopt if you do it regularly. Do we have sufficient evidence to say so? Yes. In patients in PCI trials, there were many dedicated studies, and one of the meta-analysis showed that there is a statistically significant reduction in vascular complications and access site hematoma, and non-significant reduction in bleeding complication in PCI trials. So when it is seen in TAVI trials, large bore access, it has seen a significant reduction of total vascular complication, including bleeding complication. So they also concluded that in the absence of randomized studies, their data suggest a potential benefit of ultrasound guidance and recommend ultrasound to be an essential tool in the cath lab access. So it is important to note the anatomy, and this is actually the zone where we would like to get the safest puncture. So we need to puncture over the center of the femoral head, where it can be compressed easily immediately after removal, or if there is a bleeding after closure devices. So a higher puncture above this may lead to retroperitoneal hematoma, and a lower puncture below can have complications like pseudoaneurysm or AV fistula. So let's see what do we need in the cath lab. So what we need is a linear ultrasound probe, an ultrasound machine usually which is portable, a sterile ultrasound gel if available, or if not, we can fill the unsterile gel in the sterile plastic sheet, and we can add little sterilium morbitudine in the skin, which will increase the ultrasound quality, and the needles specifically related to the procedure. And it's a good idea to mark the site of the lower end of the femoral head in one fluoroscopic shot, and mark with the artery forceps. Then we can do the further puncture. You can have the ultrasound screen in front of you, and this is the sterile cover which holds the probe. And now you are comfortable, and if you have a person to assist you, you can have the screen adjusted, the size, the recording, everything can be done. Now, how do we do this? The probe definitely has a marker here which need to be identified, and hold it vertically, and it is facing upwards on the femoral artery. So in the first, we get a longitudinal view of common femoral artery, and then you can trace and find out where exactly is the bifurcation. So here a gel is applied, and our femoral artery is palpated, and you place it in the longitudinal fashion. And once the artery is identified, identify the bifurcation, the point of bifurcation in the ultrasound. This is one advantage of ultrasound guided puncture. And then rotate counterclockwise, and you see a cross-sectional view with femoral bifurcation. The next step is move the probe cranially and choose a puncture site which is free of calcium. You can see here the anterior wall, there is no calcium here. Now, this is the common femoral artery. You can see certain calcific element here in the posterior wall, but anterior wall is free, and that would be an ideal location for puncture. The next step would be to give the local anesthesia, and after that you can do puncture. You can see that live. You can see the tenting over this dome of the artery, and you can complete the process of arterial access by wiring. We can actually use the standard 18 French technique, or we can use the micropuncture technique. We can use this for ultrasound guided venous puncture as well. This is a left-sided femoral vein taken before a TAVI access. So ultrasound guided access, and we can safely access the vein as well as the artery on the contralateral side here. And this is done by an 18 gauge needle, and on the right femoral artery, a micropuncture set is used. So using the micropuncture technique, we initially take the access in the same method that we just saw now, and after the micropuncture, the thin wire, guide wire, is inserted into the femoral artery. Confirm the femoral artery position in the wire position in the fluoroscopy, and then we exchange advance the catheter and remove the wire, and then take the 038, 035 wire, short wire, and go with the access that we require for the intervention. Sometimes with the micropuncture technique, you might feel kinking or difficulty in advancing the catheter, especially in those with those who are obese and a lot of subcutaneous tissue. Sometimes you may form bend on the PTFE wire, then it will be very difficult. Then one technique is to cut here and cut the tube and advance the short tube vertically, and then advance the bigger wire. This ultrasound guided method can be extrapolated to practically any arteries, and this is one where I used to puncture the popliteal artery for a retrograde access when the antegrade attempt for CTI angioplasty failed. And again, this can be used for transaxillary also. In the axillary, you point in the longitudinal axis, you point the probe towards the chin of the patient and find out the longitudinal axis, rotate, you see the cross-sectional artery, cross-sectional view, and move out and find the lateral thoracic artery, and outside that make a puncture, ultrasound guided, and then you can go with the procedure. To conclude, positive results from data regarding the effectiveness and safety of the technique argue in favor of routine ultrasound use for gaining femoral access. Ultrasound guided femoral access is likely to benefit more with the large access procedures like TAVI, EVAR, and mechanical circulatory support system. Ultrasound guidance as a procedure has a steep learning curve, but it can be a part of the, it should be a part of learning or teaching technical skill to be taught in contemporary interventional cardiology training. And every operator should develop the proficiency in this technique to limit access-related complications and improve outcome. Thank you. Thank you so much.
Thank you, Dr. Shafiq, for the excellent talk. We'll have a discussion at the end of the session.
Thank you.
We now invite next speaker, Dr. S.M. Ashraf.
Ashraf is talking on he's become professor and head Pariyara Medical College, Calicut.
Change. Respected chairperson and senior colleagues and my dear friends. First of all, thank you, Dr. Sajan and Dr. Shivaprasad sir for giving this topic. This is relatively simple, but I will go only for the practical aspect. There is nothing theory on this. There is a guide extension catheter. Everybody is using this. So this is a case given to me. That was case at 1 a.m. Previously, we were doing the primary those days, but for the last 5 years never, except yesterday only. I did at 10 a.m. because of my close friend at MI. And this anterior STEMI primary, LV dysfunction, calcific CAD in type 2 diabetes, TUF primary, middle AD lesion, stent not tracking. So this is the case given by Dr. Sarjan, and I will give the answer at the end of my talk. So the clinical use of guide extension catheter to facilitate the smooth equipment delivery, to the design aids in allowing the device delivery in the complex and tortuous lesion. This very beautiful engineering technology to how the catheter is designed, and there is a metal tube is there, and distal 5 to 15 centimeter flexible plastic tube is there, so that will go through the vessel very easily, and there is a transition. Also there is a physics in that, and you go there, it's a beautiful engineering technology, and that facilitates easy travel of the stent. So device function provides coaxial alignment with the increased backup support. So there should be a coaxial element. If you take the ambulatory catheter, there will not be much coaxiality. So for example, right side, better will be the JR catheter rather than the ambulatory side. So usually better useful to transradial approach, anomalous arteries, and any situation with the guide back out. Create pathway for the PCI, especially complex lesion, the calcium diffuse lesions, and tortuous vessel and distal lesions. So our case is all these things, because it's calcium with the diabetes, diffuse everything with a distal location. That is middle AD case. So there are a lot of guide extension catheter. The guideline V3 is available now. We have been using the V2, that's the Teleflex. GuideSlide 2 from the Boston Scientific, Hartle 2 from the Thermo, Telescope, Medtronic, the earlier available easily. Now it is not much available. The trap line, there is a Teleflex, there is a beautiful technique, there is a balloon there, and that will trap in the vessel, and you can use as a guide extension. And Guide Plus Nipron and Guideon, that is a European product not available in India frequently. So if you compare different products, notice there is not much difference. We have been talking about Guidezilla, Guideline, all these, and nothing, only 0.01 French. And so whatever available, it's okay. So to me, there is a 5.5 French available, that is guide extension for the guideliner. So that will be easily available. That can you even use the 6 French. So in our case, we can use that. If you are using the radial, you can use the 5.5 French. If you see the guideline V2 and Guidezilla, not much difference. Only the engineering technology, that's coating, silicone versus hydrophilic, and all polymer column versus stainless steel. The only difference. Otherwise, outer diameter, inner diameter only hardly matters, and flexible. The Boston people are talking about Guidezilla, but I don't think so. Whichever guideliner catheter, guide extension catheter is friendly to you, use that. So the other user to improve the coaxial element, the backup support the guide catheter. To deeper the intubation length, the greater the support. Requirement 5 mm guide catheter and 5 to 15 cm gauge for the GEC. This was we are debate in the Dr. Ronnie Matthew, the previous discussion, how much and all. So at least guide catheter has to be 5 mm, and guide extension catheter has to be from the 5 to 15 cm. Whatever extension you can go, that will backup support will be there. If your guide catheter is outside the vessel wall, the benefit of the guide extension catheter is not there. At least 5 mm inside your catheter. Otherwise, ambulatory catheter, the opposite wall gives support, then it's okay. So the facilitation, they're using a balloon for distal anchor, that is balloon surfing technique or balloon trapping technique there. Inchworming technique using balloon assisted tracking technique. I will prefer the inchworming. That is when half of the balloon is in the guide extension, half of the balloon in the vessel. The advantage is you are in the distal anchoring, you are pulling back the balloon after deflation, and the guide extension catheter is going along the vessel. Most of the time there will be calcium tortuosity. So that will hit on the calcium plaque and that can cause dissection. Whereas inchworming technique, it will be you are deflating the half of the balloon inside, then you can go. So the catheter going the coaxiality into the central lumen rather than the vessel wall. So there will not be injury, and if there is bend and turn, it will dissect there. So I think for all these people, my personal approach to injury, you all also follow, please, because whatever the theory and the practical thing is there, injury is better. So this is just this is basically, it is not rather injury, rather balloon surfing. So I just giving that example. Even the catheter is a little bit away. There was a lot of issue because the vessel is horizontal and chamfered and a lot of tortuosity. But even 10 mm inside the catheter, that make a huge difference for the tortuosity. So the support the use of threshold for using the guide extension catheter has to be very, very low. You have to use at least 10 to 20% of your practice in especially these difficult cases. So the other uses like selective contrast injection, it can improve the vessel visualization and minimize the overlap with other vessels that can complicate the image interpretation. Also help to limit the contrast usage. It also improves the OCT imaging quality by ensuring adequate blood clearance. But I don't agree this, because if there is catheter, there will be some pressure, extra pressure has to be there. So that is not much, even though people are talking about this. And other use can help deliver drugs distally, especially no reflow situation, just like in our MI, in 1 AM, we can still use this case with this catheter. So what about calcium bifurcation? Sajan has mentioned the calcification. If there is a very huge diagonal coming, you can use this and also guide extension, and you can stage. Suppose if there is need for rotablation as a stage procedure, you can use 2 wires and one guide extension catheter. Through that, you can use the one rotablator, because the rotablator you should not use the additional body wire or additional wire. It can cut that wire. So in that scenario, you can use the guide extension catheter very, very rarely. In heavy thrombus, GC can be tried for thrombectomy after dedicated aspiration catheter is failed. So it has a larger inner lumen. Anecdotal reports are there. We can use that guide extension catheter. But we have now the product has come, like our Indigo catheters come. So we can use that. Now the retrieval of lost device. The surgeon mentioned that stent is not tracking. If there is loss of stent, there you can use the guide extension catheter trapping technique. By trapping the lost stent from within the NC balloon into the guide extension catheter was used to retrieve a lost stent from the LED if it is happened. So what about role in CTO? Dr. Pradap Kumar, yes, it's in front of me, but the Kovais reported the use of guideline catheter the balloon uncrossable CTOs. So you can use that uncrossable. You can dissect there and you can enter further balloon and all. That was the very remote possibility. GEC can facilitate entry of retrograde catheter with the antegrade catheter when they employing the reverse car technique. Also Rendeau's technique also, you can add the catheter to micro catheter to guide extension. So guide extension catheter in aberrant vessel PCA. Suppose aberrant vessel from the RC coming from the left side. You have used JL catheter, everything you tried, at least you are not trying to enter. Then you can use the JL or EBU3 or whatever, then use the guide extension catheter, then you can engage the target vessel. G is in the previous TAVR case. Everybody uses the guide extension catheter is common during the time of TAVR because for the protection of the coronary. But previous TAVR situation where the crossing transcatheter aortic valve by GC is not possible due to inadequate backup support, use of GC wherein guide wire is first delivered through the valve cage followed by advance the guide extension catheter can create direct coronary engagement. Even Hyderabad saying that the cell the size is larger when compared to Medtronic, but your sinus is lost, so you can't use the EBU catheter. So this is the one example case that was done almost 2 weeks back. This case was done almost in 2019 Medtronic Evolute Pro. You can see whatever you said, no catheter is properly engaged. So you use a JR4 wire guide catheter. Then selected each cell is very small and there is no conventional alignment, those quals and also it was very tough for me. Big patients got tight LAD and also LCX. Calcium not tight 70 to 80%. So just put the wire, tried, and then both wired and the balloon trapped, then push the guide extension catheter inside. You can see that. Then tried for this one OCT analysis because the IVUS is not going really. IVUS is best, but here advantage of guide extension, you can selectively engage and you can with the dye injection is possible. After that, you can see the very easily going through the guide extension. Guide catheter is situated outside the cell, outside the wall, and guide catheter extension is going inside. And one complication is there is a spasm the codominant circumflex. You can see a patient with some hypotension. So guide catheter extension is taken out and check the circles almost like TIMI2 flow. So then tried again, and you can see that without GEC the stent is not going. So then after a push-pull technique, ultimately go with the protrusion of the guide extension catheter in the outside the cell of the wall. So ultimately we got a good result. So this is the GEC complication. Coronary dissection is possible. Wire and push rod wrapping, the difficulty in stent advance. Suppose you are using the 7 French guide and guide extension is 6 and you have a steel there and you are using 4 mm size stent. Definitely there will be stent issues. So if you are using that, you have to go for 8 French also rather than 7 French. If you are using 7 French, 6 French guide extension catheter, your stent choice should not be 3.5. You can make 3. Otherwise, there will be wire wrapping and push rod wrapping with all these hard wires. And air embolism also possible and ischemia. Ischemia by GEC, the obstruction caused by either pseudo obstruction, more torsus or arterial calcification. How to prevent? You can rapidly withdraw from the distal vessel and then the ischemia can be relieved. One issue is there will be dampening of the pressure when you do the GEC. So what happens?
So I think you have to
last
wind
slide,
up.
madam. And GEC catheter is there now, so pressure will be low. So the pressure there will be backflow through whatever the wall, so that can cause air emboli. So you have to open these areas. Guide catheter and air embolism can be prevented. So to conclude, antivolamide tough case at 1 a.m. Change to femoral. I will make change from the radial to femoral. Use 7 or 8 French or 6 French GEC. Limited contrast. POBA, Ds and only POBA rather than angioplasty if there is difficulty. And staged calcium modification may get PCA. Then I want to get a good sleep for the next day work. Thank you. Thank you,
We
madam.
have the-
Taking that 1 minute advance as a secretary, madam. It's fine.
Thank you. We'll have the discussion at the end.
Dr. Ramesh Natarajan regarding renal denervation.
Respected chairpersons and good evening to all. Thanks to Sajan and CSI for giving me this opportunity. So the case scenario is given to me was that of an 82-year-old male with a creatinine of 1.6, weight 80 kg. So the calculated creatinine clearance is about 40.28, and he has a blood pressure of 160 over 100. He is on ARB, diuretics, moxonidine, prazosin, all drugs, and still the blood pressure is 160/100. So the patient is asking not to add any further drugs, and whether anything else can be done for this particular situation. So if you look at the strategies for blood pressure lowering, you have the lifestyle changes, the combination drug therapy, and the newer addition, which is the renal denervation treatment, which basically involves works on the premise that the sympathetic activity, which the sympathetic supply to the kidney, in fact, leads to the increased release of renin, RAS activation, sodium retention, and increased blood pressure. So what we do is pass a catheter into the renal artery, trying to pass radiofrequency energy, thereby ablating the tissue surrounding the renal artery where you have the sympathetic plexus, and that leads to a decrease in the attenuation of the sympathetic activity, leading to decrease in the blood pressure. And it is important to know the anatomy of the sympathetic plexus, which in fact had led to some failure in the earlier trials. The sympathetic ganglia, which are the para-aortic ganglia, which give the plexus, and the nerve plexus, in fact, is lying very close to the arteries, only in the mid and the distal branches, and not very much in the proximal third of the renal arteries. So some of the earlier trials of RDN, they focused on ablating the proximal part, which in fact led to the diminished or negative results. And what is important is the ablation of the perivascular tissue, which houses the sympathetic nerves, and the necrosis of this tissue. And it is not the depth of ablation that matters, but the extent of necrosis that you create around the renal artery, which leads to which decides how much plexus is involved and how much successful your ablation is. And the catheter that we have is the Simplicity spiral catheter, which has got 4 electrodes, and it gives a circumferential ablation, which results in a thermal damage of the nerve plexus. So as I mentioned, the lesion shape and volume are more important, and that can be achieved with less of energy than if you try to create more deeper ablations. So this information has in fact led to a decreased usage of the current strength and less of renal arterial side effects and renal injury to the renal arteries. And the sustained BP reductions have been demonstrated by this therapy up to 3 years by the global Simplicity registry, the office systolic blood pressure, as well as the 24-hour systolic blood pressure has been shown to be sustained reduction up to 3 years. And some of the independent registry follow-ups, they have shown up to 9 years of reduction of the systolic blood pressure without any increase in the number of drugs. So basically, this second generation sham control trials have not shown any side effects with this particular therapy. No disturbance to the renal architecture, no renal artery stenosis, as well as there is no decrease in the renal function. And in fact, with better control of blood pressure, there is a preservation of the renal function. So basically, ideal patients are those with the true resistant hypertension, as was in the case given by Sajan. So multiple drugs, uncontrolled hypertension, BP is still more than 140/90, with more than 3 drugs, including a diuretic, despite lifestyle modifications. And special emphasis is given to patients who are at an increased cardiovascular risk, who have cardiovascular disease, multiple risk factors, and patients who prefer an alternative additional therapy. That is also extremely important. The major contraindications are renal transplant recipients, because you do not want to injure the arteries of these patients. Impaired renal function, a GFR of less than 40 ml per minute is still a contraindication for doing this procedure. Secondary hypertension, especially the renal artery stenosis or the hyperaldosteronism, that group, except some cases of chronic parenchymal renal disease where the GFR is more than 40, all the other secondary hypertension groups are excluded. And the renal artery diameter, with the currently available catheters, the renal artery sizes which are 3 to 8 millimeter only can be ablated, while anything less than 3 or more than 8, they are contraindicated. So coming to this case scenario, clearly this is a case of resistant hypertension, and the GFR is borderline, just above what is permitted. And then the patient is an unhappy patient. He is asking the doctor to do something to control my BP instead of adding new drugs. So clearly, this is the therapy which we can offer. We have 2 approved catheters, the radiofrequency simplicity spiral from Medtronic, which is a helical catheter with 4 electrodes. It is the same catheter is used for vessel sizes from 3 to 8 millimeters. And it's a 4 French catheter which goes over an oven 4 wire. It's about 90 centimeters. And this is the ultrasound catheter, which requires a different guiding catheter for different catheter for different sized vessels. And this is not available in our country. So this is the catheter, the helical catheter. These yellow points, they are the electrodes. And this assumes the shape, it becomes linear when you pass the wire inside, and assumes the shape according to the size of the vessel, so that the electrodes are in contact with the vessel wall. And pre-procedure, you have to confirm that the patient has blood pressure despite the optimal treatment. It's advisable to get an ambulatory blood pressure to confirm the uncontrolled BP or resistant hypertension. So average blood pressure more than 130 is despite being on drugs. That is, it confirms resistant hypertension. Rule out secondary causes like all these which I mentioned, and chronic kidney disease with GFR less than 40. And imaging is very important before planning this procedure, because you need to look for accessory renal arteries. You have to look for the sizes of the arteries. It should be in the 3 to 8 millimeter range. And invasive renal angio you can do at the time of the procedure. This was our case actually, where this gentleman, before about 2 to 3 years before the procedure, he had this left renal artery stenosis which was stented, and he had partial response, but subsequently he was on multiple drugs, and the pressures were not controlled. So this CT renal angio we did again just before the procedure, and it showed a patent stent in the left renal artery. There were no accessory renal arteries, and the vessel sizes were in the 3 to 8 millimeter range. This was the ambulatory blood pressure, which showed a paradoxical rise in the nocturnal BP recording, and the nighttime BP was about 152, and this was the renal angiogram which was taken, the left and right at that time, and we could measure the sizes of the vessels. You can do that by QC also. And adequate hydration pre-procedure, loading with aspirin 300 milligrams and 75 mg post for 1 month. Intraprocedural heparin is indicated to keep the HCT above 250. And adequate analgesia during the procedure is important because the thermal ablation can be painful and the patient should not shift and cause movement of the catheter. And usually a 6 French renal guide is taken. We used a Sion blue wire, but you can use any non-hydrophilic wire can be used, and support wires are preferred. You can use buddy wires if there is a tortuous vessel and difficulty in tracking. Heparin, intra-arterial nitroglycerin is given to prevent the vessel spasm, and all accessible renal arteries in this size, 3 to 8 millimeters, should be ablated, and a final angiogram to look for complications like dissection, distal perforation, and so on. So this is the wiring, and then the catheter comes, and you pass the catheter. The catheter is placed. It's better to avoid any carina points because, and also the intraparenchymal vasculature is to be avoided because those are thin and can lead to perforations. And once the position is reached, you take out the wire, and then so you ensure that the 4 electrodes are in contact. And then this is the one, before giving the ablation, you ensure that the impedance is in the uniform range, so that this indicates good contact of the electrodes with the vessel wall. And then you proceed with the ablations. So in our case, we could give 11 ablations on the, so after ablating one vessel, you can withdraw and pass the wire into the other branch, position the catheter into the other branch, and do the ablations. You can check the position. And this is the console, which shows the rise in the temperature. And this is, as the impedance shows a slight fall as you ablate. And so we could do 15 ablations on the right side also. And so post-procedure, there are no on-table clinical endpoints for successful renal artery ablation. So after the procedure, usually it involves just management of the vascular site, overnight monitoring, especially the hemodynamics, urine output, look for any hematuria which indicates a perforation. Continue the antihypertensives as before. And aspirin is given for a month and follow up. And usually it takes 90 days for the necrosis to be complete. So you get an optimal result at the end of about 3 to 6 months. And right now, at 6 months after the procedure, our patient is having a blood pressure on these 3 drugs. And the ambulatory BP is very reassuring that you can see the nocturnal BP has fallen almost 24 millimeter drop in the mean arterial pressures. So these are SKY statements. And exclusion of secondary causes and persistent hypertension. So this is the recent guideline, the 2024 ESC guideline, which says that for resistant hypertension, a class 2B indication, it was class 3 in 2018. So for patients who are on uncontrolled blood pressure, especially if they also express a preference to undergo renal denervation after a shared decision making. So the shared decision making is also given importance. So thank you.
Wonderful.
Kindly call upon the next speaker, Deepak sir. He's going to talk on vascular closure devices.
Good evening to all of you. Let me thank the organizers, especially Shiv Prasad sir, Sajan and team for the opportunity given. Well, the question is, we have a 17-year-old patient who had undergone coarctation stenting. How do you manage a 12 French femoral access? Well, we have 2 options. One, it could be a suture-based closure device, or it could be a collagen-based closure device. Suture-based, it's ProGlide, and collagen-based, it's going to be AngioSeal, the Obtura, or the Manta device. Regarding ProGlide, it's basically a very sophisticated device. You could see that on the top frame, you could see that's how the arteriotomy site would look like following the suture implant over there. Regarding the deployment steps, you have a wire inside the femoral artery, get the device into the femoral artery, remove the wire, and then push the device further into the femoral artery. Once the device goes deep into the femoral artery, once it's well inside the femoral artery, you have a back bleed. And once you see the back bleed, you're sure that the device is inside the femoral artery. Then you need to deploy the foot. Now, how do we deploy the foot? You need to lift the lever over there. Once you lift the lever over there, the foot is deployed, and then you push the plunger on the top. You push the plunger, and then the needles are going to be deployed next. So that's what you're seeing. The needles are deployed. Then you pull back the plunger to the maximum so that the sutures also will be deployed. So you have a loop once you pull it out. And once you pull it out, you need to get out the device from inside the femoral artery. Then again, you have to close the foot so that you need to push the lever downwards. Once you push the lever downwards, the foot is closed, and then you need to take out the device. Once the device is out, you can catch hold on to the wires. You have a white wire and a blue wire. Catch hold of the blue wire, pull it little bit backwards. Once you catch hold of the blue wire and pull it little bit backwards, the suture becomes taut. It sticks onto the anterior wall of the femoral artery. Once that is done, you go inside with this knot pusher. We are now pulling the suture. Then the device is taken out, and then you go with a knot pusher inside the subcutaneous tissue. That's the knot pusher. With the knot pusher, you can push the knot downwards onto the top of the femoral artery. That's a knot pusher. So you're seeing that the knot is pushed on the top of the femoral artery, and then you cut the sutures, and that's how the procedure is done. The greatest advantage of ProGlide device compared to a collagen-based device is it preserves the access site for future interventions, which means that the very next day you can again re-access the femoral artery. It can be used for arterial as well as venous closures. For arterial closures, anywhere between 5 to 21 French access can be closed with ProGlides, and for venous access, you can close it up to 25 French. When you have a access site which is more than 9 French or so, you need to use two ProGlides, one which is oriented towards the 10 o'clock position and the second one which is oriented towards the 2 o'clock position. And data says that you have a success rate of around 95 to 90 to 95% with ProGlides, and above 8 French access, you need to have 2 ProGlides. That is one which is oriented towards the 10 o'clock and the other one towards the 2 o'clock position. Alternatively, you could use one ProGlide and then a collagen-based device that's either a obtura or an angioseal. The disadvantage of this particular device would be it's got a very steep learning curve and higher failure rates compared to collagen-based devices. Now, coming to collagen-based devices, you have the angioseal, which is actually marketed by Terumo. Basically, it's a very simple thing. You have an anchor, you have a collagen, and these are connected with the help of thread. Everything is resorbable over the next 3 to 6 months. Well, this is how the device would look like. So once the procedure is over, you have the wire inside the femoral artery. Over the wire, you can introduce the sheath of the angioseal. The sheath is inside the femoral artery. Remove the introducer from the sheath. Now, before that, you need to make sure that the sheath is well inside the artery. And once the sheath is inside the artery, that's the introducer that's been removed from the sheath. And then you take the device which goes, that's the device. It's got the sutures, it's got the collagen, and it's also got the toggle that's supposed to be anchoring towards the femoral artery. So that's the anchor being released. You could see that the anchor is being released inside the femoral artery. And once the anchor is released, pull the entire system backwards and the anchor holds on to the vessel wall. Rest of the sheath, it comes out. Then you go with the collagen pusher. That's the green tube. The collagen pusher is used to push the collagen to the top of the vessel. So you have the vessel being sandwiched between the anchor and the collagen. Remove the wire. Cut the wire. Now, data says that you have more than 95% success rate with this device. Comparing ProGlide with angioseal, you could see here in this particular study that there are almost 10% failure rate with ProGlide and no failures with angioseal. Now coming to Obtura, that is marketed by Merrill, the made in India device, again a 6 French and an 8 French device. They have 6 French for the 6 as well as 7 access sites and 8 French for 8 and 9 access sites. It's again very similar to angioseal except that you don't have an additional introducer sheath. You could use the same sheath that you're working for the angioplasty. That's a 7 French sheath that you've done, use for the angioplasty procedure. Then you can introduce the anchor as well as the collagen into the vessel, then pull the hub little bit backwards and pull out the entire system. Once you pull out the entire system, you can use the collagen pusher. That's the green rod. With the help of the collagen pusher, you can push the collagen into the vessel, hold on for 30 seconds, and that's how the procedure is done. Once the procedure is over, that's how the groin would look like. Now coming to the Manta device. Manta device is the latest device that's available for us. It's actually available for up to 25 French vascular access, from 12 French to 25 French. And this is again very similar to angioseal device. You have an anchor, you have a collagen, and everything absorbs except for a radio-opaque marker that remains on the top of the artery. You have two sizes, the 14 French and the 18 French. 14 is for 12 to 18 access, and the 18 French is for 18 to 25 French access to the arterial artery. That's how the procedure is done. You have an initial depth locator, that is with the help of this particular small sheath you could identify the depth of the arterial wall, how deep is it from the skin to the arterial wall. Then you could use the device, that's the sheath going inside the artery. So once the sheath is inside the artery, you remove the introducer from inside the sheath, and once that's done, this is the device which has got the anchor, the collagen, everything. It goes inside the vessel through this particular sheath, and once it's pushed into the vessel, you deploy the lever. You pull back the lever so that the anchor is deployed. So that's how it goes in. Once it's inside the femoral artery, you slowly pull it back to the predetermined length. You know how deep the vessel is. You pull it back till then pull the lever backwards so that the anchor is deployed, and then pull out the entire thing, and then push the collagen pusher into the vessel. And once that's done, it seals off by itself. Well, again, the data says that you have more than 97% success with the MANTA device when you use it for large bore access. And how do we safely use a vascular closure device? Always make sure that you have a clean stick. Always the puncture site should be above the bifurcation of the femoral artery and below the inferior epigastric artery. Always look at the fluoroscopic images. Also make sure that you have a proper injection. Make sure that you have the anterior middle puncture rather than going through the sides. And regarding pre-procedure planning, it's always good to have a CT angiogram also done so that you know about the bifurcation, you know about the calcification, tortuosity, as well as the vascular anatomy. And if you have persistent bleeding after the vascular closure device, manual compression is an option. Balloon dilatation from the opposite side, having a covered stent, and a surgical management would be the last option. So this was a patient who received a portico valve in our center. Following that, you could see that at the access site there was persistent bleeding despite having a ProGlide as well as an Obtura device. It persisted, it did not stop bleeding, and at some point of time we also made out that there was a narrowing over there, so we decided to go with a fluency stent from the opposite side. That was a 7 fluency stent that is being deployed there well above the bifurcation, and that was the final result that we could achieve. You could see that the stent is landed well above the bifurcation without compromising the profunda. Well, so dear friends and teachers, in closing, 17-year-old student, coarctation of aorta stenting done, how to close the 12 French femoral access. If finance is not an issue, I would prefer using a MANTA device, and if finance is an issue, then a ProGlide plus an Obtura would be safe enough to close the 12 French access sites. Thank you so much.
Thank you.
Thank you.
Deepak,
So please remain
stay back.
on stage.
Please stay back. Invite all the speakers to the stage.
I request Dr. Shafiq, Dr. Ashraf, and Dr. Ramesh to please join Dr. Deepak sir on the stage.
So, first of all, let me congratulate Dr. Sajan for selecting, and Dr. Shiv Prasad for selecting such a interesting and important topic, and it's got a lot of practical point also. My question is to Dr. Shafiq. What is the contraindication for doing ultrasound guided puncture, then C puncture?
Then
Any contraindication?
Actually, there is no contraindication.
So,
It
do you
can be
think that
practiced.
inexperienced person is a contraindication? So, you should have more experience in doing ultrasound.
In fact,
so I think that should be the things. I think we should learn, all of us should learn how to puncture based on ultrasound.
Yes.
I think that's one thing. Otherwise, routinely, I think we should practice, it's mandatory, and in legally also, we should puncture only based on ultrasound or under fluoro.
It is.
I think it's better.
It definitely has a learning curve, but it is important to start as early as possible.
One more question. What about radial puncture? Do you recommend ultrasound?
In most of the trials, the benefit was maximum in large bore access. There were benefit in the coronary PCI transfemorally also. In radials, of course, we can do, but then as we know, the vascular complication as such is much less in radial. I used to do vascular ultrasound guided puncture using micropuncture technique in brachials, but radial we are comfortable with the conventional way.
Can I bring this radial diameter also we can assess?
Yes.
So what are the situations where you definitely use ultrasound guided puncture? Like not for all, because most of the time we are comfortable with fluoroscopic guided puncture for the femoral. Yeah. So how often do you use? Suppose you're doing 100 femoral interventions. So what percentage do you use ultrasound? You want to answer, Deepak? No problem.
In our center, always 100%, because now only when you get used to that, when you have a large bore access, you'll be well versed with that particular technique. So every femoral we try using it. We have a small the V-scan from GE, which is very useful. It just opens up. You open up the device and within 10 seconds it's on. So you don't spend
So it's
time.
a linear probe that you
It's
It's a
linear probe.
Okay. So I think certain practical clues you have mentioned that you have to put it into a sterile
cover.
sleeve and it has to be very tight.
Yeah.
Very tight.
The
And
gel-
where is the needle position? Is it anterior or posterior? Any advice on that?
It's precisely the center. If we are using the cross-sectional view, precisely there's a marker in the center of the probe, and we precisely use that and make sure the vessel that we are planning to puncture is in the center of the imaging screen as well. So you get the precise. You can in fact see the needle going in very well.
So, and then you take off the probe.
Take off the probe and put the wire.
Okay, so
I think it's till that time I think you should use fluoro and the puncture should be below the ilioinguinal, above the bifurcation, at the middle third of the femoral head. That should be the message.
Yeah. So use the fluoro first and mark the lower end of the femoral head with the artery forceps, and then there is no need for unnecessary radiation. We can go ahead with the ultrasound.
For Deepak, you have told so many vascular closure devices. So among the Optura, Mantra and all, you have experience with almost all. So which you prefer and why?
The easiest to use would be Angioseal and Optura. But with ProGlide, you need to get used to ProGlide, because as we go in for graduate for this large bore access, when you want to do a TAVR, you cannot go in for an Angioseal or a Optura. So you need to get used to ProGlide. So we always try to use ProGlides in our center during coronary interventions. And now for the last 3 months or so, we have the Manta device, which is almost similar to Angioseal or an Optura device for the large bore access. Gives so much of peace of mind at the end of the TAVR procedure. Groin is never a complication.
Hematoma complications when you used?
We've used 4 cases. Manta never had a problem with that.
see, you said almost no complications with Angioseal.
Yeah,
Because
in that
when you
particular
presented,
study.
you said like that,
In
but
that
I have
particular
an anesthetist, lady anesthetist who underwent a right SFA recanalization through the left, and he had put in a 8 French sheath. This one, okay. Angioseal. He had closed with the Angioseal. Unfortunately, at night, this Angioseal just gave away.
Yeah, ma'am,
Collagen
it
plus
always-
just
it
gave
is
away.
ha-
So, what is the reason for that? How can you avoid that?
Ma'am, this can happen to anybody. And again with the Angioseal data says that you have a success rate of only 96 to 97%. In that particular study alone, where they compared with ProGlide, there was 10% failure with ProGlide and no failures with Angioseal. So it's definitely that you could have bleeding complication, you could have ischemic complications also. The collagen can embolize into the vessel, that you can lead on to ischemic complications also.
So I think it's the study you quoted, sir. At
Madam,
least
one second, that was the
1.7%.
practical issue. This one, Manta versus the Angioseal. Angioseal, one practical issue is if you are using the Angioseal in the opposite left limb, your angle will be different. And many of the time there will be in your TAVR and all, you are focusing on the primary limb. And the opposite limb, you are going like this. And you may change the angle. And many of the failure occurs like that only. Otherwise, no. And, yeah, peripheral.
I think it's, as you mentioned, the complication rate is not 0, at least 1.7%. And vascular surgical rate is at least that also is 2 to 3%.
Yes,
So,
the
Angioseal you said is similar.
last week when Manta used, that was 3 Manta in a row, but the second Manta after that the femoral is cut off. after the SFA, but actually it was a CTO, the profunda is supplied. So the CT scan, they won't go below the bifurcation. So you have to be very sure that whether it is lower limit. So immediately check that profunda, then at least vascular, saturation, it will be okay. So
angio may not be possible post procedure. What about ultrasound?
No, before procedure there will be CT angio.
Yeah. Post procedure, post device closure.
Post device, I had an experience in my second Manta when there's a learning curve for how much we should push the collagen with the plunger, because in the second case I probably pushed a little too much, and the hemostasis was absolute. But when I checked from the contralateral side, there was actually a space, a moving object which was partly inside the artery. Then I took a balloon and just did a balloon dilatation and opposed it.
So the Manta is more
But there was no bleeding.
expensive than angiosin. So what is the cost?
50.
Two ProGlides would be better financially if you look at the costing. But comfort of use is it?
Comfort of using and not interior.
Okay. Any question here? I think two questions here. I think guide extension.
We'll have one question.
Guide extension. You said inching. You said inching technique is your favorite technique.
Yeah.
Guide extension. Inchworm. That's a new worm.
But that's why because
Okay. But I'm asking you what percentage of cases you do this, because oftentimes we don't use the inching technique. Okay.
No,
you
madam,
often take a balloon down.
No, but usually why you are using guide extension, there is a calcium and tortuosity. And if you are using the balloon trapping and you are deflating and pushing the guide catheter going, and it definitely go along the vessel wall, and definitely there will be dissection, spasm. So the inchworm, the half of the balloons within the guide extension, half will be in the vessel wall. So that it won't touch upon the vessel wall. It will be central lumen rather than the vessel wall.
Probably it's a technique which is worthy of trying. That is all.
Probably it's safer also. That is
safer. So to avoid that very close to the guide extension.
So GEC, lot of GEC is available now. Which one is your favorite one?
Guide layer, of course.
Why not Guidezilla? Because Guidezilla is
flexible.
smaller than Guidezilla, and its inner diameter is at least 0.01 larger than Guidezilla.
Sir, that was
0.01.
No, OD and ID is smaller in Guidezilla, ID is larger in Guidezilla, but the difference is hardly matters 0.01 and all whatever. So that will be equate with your new generation stent, FDA approved stent and other stent.
You mentioned all the complications. What about the dislodgement of the Guidezilla tip? Anything? Dislodgement,
so especially
fracture?
I think last time also Dr. Jayesh showed that in a rotablator case.
But actually, inchworm technique is actually the ideal technique if you cannot cross the guideliner even with a balloon. Balloon is not going, it is not going. Inchworm technique is a technique, it can be used even in a tougher case to take the guideliner down. That's a very good technique actually. If you practice that, it is very easy to do also.
We'll have
Like the Guide Plus.
Yeah, Guide
Plus is excellent.
But now future generation is coming cross liner. That was the microcatheter distally.
Even the Medtronic Teleflex also came, but now it is not there in the market.
We'll
so
have
that also gave a lot of problem.
Cross liner actually advantage is actually you have a flow also will be there. If you actually take a guide liner into the circumflex, your flow to the LED is actually disturbed.
Yeah, I
in
think
the cross liner it is easy.
One question to Dr. Ramesh.
Dr. Sandeep, you would like to.
See, so the Simplicity 3 trial, that was the one which put nailed the last thing, nail on the renal denervation. How did this new guideline recommendation come? And what is the data based on which the ESC has given a class 2B? I don't think it's a great indication, but still you have this.
Yeah.
Which is the data?
No, I think basically the ablation points, it was mainly, it was used to be proximal. Now they are using more of the distal ablation points and accessory renal arteries were not targeted at that time. So
I think also they can
all available vasculature should be this thing. So
all renal arteries should be
renal
ablated.
arteries should be
I think
ablated.
mostly the fibers are in the ventral aspect. So that's why
And
the spiral
long-term
catheter.
Madam Chairperson is taking longer time.
Yeah,
I think.
one Dr. Sandeep, we have to have one comment from the stage manager who has been
Sorry,
silent
sir,
all along.
to keep you guys waiting. Ashraf sir, just coming back to basics, can you comment on few GECs that support covered stent
Good question.
accommodation?
Basically, if you are using the guide extension catheter, don't use covered stent like more. At least in that case, you have to use the 7 or 8 French guide extension catheter, and guideline it is available. And other telescope or this later part, Hatterite is not available with 8 French. So better with the 7 French is okay. Don't use the 6 French with the covered stent.
Right. Thank you.
But use it. But issue is difficulty because pushability availability. No. I am telling that in a teaching module, don't use guide extension catheter for the 2.5 mm vessel and more than 4 mm covered stent or equal to
Regarding this
covered
question
stent.
on covered stent, the problem is not the internal diameter. The problem is at the entry point. That is the most difficult
hub
to tackle.
point.
That you will not be able to get across.
Transitional point.
Transitional
And many
point.
of the time it will be dislodged and broken.
Dr. Ramesh
Yes,
Natarajan.
we'll have the photo.
We have 3 modes of ablation now, including alcohol recently. So any advantage over radiofrequency ablations of ultrasound ablation you have comparison?
Yeah, ultrasound also there is a trial. That's the there's a long-term data for ultrasound also, but not for the alcohol. I don't think it is there.
Yeah.
But for simplicity catheter and this one, it is there.
Okay.
I think,
So
thank you
I
so
think
much.
it's the last question, because you already mentioned that is indications, contraindications for using radial innervation therapy. But what is a physiological effect? Suppose this patient comes with hypertension of any cause, how the body reacts, because renin won't be there to secrete. Just like we stimulate the carotid bulb, we need sympathetic activities in the body. How we are going to? What do you think?
No, it's not going to be.
Any words you have?
See, it's not going to be so absolute. Like see, even drug trials have shown only about 3 to 5 millimeter mercury reduction. So here this has shown up
I
to
think we had
almost
a very
10 millimeter
fruitful,
reduction. That's all.
session. Thank all the presenters for the very excellent presentation, opening up a lot of discussion.
We'll have a group photo. Sandeep, group photo. Yes. A silent photograph.
Thank you, everyone.
Thank you. Thank you so much.
Next is Act 2, Scene 3. We have 2 panel discussions. Each panel discussion will be allotted 25 minutes. A warning signal will sound 5 minutes before the conclusion of your allotted time. Rheumatic fever prophylaxis, challenges and solutions. I would like to invite the protagonist, Dr. George Koshi, and the cast of characters, Dr. Abdul Khader, Dr. Sulfikar Ahmad, Dr. Abhilash TG, and Dr. Arun Kumar onto the stage.
Thank you. A few announcements before the last session. So this will be the last session where we have 2 panel discussions, and following that there will be the general body meeting in the same hall, and all the postgraduates are kindly requested to go for the echocardiography congenital heart disease session. It is going to happen in Hall B at the end of the industry area. And one small but important request from our industry colleagues, partners and friends, kindly visit their stalls because they have painstakingly made arrangements, and there is also a dedicated IVAS desk also. I'm sure the postgraduates would want to visit that. Thank you so much. Abdul Kader sir, who is a staunch stalwart in rheumatic heart disease, sir is down with an upper respiratory infection, probably not a group A beta hemolytic streptococci, and sir has conveyed his regards to everyone.
Let me first of all congratulate Dr. Sarjan and Dr. Shiva Prasad and the entire team for including this topic, which is very relevant now. Rheumatic fever prophylaxis, challenges and solutions. The cast of characters, very eminent people. I don't think they require any introduction. So we will go to the case scenario straight away. A 30-year-old lady on oral penicillin for secondary prophylaxis. Both Capen and Pintits are not available. So what to do? That is the question. Just an introduction. We know that rheumatic fever prophylaxis, we have the primordial prevention, the primary prevention, and the secondary prevention. I don't think there is any controversy in the initial two areas because we have other drugs available for primary prevention. So we will be discussing mainly on secondary prevention. If the oral penicillin is not available, what we can do. That will be the focus of this session. Just one point about primary prevention. Remember that rheumatic fever can be prevented if antibiotics are started within 9 days of onset of symptoms. You do not have to start it immediately after the sore throat. So you have a good time window available. And that probably is the reason why rheumatic fever has come down in the state of Kerala, because azithromycin and other antibiotics are used so extensively by all the doctors. And primary prevention, we know that we all tell about single benzathine penicillin injection, but seldom used. Usual antibiotic for 10 days, we have oral penicillin, ampicillin, cephalosporin, azithromycin, everything is effective. But it should be given for 10 days, except for 2 antibiotics. If it is azithromycin, 5 days are enough. If it is ceftriaxone, that is the cephalosporin, Keftam and all that, it is required only for 5 days. And secondary prevention is the main target, that is targeting those with history of rheumatic fever, rheumatic heart disease, in which we have various options available. We know that it should be effective, safe for long duration, very important. It should be economical and easy to administer. We know that benzathine penicillin is the most effective one. No controversy on that. But because of the risk of anaphylaxis, the pain related to the injection and logistic issues, we are all very reluctant to use that. So we depend entirely on the oral penicillin. Please do remember that we have penicillin V, which is potassium phenoxymethyl penicillin, which is a so-called K-pen. And the second one is the penicillin G, that is actually benzyl penicillin, which is a so-called Pentits. In comparison, the penicillin V is better. That is potassium phenoxymethyl penicillin, because it has better oral absorption. Now let us come to one or two important areas. Let us have a quick look at the current guideline-based recommendation for secondary prevention. I think I will start with Dr. Abhilash. Actually, Dr. Abhilash had this thesis in rheumatic fever, I believe, with Dr. Sulfikar during his MD days. Please.
Sir, actually, these guidelines are based on studies maybe before 60s. And there is no correct randomized control trial or recent trials for the prophylaxis. And the current recommendation based on the drug, as you have mentioned, benzathine penicillin is a preferred drug. It has to be given at 1.2 million units IM if the weight is more than 30 kg. Less than 30 kg, it is 6 lakh units. Once thrice or 4 weekly. In endemic areas, it is thrice weekly. And the less prevalent areas, it may be 4 weekly. And if not willing for penicillin injection, we can use oral penicillin, which is less effective, maybe 1/10 effective than the injectable penicillin. And penicillin V is preferred over penicillin G. 250 is dose for penicillin V, and 400 BD is for penicillin G. And if the patient is allergic to penicillin, we can use erythromycin, 250 milligram BD, or sulfadiazine, 1 gram if weight is more than 30 kg, and 500 milligram if less than 30 kg. This is regarding the drugs. And the duration, which varies depending upon the guidelines we use. American guidelines prefer if the duration depends upon the severity of carditis. If there is no carditis, we can use prophylaxis for 5 years or 21 years, whichever is longer. If mild carditis, we may use for 10 years and 21 years, whichever is longer. And severe carditis, we may use for 10 years and 40 years, whichever is longer. WHO has a slight variation. They prefer if no carditis up to 18 years or 5 years, and mild carditis up to 25 years. And severe carditis and valve replacement, they prefer lifelong prophylaxis. And Australian guidelines have introduced a middle term like moderate carditis, where it can give up to 35 years. That is regarding the duration of prophylaxis.
So I think most of the guidelines are more or less similar. There's no very major difference between the various guidelines. Now I think which should the one we should follow? I think we have Dr. Sulfikar with a lot of experience. I think he was one of the members of the writing committee on secondary prophylaxis and rheumatic fever issued by the IAP, through which I have gone, and he will be the right person to answer that question. Are the guidelines based on strong data? Any recent study? And which do you think is the best recommendation in the Indian or the Kerala context? Dr. Sulfikar, which one should we follow?
Okay. Now the point is that if you talk about a secondary prophylaxis, if you go through the literature from 1955 when the first introduction to secondary prophylaxis was made, at that time only penicillin, oral penicillin, one kind of oral penicillin. Penicillin G was not at all mentioned. And sulfonamides were there. Later on we realized that somewhere around 2000, 2005, they introduced erythromycin followed by azithromycin. So there is a subtle change in choosing the drugs or the antibiotic. That is one point I want to stress. So for the last 10 years only this macrolides have come into the picture as a potential alternative. And we must remember, if you look at any literature, Australia, New Zealand or whatever, you will find that they are all prescribed for people who are allergic to penicillin. They don't envisage a situation where we have now, that is non-availability. Okay. So that is one point I want to stress. So based on that is one. Then the guideline based on strong data, basically we all know that, as Koshi was mentioning, we are very clear that antibiotic versus no antibiotic, absolutely huge difference. Penicillin versus any other oral antibiotic, a huge difference. There are two, these are known issues. The third issue is what are the oral drugs which are positive. So sulfonamides may be based on whatever data, as Abhilash was saying, in the 60s, sulfonamide may be slightly inferior, and probably we would not be very keen to use sulfonamide.
Anyway, it is not available.
Sulfadiazine
is not available.
And if it is not available also, we will be little more defensive about using it. So what we have left is oral penicillin and erythromycin and azithromycin. And if you again look at the articles, you will find that whatever may be the worth of those 1A, 1B, 1C and all, this erythromycin is put under 1C. So the level of evidence regarding use of erythromycin as a secondary prophylaxis is a bit less strong. That's all to say.
Okay. Now let us come to something very important. What about the prevalence of rheumatic fever and rheumatic heart disease in Kerala at present? Is it a vanishing disease like endomyocardial fibrosis? That's very important because Kerala has a population of 360 million. So it's important to know how many cases of rheumatic fever really happen in the state of Kerala during the last, say, 6 or 7 years. This is information I got from Dr. Abdul Kader, who has the rheumatic fever registry. Manjuran sir is sitting here. There's a very good registry, and this is the data which he could gather. And over the years, the number of rheumatic fever cases have come down to the extent that in 2023, it is just 15 cases in a state with a population of 360 million. It may not be a complete representation, and North Zone 5, Central Zone 4, and South Zone 6. So that is all. So certainly rheumatic fever has come down. It is not going to vanish altogether, but it certainly has come down. There's no doubt about that. Dr. Sulfikar, what do you think? Has it really come down?
Yeah, I think definitely it has come down dramatically, both in the private sector and government sector. It has come down because I still remember in 2003, we had in SAT hospital alone, we had 100 patients per year, 100 patients, and people were stunned by that value. But now it is around, let's say 5, less than, it's only a single digit figure. But this probably could be an underestimation.
Exactly.
But we have to accept that rheumatic fever
has come down. But I think there was one more point. See, Pentits and Capen are not really available for the last 3 to 4 months. Honestly, many people have discontinued secondary prophylaxis. You know, how many new rheumatic fever have you seen? You would have expected the hospitals to get flooded with rheumatic reactivation. I have not seen any. I don't think any of you have seen any new cases. That means many of these people are probably receiving secondary prophylaxis for much longer period than what is really required. It is good to have a relook at that. I am not telling that rheumatic fever has gone. No, it is still there. There are a lot of things to be done. Secondary prophylaxis is important. But I know many 60, 70-year-old people still continuing secondary prophylaxis. So I think we should have some discussion on that. I'll come back to you.
I would just want to contest you on a particular point. See, for example, you are saying that there are no crops of rheumatic fever coming just because you have 2 months, 3 months of absent oral penicillin. But you must remember that pre-penicillin era also.
No, certainly I am not. See,
let me
fully accept that.
Let me finish that. In the pre-penicillin era also, after 5 years, the recurrence was 40%, which means 60% did not have a recurrence. They lived happily, So that's
exactly. Now, what are the options which can be considered if oral penicillin is not available? Dr. Arun, please. Because that is exactly the problem now.
Yes, sir. It's already told. According to the guidelines, they say that sulfadiazine is the next best option. But as it is not available, then they give the preference to macrolides, including acylates and this one. Erythromycin is already a accepted thing, 250 mg. But nowadays, the Lal Chandani, they have a reference of data saying that azithromycin is very strong, and they have their own points saying that one thing is immunological modulation is something they bank on for the azithromycin, and it is actually without, it just needs to be given according
I think
to them.
we'll come back to azithromycin in
Okay,
detail
sir.
because that is something everyone is interested. We'll
Okay.
come back to
Okay.
azithromycin. Now, let us have a critical look at erythromycin, because the moment you tell that penicillin is not available, all guidelines recommend erythromycin. What about the long-term safety of erythromycin? We have the estrolate, stearate, ethyl succinate. Is there any real-world trial data? Or rather than just telling erythromycin is a good substitute for penicillin, what about the GI and hepatic side effect and the issue of QT prolongation? A lot of EP people are sitting here. Dr. Nadarajan is in front of me. The moment you tell about erythromycin, then immediately they will tell, okay, measure the QT interval. So, who would like to answer that question? Dr. Abhilash, what do you think? Is it very safe to give erythromycin over a long span of time, like the way you are giving Capen or Pentits?
Two, three issues. One is there is a risk of macrolide resistance, which is more common with compared to penicillin. Macrolides have more resistance of GB, group A beta amyloid receptor. Okay, and there is associated QT prolongation is there, and GI side effects, hepatic effects, especially with this estrolate syrup, and also there is some hearing loss is reported.
How often do you get hepatic dysfunction statistically? I think they tell about 1 to 3%. Dr. Sulfikar may be
More
able
common
to
with
add
a-
something to
more
that.
common with adults and pregnancy. That is what they say with estrolate.
More common with adults.
and in pregnancy.
They in fact tell about the so-called hypersensitivity cholestatic jaundice with erythromycin estrolate.
Stearate is more hepatic safe, but it is associated with more GI effects. It is less lipophilic, so the absorption is less. So now we have to take it on empty stomach, which increases the gastric side effect and which may hamper with adherence to rheumatic fever.
I think overall we can tell that in pediatrics it may be better tolerated compared to the... Now, what do you think, Dr. Sulfikar? Oh, please, please.
This long-term safety of erythromycin has probably been not addressed because, they have been using erythromycin for acute situation. They said it's a safe drug for children also. That is succinate. So, second, between acetylate stearate and erythryl succinate, probably there is hardly any difference. I think if you go to the literature, you will find ethyl succinate being mentioned initially in the AHA guidelines.
It is mentioned.
They
It is
later on
mentioned.
they removed that. Just said erythromycin. So probably at that time they were keen on succinate, but doesn't make any difference. Then no real world data. GI hepatic side effects are more or less, I think, the same. The issue of QT prolongation, I think there is. So, for example, even when I was treated with azithromycin, in ID people wanted to do once in 3 days ECG. I have a lot of ECGs with me now. So, really. But again, there is a feeling overall in the scientific literature, azithromycin is better than the other macrolides in terms of QT prolongation.
Okay.
That is probably one point, a soft point for azithromycin, but not for, I mean, we'll come to that. Again.
Yeah, I think we'll come to that. And Dr. Dambudiri and all, Dr. Praveen, everyone is there. We will ask their opinion regarding the QT prolongation
And
part.
drug
Okay.
interactions also with
Okay.
other
Now,
cardiac
I think
drugs
we
like
should have some
warfarin and-
discussion on azithromycin because many people ask whether they can take azithromycin, and there is some data and all that. What is the current status of azithromycin?
Sir, azithromycin.
Should we give it as a substitute or not?
Sir, right now, according to all the guidelines and all favoring azithromycin, not as the first one, even after sulfadiazine. So,
No,
they
let
have
us
some
not discuss
data.
sulfadiazine. Sulfadiazine is not available.
Yeah, it's not available. So then they prefer, and even the JAC 2023, they have an article on focused article on the rheumatic heart disease. So there also they advocate this azithromycin as well as all the macrolides and acylates. And this the most important advocate I think in India is this Lal Chandani group, where they say that just give azithromycin whenever you are giving for the initial 5 days, 500 mg OD for 5 days, followed by weekly dose. That is the benefit they are saying. It has to be just given weekly. But the one problem we see is that the studies found that it is not giving a culture negativity. Especially from Chitra, there is a small study saying that when they have seen that the cultures at the end of after giving oral penicillin versus azithromycin weekly, it was inferior. It was the final conclusion, but it was not good. So it was inferior to the oral penicillin. That is actually again no doubt that even there is resistance to the drug for whether if you give erythromycin compared to the oral penicillin. Oral penicillin, one good thing is they haven't found any resistance.
No, there's no controversy on that. No controversy about penicillin. We are just trying to compare.
But azithromycin have been given and now in all this
Recommendations
recommendations as the last option.
Okay.
Because when
No, I agree with you because I also read that this Arathi Lal Chandani is one person who is very actively promoting.
No,
You would have listened to her in all these
Yeah,
CSI
the point
meetings.
See, the point, Koshi, is that we have no objection. I mean, there is no problem with the azithromycin, provided you give 6 milligram per kg per day. So there is no controversy regarding that. That is, if oral penicillin is not available and erythromycin is also not given, you can safely give azithromycin 6 milligram per kg per day. That is also a part of a recommendation which has been accepted by many countries in the world, right? So that is not the problem in front of us would be this
Weekly.
the weekly thing. That probably would not be generally accepted. Even if you accept that the half-life of azithromycin is pretty long. But it is
Actually, there is one study with azithromycin which I could find in which 730 patients, they gave 500 milligram daily for 5 days. Thereafter, 500 milligram on 2 consecutive days. Then they stop it for 5 days. And they found it is effective and all that. I don't know. But remember this good study from Sri Chitra. It's a very well conducted trial. I think Dr. Harikrishnan, the entire Sri Chitra group. It's a small study, only 26 patients, but well conducted study. They found that over 6 months follow-up, they could identify 4 patients on azithromycin developing sore throat with beta hemolytic streptococcus with elevated ASO titer. So it is really a beta hemolytic streptococcal infection while on azithromycin, which what doctors exactly with what Dr. Sulfika mentioned. It's a very well conducted study, small study, only 26 patients, but it gives some data. I think the most experienced person, Dr. Sulfika, should be able to answer this question. Risk stratification in deciding the choice of drug as well as the duration of secondary prophylaxis. And with that, I think we will wind up.
Yeah, I think basically Abhilash had mentioned that there is some what you call as asymmetry between American Heart Association guidelines and WHO guidelines. Little bit. Basically, what it means is that when it depends on the severity of the disease, the young age of the child, and the duration of prophylaxis. These are all the things which matters actually. So basically, everybody has a feeling, scientific feeling, that beyond 20 years or beyond adolescence, the incidence of rheumatic fever comes down. So naturally, the need for continuing for a long time is less. Previously, we used to think that penicillins are forever. Now it is not. That is the fundamental thing. And there is a subtle difference between US guidelines and WHO guidelines. WHO guidelines seems to be a comfortable thing for a practicing cardiologist, because if you have a rheumatic fever without initial carditis, continues to have a normal heart, we give it for 5 years from the index event until 18 years of age. That is the one thing. Whereas if you have a rheumatic fever with carditis and it just disappears on follow-up, as many people do, we will continue for 10 years or for let's say 25 years. 25 was WHO. And of course, if you have a rheumatic heart disease, they said it will continue probably lifelong, maybe somewhere around 40 years, we could stop. Because the difference is that for AHA guidelines, both are 21 years. That is, without initial carditis, with carditis, but which disappears, the duration, the longest would be 21 years. The rest is more or less the same. So we can always take refuge in one of the, depending on the circumstance. For example, a real life situation, I will tell you. Suppose we had some of the young girls who are 19 years old, rheumatic fever without cardiac involvement, on penicillin prophylaxis. They are getting married. Even though the average age of Malayali women getting married is 24 years, but they get married at 19 years. So at that point, I would take refuge in WHO guidelines and stop secondary prophylaxis, because when they go home, they go home means I think.
So I think
practical things.
We'll come back to Our Lady and conclude. Sarjan is looking at me.
Oh yes.
Though you are speaking, he is staring at me.
Super.
So our 30-year-old lady, what should we do? That is a question. So get the old records. Find out whether she had carditis during the initial episode of rheumatic fever, and what is the extent of valvular involvement and all that. Have a proper clinical examination. Do an echo Doppler. Make sure whether there is cardiac involvement or not. If rheumatic fever was before 25 years of age, no cardiac involvement at that time, secondary prophylaxis can be stopped. You agree? Okay. If rheumatic fever was before 20 years of age, there's a gap of 10 years, and records show that there was no cardiac involvement subsequently, we can consider stopping prophylaxis. Agree? Okay. If rheumatic fever was less than 5 years ago, or rheumatic fever less than 10 years ago, and has rheumatic heart disease now, then we have to take it seriously. If Pentix and Capen are not available, we have to give erythromycin. We have to monitor the LFT occasionally and take all precautions which have been mentioned. Now, if rheumatic fever was before 20 years of age, okay, rheumatic heart disease now, there is some residual valvular heart disease. She is above the age of 30 years. I think the choice is between erythromycin and azithromycin. Okay, now with the guideline, maybe azithromycin, whether once weekly or 2/5 is a question yet to be answered. Now, okay, I think whatever be the thing you are using, prompt treatment of sore throat very important, wearing mask very important, avoiding overcrowding, and whatever you tell that general guidelines are all very important. And Sulfika can tell the final comment and then we will wind up.
I just put it very, very succinctly. I think we all agree. No, the jury agrees. Thank you.
Thank you.
So thank you very much.
Thank you very much.
Thank you all the actors or character. What should I tell? And no, I think I am the protagonist.
Yeah. They are the cast of characters. You can have a photograph. Yeah, Manjunath sir last. While you stand for the photograph, sir can.
Yeah. Thank you.
We have done a study at Kottayam Medical College where we wanted to find out when we can stop secondary prophylaxis. We had 400 patients. They were grouped into two groups. One above the age of 30 years. Then one group where the prophylaxis was stopped, and the other group prophylaxis continued. The only instruction we gave to the patients who had prophylaxis continued was that if you develop sore throat with fever, you take erythromycin 6-hourly for 10 days. And both the groups did not have any record.
Sir, in the present scenario, I think azithromycin for 5 days for that indication will be
But at that
sufficient.
time,
It was not available. I am aware of that study. In fact, I got it once from you.
Thank you, sir.
I had a talk in one of the CSI on the same topic.
Yes. Yes. Yes.
No, this is just to bring the name of Aarati Lalchandani. When she initially presented this data, no, very seriously, when she presented this data, we were all laughing at her.
She is very emotional about that.
And she was very serious about it. And at least there are some trials which have shown the validity of her this thing. The point is that she persisted with this for a long, long time, and at least now somebody has recognized it.
Time, I think.
So telling about the weekly azithromycin, which has no scientific basis. And if you read our latest article,
If I remember correct,
our article
it is not weekly. You give only daily for 1 week and stop lifelong.
No. Give it for 1 year. Give it for 1 year.
1 year.
No, Lalchandani was telling, give it for 1 year and stop.
And when you
That's it. She mentioned to be given for a period.
1 year,
then
1 year.
stop.
1 year, 1 year, 1 year.
And completely
Another
stop.
thing is that if you read that article, the major article recently, so emotional.
I think she is very emotional rather than scientific. It is emotional.
No, because when we are talking about this, it's a history of evolving therapies in rheumatic fever. So at that point of time, her point is also valid because we cannot just negate it. Earlier, what we used to do was it is something foolish.
Just one last
Thank you.
Just one last final comment. So the only thing is, I remember our professor of medicine, Dr. Matthew Thomas, sir. He used to give injection Panadol in his ward for all his rheumatic fever patients. Why we are doing a lot of ablations, tower, this, that? Why can't we, as a body, take this up and start giving injection Panadol? Is it a problem? There's so many hospitals.
A very important area. We'll discuss it over dinner. Please, we'll go to the next
Moving forward.
last session.
The last comment is
We are right now on time at 6:30. We would like to finish on time. Thank you.
To answer Sunita's question, I had 4 deaths when the patients were taking Panadol and Alleppy. I had a serious situation. That is why we had the problem. Agreed, but 4 coming together in this thing.
Natarajan sir, the stage is yours. You can
Moving
take
forward, management of infective endocarditis. I would like to invite the protagonists, Dr. K.U. Natarajan, and the cast of characters, Dr. R.J. Manjuran, Dr. Sibu Matthew, Dr. S. Praveen, and Dr. Vijay George.
At the outset, I thank Professor Shiva Prasad and Dr. Sajan. When I entered the hall, I thought almost it is like a palace. It was not like an auditorium. And the last session of the day, management of infective endocarditis. Infective endocarditis is not a very uncommon problem, particularly if you work in an institution with multiple specialities, with an active cardiac surgical program. It is not that very uncommon a disease. So the case in question is a 60-year-old male with history of fever, vegetation on the aortic valve, presumably on a transthoracic echocardiography, with moderate to severe aortic regurgitation and pulmonary edema. The very fact that a patient with moderate to severe AR develops a pulmonary edema means the AR is possibly acute and it is a consequence of the infective endocarditis. There is obviously sinus tachycardia as a consequence of fever as well as severe acute AR. There is PR prolongation, that is something to take note of. On IV antibiotics, details not mentioned. On 6th day, there is right leg pain with absent pulses, possibly an embolic event. Here, the diagnosis of infected endocarditis is rather straightforward. We all know that at least the diagnosis is certain here. We are not dealing with cori-infected endocarditis. It is a confirmed case of infected endocarditis, and this is not always the case. So with this background, I'll ask a few questions to Professor RJM. Infected endocarditis is one condition where high index of clinical suspicion is the key to diagnosis. When do you suspect infected endocarditis, especially in a patient with hitherto no known heart disease? There's no heart disease. When do you suspect?
Thank you, Natarajan. Infective endocarditis, as he has rightly mentioned, in a large hospital where a lot of medical specialties and active surgical program, infective endocarditis is a very common problem. And when to suspect? Of course, we have always studied that fever of more than 2 weeks in a patient with vulnerable heart lesion, that's a situation where all of us will suspect infective endocarditis. Another condition is that, situation is that a patient with fever following a dental procedure where you think that the bacteremia might have caused the infective endocarditis. But there are many other situations where I was going through the situations in our own institution where we had 2 cases where the patient actually went to the neurology department because the patient had a stroke. And then they did a CT and all, and the CT was reported to have a small aneurysm. And they sent the patient to us. The patient had, the neurologist detected a murmur, and the patient was sent to us, and the patient had a infective endocarditis vegetation on a mitral valve case. So the patients with infective endocarditis can even present with an embolic episode. That's a very important point. Secondly, sometimes you may get infective endocarditis in patients without a heart lesion. What are the situations in which you can have a infective endocarditis without heart lesion? Patients who are having a immunologically compromised disease like HIV, or sometimes patients who are taking immunosuppressants, they are candidates even without without a valve involvement can have infective endocarditis. So these are the few situations where I feel that you should be cautioned and look for infective endocarditis.
As you rightly mentioned, prolonged fever, patients presenting with embolic events, particularly in the context of an old heart disease. And it is once in a while, it's good to use the stethoscope to pick up murmurs. And it's good to know that the neurologist picked up a murmur. That's like good news actually. So please explain in brief, Sergeant, within quotation brief, the protocols for appropriate blood culture sampling. It's just a revision, not pertaining to this case in particular. In very brief, you can tell us, sir.
No, I think everybody knows how to collect the blood, but to recapitulate what has been told as a third-year medical student, actually we know the positive blood culture is the cornerstone of infective endocarditis treatment. That is because 1, it helps in the diagnosis. 2, it helps us to find out what is the most appropriate antibiotic. Very often the problem is that we may not know which antibiotic to use. So if the culture positivity gives a solid ground on which we can use the correct antibiotic. So the blood culture positivity is extremely important. The first step to positive blood culture is correct sample collection. And what are the precautions that we should do? 1, sample should be collected always from a peripheral vein, never from a central vein. Many of these patients who are sick may be having a central cannula, but that should not be used to collect the blood. Preferably blood should be collected. Never collect blood from a cannula which is in the peripheral vein. It should be a fresh puncture. Never collect the blood through the cannula which was there for 24 hours or 48 hours. And the standard recommendation is that you have to take minimum 3 sets of samples at half an hour interval, preferably from 3 different sites, and you should collect 10 ml of blood, and it should be cultured for both aerobic as well as anaerobic organism. So this is the basic thing about collection of blood.
what to look for in transthoracic echo. Last question to you, sir. What to look for in transthoracic echo in a patient with clinically suspected infected endocarditis. This patient has a vegetation, obviously. When the vegetation is not very obvious, what all you look for? When do you really suspect?
I must say that echocardiography has revolutionized the management of infective endocarditis. If you look at the different stages through which infective endocarditis has gone through, before the antibiotics, the infective endocarditis mortality was almost 98 to 100%. With the introduction of antibiotics, it fell to 45%. With the introduction of with the introduction of proper blood culture and correct antibiotic, it fell to around 25 to 30%. With the introduction of echocardiography for the detection of vegetations and early treatment of infective endocarditis, it fell to around 15 to 18%. So infective endocarditis, the echocardiography has played a very major role in bringing down the mortality in infective endocarditis. So of course, the basic and the most important thing is vegetation. And in the vegetation, you can look mainly for the size of the vegetation. Of course, vegetation helps you to diagnose, but the size of the vegetation. Because studies have shown that vegetations which are more than 10 millimeters in size or even 15 millimeters in size have got a higher incidence of embolic episodes. And there is a recommendation that these patients should undergo a surgical resection. In addition to the vegetation, there are a number of other things which can be picked up in the echocardiogram. They are one, the patient which has been quoted here developed acute aortic regurgitation. The valve regurgitation can become more prominent. There can be valve perforation. There can be the spread of the infection to surrounding tissues, which can give rise to even PA prolongation or bundle branch blocks, or the patient can develop abscess, and that can also erode into surrounding structures. It can give rise to pseudoaneurysm. Even infective endocarditis can give rise to ruptured sinus of Valsalva. And the one important reason for the sinus to rupture to the left atrium is infective endocarditis. So you can look at many things through the transesophageal echo when you are screening for screening in a patient with infective endocarditis.
Thank you, sir, for bringing out very important points. High index of clinical suspicion, blood cultures to isolate the organism concerned, and the presence of vegetation on transthoracic echocardiography, with the added findings that he mentioned. If they are present, they are all invaluable in making a diagnosis of infected endocarditis. In this patient has a large vegetation and a new onset AR, so the diagnosis is certain. So culture becomes very important to isolate the incriminating bacteria here. So to Dr. Sibbu, transthoracic echo many a time is not very conclusive of endocarditis. Fever of unknown origin, prolonged fever, a suspicious murmur. You do an echocardiography transthoracically, you don't pick up vegetation. Out of 5 operators, 2 people say it is there, 3 people say it's probably not there. Some people call it artifact, so on and so forth. So what is the role of imaging beyond transthoracic echo in a case of infected endocarditis? And in this case, with the vegetation on the aortic valve, will you get a TE done? Will TE be of any incremental value when you already picked up new onset AR as well as a large vegetation?
So, thank you, Dr. Natarajan, and thanks, Sajan and Shiprasad sir. So, our patient, this all definitely has got infective endocarditis by the clinical scenario. But in general, the question is, what is the role of imaging beyond transthoracic echo in a case of infective endocarditis, and particularly in this patient? Can you just show that one slide? So, because I put one slide just to show the importance.
Sure. So before I go to your slide, I'll also ask you a few extra questions. If a transesophageal echo is indeed done, what additional information beyond transthoracic that you are looking for in TEE, not just in this case, in general, or is there any incremental value of other investigations like CT angiogram, a PET CT, or an MRI in the context of infected endocarditis? When and why? So that is your slide here.
Okay, so this we all know this is the 2023 ESC guideline. Just want to highlight something. The one major criteria is the imaging. Imaging means to identify the vegetations as well as the complications which can diagnose with echocardiography, CT, PET scan or WBC SPECT or CT. And that is a major criteria. Look down, there is a minor criteria also. Even if it is asymptomatic, detection of these embolic phenomena forms a minor criteria. So, in the diagnosis, it is very important. In some cases, when it is a possible diagnosis of infective endocarditis, by detecting these embolic phenomena, you may convert into a definite diagnosis of infective endocarditis. So, using these modalities of investigations are one, it is useful in diagnosing. You can convert more possible to definite. Second, in detecting the complications. The complications in the heart itself, like abscess, aneurysms, or perforations, and the complications like disseminated infections, embolism, can be in the bone, spondylodiscitis, or the source of infection also sometimes can be different. So the imaging now is a multimodality imaging is needed. It is not just transthoracic echo. We start with transthoracic echo, it is immediately available. But beyond that, as Dr. Natarajan said, poor window, small vegetations, you may not pick it up. And if you use all these investigations, probably your diagnosis will be better. So if you look at non-valvular endocarditis, definitely all cases should be followed up with the TE. Transthoracic echo should be followed up with the TE. And a CT is the investigation of choice. So if further evaluation
that is unfair, Bell. 15 became 0 all of a sudden. Sajan.
In the case of prostate,
you are partial in the case of Dr. Zulfikar.
No, I literally pulled him off the stage.
In the case of prostatival endocarditis, definitely here also TE is indicated, but then a CT or a PET scan is useful here, and WBC SPECT. Probably I will discuss that later. But PET scan is not does not have good sensitivity in non-valvular endocarditis, where it is useful in prostatival endocarditis or implantable devices. PET scan or WBC SPECT are useful. TE and CT are useful in both. So in this particular case definitely has got complications beyond transthoracic echo. We should go for a transesophageal echo to identify any complications which may be there, like a abscess formation or aneurysm formation. And probably if TE is not good enough, we may have to go for a CT also.
One more indication for TE is actually to de-escalate treatment.
Yes.
After a week of, let's say, afebrile status in a small vegetation without valvular regurgitation, if you want to downscale treatment, you can discharge the patient. And now it is becoming increasingly popular in the West, what is called outpatient parenteral antibiotic therapy. For that reason also, TE can be done as a sense of security that you are in the right direction.
Yes, for treatment, during the treatment itself, the ESC guidelines say that the patient before discharge also, ideally you may go do a TE. Whenever you are converting from to oral therapy, you can do a TE. And one more indication, this particular patient may need surgery, and surgery may be done under TE guidance also. This patient may need surgery also, and TE also may be needed.
We'll come to that later.
But can I make a comment?
Sure.
But the infective endocarditis vegetations, most of them neither decrease in size nor will not disappear. That's what we have found. We have most of them. We have followed up about 100 patients for 6 months, and we found that very few, of course, few disappear, but almost 90% of them remain the same, and they become slightly sclerotic.
More echogenic, that's what you mean. More echogenic. So-called healed vegetation.
The literature says that around 25% disappear.
You were there at that time.
So you will, when the diagnosis is in doubt, in the form of no definite vegetation on transthoracic echo, whereas the index of suspicion is quite high, you can resort to these imaging modalities to pick up infected endocarditis. That's what you meant.
In the case of TE, even if the diagnosis is there, you have to do TE. Even if the diagnosis, even in a confirmed case of infective endocarditis, transthoracic echo is showing vegetation, still you have to do a TE. Otherwise, we are going to miss complications. Lot of complications will be missed. If you tell the complications, around 15% of the patients develop abscess, 15% of patients develop perforations of the valve, around 40% develop embolic episodes, and actually we miss a lot of cases, and actually the mortality is around 40%. We may be able to treat better. So it is a class 1 recommendation to do TE in all patients, even if the transthoracic echo is diagnosed.
Anyway, so we move on to clinical suspicion, the role of transthoracic echocardiography, and the incremental value of imaging beyond the transthoracic echo, as very elegantly pointed out by Dr. Sibu. So we move on to the third aspect of this, to Dr. Praveen.
So one more thing.
No, we will not allow you.
No.
I join Sajan in saying you are not allowed. He's actually not. He's allowing you. Okay, go ahead.
Can you say? I mean, you had two more questions there. So,
but I finished it.
No, pet.
That's what I asked. Last question.
No.
Rest of the answers we can.
No, pet.
During dinner time. Right?
One answer.
One answer he wants to make.
Please go ahead. We were just pulling your legs. Yeah. But the timer is exponentially it is coming down in logarithmic proportion.
We started.
Yes, please.
It's a clear cut.
Really, there is something wrong with this timer.
It's
No, sir,
clearly.
I am going by my watch time, sir.
I think
Maybe the discussions are so. Maybe the discussions are so interesting.
We have.
You don't know when time passes.
I think the message is clear. I will stop now. That is the CT as well as the T is better for non-valvular native valve endocarditis, whereas PET is better in prosthetic valve endocarditis. Where I want to make one statement: early prosthetic valve endocarditis, like 3 months, PET may not be good because there may be an inflammation and it may not be good. That is where the WBC SPECT is useful. But in TAVR, it's not a problem. In TAVR, even in the early phase, PET can be done.
And one more thing to remember is all these investigations are more relevant to look for extra cardiac involvement. Whole body PET CT, even neurological imaging, all that can be encompassed.
Now, as Sibu has rightly pointed out, patients with prosthetic valve who has been more than 3 months, and detection of inflammation is an important positive diagnostic point for infective endocarditis. I think that's very important.
Thank you. Thank you, Dr. Sibu. And to Dr. Praveen. This patient is obviously sick. If somebody doesn't call this patient sick, they are actually sick. So the diagnosis of infected endocarditis is quite obvious. Vegetation, acute AR, pending culture reports. What would be your choice of antibiotic?
Sir, as per the latest guidelines that we have in case of infective endocarditis, the ESC 2020 guidelines. So as per this guidelines, the empirical treatment should have ampicillin along with ceftriaxone, ampicillin the dose of 12 gram per day, along with ceftriaxone 4 gram per day, with gentamicin of 3 mg per kilogram per day. So
ampicillin or
ceftriaxone plus gentamicin. So that should be the empirical treatment in case of pending culture reports.
I think that if I tell you what the infective endocarditis, the KIN registry found, it is actually ceftriaxone and gentamicin, and they gave the best result. That was the combination most frequently used.
That's what we also use kind of routinely. So if the culture is positive, the choice of antibiotic is quite easy. What if cultures are negative? How do you decide on antibiotics in that situation?
So the most common cause for having, unlike in the Western world where the culture positivity will come to around 80%, but this in our setting it is maybe around 40 to 50% will only have culture positivity. So in this cases, the investigation should focus on other investigations rather than culture alone. You have to go for focused serological examinations, PCR, and if possible tissue diagnosis, because tissue diagnosis is the ultimate. So if that can be done, then it has been included. So another problem is that the usual cultures don't grow the fastidious organisms, fungi, or most often the patients would have received antibiotics from the outside. That is the most common cause that we have. You would have visited at least 3 centers before reaching a tertiary center. So that is most common. So you have to, one option is to repeat the cultures. After 48 hours of treatment, repeat the cultures. And the choice of antibiotics here would include the usual lines of gram-positive coverage and gram-negative coverage in the form of gentamicin. And if it is a prosthetic valve, you will have to add rifampicin. And in case of adding rifampicin, what you have to concentrate is that it has to be added only after 3 to 5 days of the initial intensive phase of bacteremia, where the other antibiotic should add. Otherwise, this rifampicin will have an antagonistic effect. So rifampicin has to be started only 3 to 5 days after the initial antibiotic coverage. Then the others are the atypical organisms like Coxiella burnetii or Trophorema whippley, etc. So the most common another agent that can be added is doxycycline, which is freely available, easy to administer. So that can be added along with this. Then of course fungus we have to culture, we have to look in for other PCR and other serological examinations to decide on the antibiotic course.
We'll skip this question. How do you assess the response to treatment? So with a large vessel embolic event, would you consider fungal endocarditis?
Yeah,
Femoral
of
artery
course.
is occluded here.
Yeah, when the large vessel, the slides need not be shown.
Pardon?
No, the large vessel embolic event, of course, fungal endocarditis has to be considered. And other causes for large vessel means large vegetations would be in patients with indwelling catheters or immunocompromised patients. In such cases, fungal endocarditis has been. And as per the ESC guidelines, the response to treatment, they have cut off points like fever for absent fever for more than 2 days. If the CRP value is less than 25% of the maximum measured value, or if it is less than 20 milligram per liter, or the third criteria they have said is leukocyte count of less than 15,000. These three criteria. And as sir said, TE would be beneficial, but then the vegetation size never comes down. That's what said. Maybe it becomes little hyperechoic. That's all.
So
And
last
most is the
question.
patient's response. The general well-being. The patient starts to take food. That is the most common thing that we.
How relevant is this outpatient parenteral antibiotic therapy in the Indian
I
context?
think in the Indian context, this will not be very much relevant because our patients, once they are discharged, they discontinue to take. They don't follow the
Oral
treatment.
antibiotics, oral
Oral antibiotics and
Do you want for that?
oral antibiotics. Of course, it is easy for the patient, but we have to ensure that the patient takes. In the Western world, they have a regular follow-ups. Telephonic follow-ups have to be done. Otherwise, we will have problems when they are given oral antibiotics. So I think preferably in our setup, it is to continue 6 weeks of parenteral treatment.
Like we measure orthostatic hypotension, Sergeant from the sitting posture has now assumed the standing posture. So to Dr. Vijo, the last
5 more minutes. Yeah.
Change in posture.
Yeah, and he's not having orthostatic hypotension. In fact, his BP has gone up.
He's getting ready to get down to the stage.
So how would you address, treat the acute vascular occlusion?
Okay, sir. I could.
And also I'll add a supplementary question. Do you just go by clinical examination? Do you do a Doppler and you are happy with it? You will want advanced modalities of investigation like CT angiography to confirm the diagnosis, particularly in a sick patient like this, difficulty in transport, etc.
So to address this question, I couldn't get any guidelines to answer this question. Actually, I searched in 23 guidelines, ESC or other guidelines, but we can answer only from our practical experience and from some case reports. So to answer this question, this patient has absent pulses, so you have to need a thorough clinical examination of the patient, and you have to see whether this patient has got irreversible tissue damage has occurred or not. So irreversible tissue damage can be found out by seeing that there is a sensory loss of the patient or profound tissue loss causing muscle paralysis. So such an irreversible damage to the tissue occurs, then there is no point in imaging at that point. Only thing we can do is you need amputation for that patient. So no indication for any imaging in that patient. Suppose there is no such problems like no sensory loss, no muscle paralysis, and patient is having pain, rest pain, then that means there is ischemia is there. There is no infarction. You can salvage the patient. So for that you have to need to, in a sick patient like this, you need to find out the level of occlusion. So this patient cannot be transferred to any site. So you can do the procedure in the ICC itself. You can practically we can do the pencil probe that is coming with the IABP machine. So we have used that machine for the one patient. So you can find out the level of occlusion with a simple pencil probe. So a normal flow indicates a triphasic flow, which indicates a normal flow, an attenuated systolic flow and an absent diastolic flow, which indicates a pre-occlusive event. So that is the level of occlusion, and distal to the level of occlusion, there is no flow, and also there is absent arterial flow and absent venous flow. If there is a venous, Dr. also has some significance in this context. Absent venous flow in this, there is a profound blood flow loss.
So in that way, we can find out the level of occlusion, and the level of occlusion, as we found out, then we need to address the problem. How to address the problem is, so actually this is not a thrombus. This is an embolic event, and usually it is a metastatic infection. So there is no point in giving a intra-arterial or catheter-based thrombolysis. The only thing we can do is remove the occlusion. So we need to call our cardiac surgeon to the cath lab usually. Usually you can do this procedure in a cath lab. We can make our own cath lab into a hybrid cath lab actually. And we can give the level of occlusion. We can confirm the level of occlusion by giving a retrograde injection. And we can give the same site to the surgeon, and we can give retrograde injection, and we can we give an injection and again level of occlusion, and embolectomy using a normal Fogarty's occlusion can be done for.
One important point that you made out was you should identify this problem before irreversible damage has happened. That again highlights the value of clinical medicine. Like we have to use the stethoscope regularly. We should also feel the pulse of these patients quite regularly in these patients, especially when somebody complains of pain. You shouldn't say that it will be all right, don't worry. You should always feel the pulse. That's very important because time is very important here. And you also brought a very pertinent point that thrombolysis should not be done in this situation. So you already mentioned the role of the vascular surgeon. So now that this patient has two major consequences of infective carditis, namely one is mechanical, acute severe AR. The other is a vascular occlusive event. Should we follow the traditional 6 weeks of antibiotics and reassess the need for surgery, or consider expeditive early surgery under the cover of antibiotics?
Sir, in this patient, we cannot wait much because already there are only 3 indications for surgery in infective endocarditis. One is presence of heart failure. That has already occurred to the patient, and that was a massive heart failure with the pulmonary edema. And second indication for surgery is embolic event. That is also occurred to the patient. So according to the 2023 guidelines, they are divided into 3. Actually, emergency surgery is needed within 24 hours in a patient with a cardiac failure with a cardiogenic shock. So this patient has recovered from cardiac failure. So emergency surgery may not be needed in this patient, but urgent surgery is needed. Urgent, they have commented it into 2 to 5 days time. So this patient definitely need an urgent surgery because already 2 complications has occurred. So we cannot wait for a third complication. So urgent surgery is the indication in this patient.
And the third reason, you said there are 3 reasons. The third reason is actually your treatment is ineffective.
Yes.
The pyrexia continues, the counts continue to be higher.
There may be one more problem, that is the PR prolongation. There may be an abscess developing.
We'll come to that.
No, reason for surgery.
I'm coming to that. I'm a so-called electrophysiologist. So I'll definitely, he can only pull Sulfikar down. He cannot pull me down. Okay. So if just a few seconds you have to answer this question, like is asked in some of these TV debates. It starts with few seconds and it goes on for full hour. In case surgery is contemplated, like in this case, 60-year-old man, obviously coronary age group, role of pre-surgical coronary angiography, non-invasive versus invasive coronary angiography. What is your? This patient also has a vegetation in the aortic valve.
In this patient, non-invasive CAG will be enough for the patient because our aim is to treat the infected endocarditis part. So just to assess the risk of surgery, we need a non-invasive CAG.
So finally, back to RJM sir. This question is to you. Any relevance?
Sir, now it is really 30 minutes. Honest.
Really. So, sir, this answer you should give in 30 seconds. We talk in milliseconds in electrophysiology. So 30 seconds is given for you. Any relevance for prolonged PR interval in such a case? Is it a marker of conduction system injury due to the infective process? What are the chances that this patient will need a permanent pacing? Are there predictors of persistent AV block? Should the surgeon, in case surgery is contemplated, like in this case, tunnel and epicardial lead?
It's a very complex question that you asked.
Answer in 30 seconds.
Well, I think if there is a newly acquired PR prolongation, I think you should respect it because that may indicate that the inflammatory process has spread to the conduction system, and that itself is an additional indication for surgical intervention. Second, you have to review the antibiotic that you are using, whether you should escalate the antibiotic so that the organism is properly looked after and the patients do not develop any more inflammation, because if the inflammatory process continues beyond pure prolongation, the patient can go in for a complete heart block. So I would feel that this is a predictor of a higher grade block, and we should aggressively manage it. I do not know whether the surgeon should contemplate a tunnel in an epicardial lead. I think you are the best person to answer.
Particularly if a tricuspid valve involvement is there, it's good to have an epicardial lead because you have to go through the tricuspid valve to put an endocardial lead. So if there is complete heart block, the surgeon is anyway operating, it's not a bad idea to do an epicardial lead. Anyway,
Can I make a small comment?
Sure, sir.
I think it is very important that you should not overdiagnose infective endocarditis vegetation. And one important condition you should always think about is papillary fibroelastoma, which may present with embolic episodes and with fever, and you should not overdiagnose infective endocarditis. Clue to the correct diagnosis is that the vegetations are usually upstream. In a valve, it is upstream, while papillary fibroelastomas are downstream. So, if you are finding a papillary fibroelastoma on the ventricular side close to the mitral valve, or on the aortic side on the close to the aortic valve, you should always try to rule out the possibility of papillary fibroelastoma. Another thing that you should think about is valvular excrescence, which are seen attached to the aortic valve, and some people may overdiagnose infective endocarditis, provided the patient may having some fever, and that also is a caution. So you should be careful not to overdiagnose infective endocarditis because these things are there.
Whether you overdiagnose or not, please don't underdiagnose this condition. You should have the highest index of clinical suspicion. Echocardiography plays a major role in looking for vegetations. There is an incremental role for additional imaging modalities like CT, like what Dr. Sibu said, and antibiotics have to be judiciously used. These patients have to be followed up, and one should not wait for surgery to happen when the three reasons that Dr. Vijay said, because in our center, we almost always operate these patients, especially if the vegetation is more than 1 centimeter, 7 days into the index event, and many patients go to stroke unit, etc., and a murmur is subsequently detected. So I thank the, cast of characters, Manjunath sir, Dr. Sibu, Dr. Praveen, Dr. Vijay for the nice discussion. Thank you, Dr. Shiv Prasad and Sarjan for that wonderful opportunity. Thank you very much.
On behalf of as a panelist, I must congratulate Natarajan conducting the program. Excellent, very good. Excellent.
Thank you.
Let's give him a big hand.
Yeah.
The hand is not enough.
We'll have the photograph also.
Thank you, everyone. I have a few announcements to make. Attention members of CSI, the general body meeting will commence shortly.